I want to welcome everyone for being here. We've got kind of a full day, so if you look at your agenda committee, what we have on there is several of the written only, and I want individuals and providers to understand that at our next Bob Bethell committee, we will be having in-person testimony. It's just been that the last two committees, with them being one day, there's a lot of stuff that we have to get through in order to proceed with all the responsibilities that we have for KanCare Oversight. So if you switch over and you look at the 9:05 a.m., which, I'm almost on time, we're going to open discussion on Certified Community Behavioral Health Centers, also known as CCBHC, the history and the funding, and I'll welcome Drew Adkins to the committee. Welcome. Good morning.
Good morning. Can you hear me okay? Thank you, Madam Chair, members of the committee. Drew Adkins, Commissioner of Behavioral Health at KDADS. I think I'm here for a couple of different items today, but I'm going to start off with our CCBHCs. I've got a slide deck. What I'd like to do is go through, lay a little bit of foundation, kind of probably a refresher for this committee on what a CCBHC is, also where the state of Kansas is at, both as a state with CCBHC and then also our providers, where they are at. We also have a kind of a sneak peek of what our CCBHC data warehouse will look like, and so I'll show a couple of slides on that and some of the information that we're excited to hopefully start collecting soon as hopefully the next Bob Bethell committee. And then I'll leave some time for of course, question and answer, and feel free to interrupt me as I go along, too. All right, and we can go to the first slide if that's okay.
I just thought it was a good idea to being we're, I think, about halfway through getting our CCBHCs all up and running, that, people get more information on what's occurring, and you'll probably see this topic pop up again later this year. So thank you, Drew.
That sounds wonderful. Thank you, Madam Chair. And I can probably just go ahead and jump in as we go along. CCBHC, when we say that, there we go. When we say CCBHC, that stands for Certified Community Behavioral Health Clinic. Quite simply put, this is a specially designated clinic that provides a comprehensive range of mental health and substance use services. This is something that our community mental health centers have been doing for quite some time. Where this transformation and change happens is a couple of different places. One is with the payment structure of how the CCBHCs are reimbursed. That is different from years past. And also what is required as far as the organization goes, the quality of services, mainly the care coordination of the individual, and of course, the CCBHC may not turn anyone away. They have to serve everyone that darkens their doorstep. We can go to the next slide.
I'm going to interrupt you here just a minute, committee. Just a refresher is that all your testimony is on your S drive.
And so on this slide, we talk a little bit about what the CCBHCs are providing. I went over this a little bit, but again, community-based mental health services and substance use services. A couple of slides from here, we'll see that there is, and on the second bullet point, the advancing of the integration of behavioral health also with physical health care. So this is something that will be new to our community mental health system, at least in some way, degree, shape, and form. They have some primary care screening and monitoring responsibilities that are a part of the core services. There are 9 there. We also have integrating and utilizing EBPs, or also known as evidence-based practices, on a more consistent basis. We have 4 EBPs that are required to be a CCBHC in the state of Kansas. And I'll go over those here in just a couple of moments. We also have promoting the improved access to high-quality care. There are requirements in the criteria that have time restraints and requirements for the provider for individuals to be seen within a 24-hour period, follow-up after emergency department visit, certain things of that nature that are going to be different than what are in current state statute and regulation and how we monitor community mental health centers and other providers right now. We can go to the next slide. So again, I won't spend too much time on this slide here, but as you can see, these items are blended. So you have mental health, you have the primary care, and the substance use. And we believe this is a good image for what CCBHC stands for and what we should be getting and receiving with the investment, both federal and state dollars, for our CCBHCs in the mental and behavioral health continuum.
Committee, I think, Andrew, we'll take questions as we go through the slides, if that's all
Sure,
right with you.
absolutely.
Committee, you have any questions so far at this point? Can you elaborate a little bit on the PPS and what that means?
Yes, yes. So
If you do it later in your slide, tell me, we can wait.
Actually, it's right here, so this is great timing,
All right.
Madam Chair. Thank you. PPS stands for Prospective Payment System. This is a cost-based model and system for our certified community behavioral health clinics. So right now, we're in the process of certifying our community mental health center system per Senate substitute for House Bill 2208. And this is the method of reimbursement that the model and the criteria require for anybody that meets the standards to be a CCBHC. And so whereas we have had a piecemeal of funding for our community mental health center system for quite some time, that was made up of state aid, federal funding from our block grant from the Substance Abuse and Mental Health Services Administration, other fee funds that were designated for our community mental health center system and mental health services in general, and then fee-for-service dollars from the Medicaid and KMAP system. This method of reimbursement is a Medicaid payment based upon what the center itself, what the clinic itself tells us it will take for them to run and implement the model as a CCBHC. So this, again, I'll go over the bullet points and dive into that a little bit deeper and pause for questions, but this represents the average cost per encounter for all clients receiving the CCBHC services from a particular clinic. And I think it's important to note this does not mean just Medicaid eligible individuals. This means anybody that comes in, whether they have Medicaid, whether they are private pay, whether they have commercial insurance, or they're uninsured or underinsured, the CCBHC must see that individual. One of the biggest changes for the center going from this is whereas you would have individuals that would come in and be treated based upon their need, but only hit a certain ceiling or limit to what the center could bill for based upon medical necessity and what's allowable. This will require the clinics to provide at least offer 9 core services, and I'll go over the 9 later in the slides. As appropriate, on top of specialty services, on top of care coordination, looking at other things as far as housing, employment, as such. And so it really is not just a enhancement. A lot of the times we try to make sure at the state, and I know our stakeholders as well as our CCBHCs make sure that this is a transformation to the mental and behavioral health system as we know it.
And also, Drew, the PPS rate is also what our FQs get, correct? And I don't know if theirs works the same as the CCBHCs, but this rate can only be billed once a day.
That is correct.
So if you had 2 CCBHCs in a catchment area, and they went to A in the morning and then decided to go to B in the afternoon, A gets payment, B does not get payment, right?
That is correct, Madam Chair. And I think it is important to note, too, that those, whether the individual is met, again, at the facility or in the community, that is the same. And it is, if you have an entity that you have two CCBHCs that are in a service area, whether that be the same county, the same 7 counties, what have you, if those overlap, they would only be paid once. And one of the specific things that Kansas did that's required when you have a CCBHC program is you have to pick between 2 PPS rate methodologies. One is the daily rate, which means that a center or clinic gets reimbursed daily for the individual that they have when that payment is triggered, again, being Medicaid eligible for services. And those services are designated by the state. That's something that we did in our work in the state plan. And then you also have a PPS2, which is a monthly reimbursement, and that would be more structured like your per member per month reimbursement.
Do you have any CCBHCs that have chosen the monthly?
That's a great question, Madam Chair, members of the committee. They do not choose the methodology. The state chooses the methodology. And it's my understanding this was before my time, so my predecessor behind me can correct me if I'm wrong, but and I'll be doing that a lot today probably, but we chose the PPS1 as we thought that would be the most fair reimbursement for the services that were going to be required out of the 2.
Okay, committee, are there further questions on this? Representative Reese.
Hi, Drew. Thank you for the presentation. Just for clarification, if there are 2 or more CCBHCs, whether it's a combination of a CCBHC and FQHC, in the same catchment area, and the client goes from one to the other, the first one is the one that gets reimbursed? Or receives the reimbursement?
In that scenario, and I'll double check with my Medicaid friends here to my left, but in that scenario, I believe the FQHC would still receive payment for the individual. It's the scenario where you have 2 CCBHCs.
Okay.
Because we do not do the costing. That's, again, I believe in KDHE's realm, but we do the costing for the CCBHC. So it would only be, say, if you had an FQHC that also became a CCBHC, that would then be where you would have the individual only receiving one daily, or the provider, sorry, receiving 1 daily rate per that.
And you said that was within the catchment area, or the area is larger than that?
So with CCBH, that's a great question, Madam Chair, members of the committee. Representative, we do not have defined catchment areas any longer with CCBHC. Catchment areas are really more of the term for the community mental health centers. But with CCBHC, they are required to see anybody that comes to them and darkens their doorstep. So if you are a provider in Kansas City, Kansas, and you get somebody that comes to you from Goodland, Kansas, you are still required to at least see them, triage them as they come in, intake them, provide an assessment. Now, what can happen and what we've seen happen is that obviously our CCBHCs a lot of the time, if not always, are trying to make sure that individual, being person-centered, gets back to where if they would like to go anywhere else, or if they'd like to stay there, they would become a permanent consumer or client of that CCBHC.
It's not unusual for a client to go from Wyandotte to Johnson or Johnson to Wyandotte.
Mm-hmm.
How is that scenario played out on the same day?
For
payment.
For a payment, that would still apply. That is something that would still apply to both of those providers. And so again, it would be a timing issue where that individual showed up in the morning or the afternoon or even an hour later. And we do, one of the bigger pieces, and I'll get to this in my later in my presentation, Madam Chair, members of the committee, is that we do rely heavily on care coordination, which means that we do expect our CCBHCs to be talking with each other, but also we expect our CCBHCs to be talking with other stakeholders, our federally qualified health centers, our substance use disorder providers, individual providers that the individual or the entity may be seeing, our hospitals, emergency department, but it is truly coordinated care.
Thank you. Thank you, Madam Chair.
Committee, further questions on? All right, continue, Drew.
Thank you, Madam Chair, members of the committee. I believe we can go to the next slide, please. So I mentioned this in my response to Representative Ruiz, but these are just a list, a bulleted point list. I won't go through all of these, but we did want to provide this because this truly is what we see with consumers and how tied they are to our community programs and other providers that they may have been involved with before they came to the CCBHC. And so these are the entities when we are going out and doing quality reviews of our certified community behavioral health clinics. These are the entities that we're looking for to make sure that there are no gaps and that there is true care coordination bridged with the individuals so that they don't fall and slip through the cracks, essentially too through the safety net. We know that that can be a real issue if an individual moves. You know, that is something that we're looking at when we're doing chart reviews and we're doing our quality reviews on site. And so, you know, a lot of the times we have some that pop up with our FQHCs, our rural health clinics, certainly our inpatient psychiatric facilities, including our state hospitals. We are always looking at ways to make sure that we have the continuum sealed up, if you will, so individuals do not fall through.
Okay, and Drew, you may not have the information on it, and if not, I know your previous gentleman is sitting behind you, is a lot of this was structured, if I recall correctly, I mean, some of it was already in place, but back when we shut down 2 state mental health hospitals, was to make sure that the individuals that would no longer be in a hospital would be able to get care out in the communities.
Correct.
Right, okay, thank you.
Sorry, we can go to the next slide, please. Okay, Madam Chair, members of the committee, I spoke to this a little bit earlier, but there are a lot of stringent requirements to meet CCBHC certification. Some of those are, or most of those are listed here underneath 6 categories that we look at as we're doing the reviews for certification. Those include staffing, making sure that they have the appropriate and necessary clinical, administrative, organizational, and operational staff. Availability and accessibility of services. This is something that obviously is in much desperate need, and we hear time and time again of individuals that are needing services, and so we expect for our CCBHCs to be able to deliver on that accessibility and individual care as individuals are coming through and darkening their doorsteps. Spoke to this and won't belabor the point, but care coordination is the linchpin of the CCBHC model. And so that is a major expectation. And one of the differences here is that care coordination is not reimbursable as a service for CCBHC, but it is expected in the model and the criteria. And so that is something that we at the state and obviously the federal government too looks at when we're looking at CCBHC. The scope of services, the wide range of services, and I do have a slide on this specifically later, but there are 9 required core services that include psychosocial rehabilitation, family therapy, veterans care, crisis services, peer services. And so we look at that when we're doing reviews, not only just for an entity that's already a CCBHC, but obviously if we have an entity or provider that's interested in being a CCBHC and what their readiness is. Quality reporting. We have a lot of reporting requirements for CCBHC, and with the, up until this point, the state of Kansas has done this first in the nation, to my knowledge, to do this as a state through state legislation, again, referencing Senate Substitute for House Bill 2208, and also through our Medicaid state plan. We did that in 7 months. Again, I think that's another first. We did that very quickly. And we have been able to be in charge and control, really, of that certification process and what we require. We recently, within the last month, received really good news that we were awarded the federal demonstration project status from the Centers for Medicaid and Medicare Services, also the Substance Abuse and Mental Health Services Administration. And I tease that out here to say that will change a lot of the things that we have to report out on That will change both at the state, and that will also change at the CCBHC and provider level. I believe that there are 22 metrics that are objective metrics that are measurable, that 13 of those, I believe, are clinic-led metrics that come from the clinics, and then we have 9 state-led metrics that we have to report out on to the federal government. The last one that I'll speak on here is the organizational authority and governance accreditation. Each of the CCBHCs have requirements for their board and their board makeup and what that looks like. They also have requirements for who may sit on that board and who may represent that board in the community and also through a governance process.
Drew, and when you talk about crisis services, that means actual services available, not a hotline, correct?
That's correct. That is, sorry, if I can elaborate, Madam Chair, members of the committee, and we might actually, if it's okay, go to the next slide, because that leads pretty well into my next slide. So crisis services means crisis stabilization services. This also means mobile response services that is in the community. That is going to be a change for a decent amount of our providers right now, but mobile response being in the community, providing that, trying to provide stabilization and also crisis stabilization at the facility. Yes.
Committee questions of Drew? Senator Petty.
Thank you, Madam Chair. So you mentioned that there are 22 metrics that have to report to the feds for CCBHCs.
Yeah, and let me double check that. I believe, is it 22? Is that right? I believe it's 22. I can verify. I know it's above 20. It was 21, and they changed it recently. But yes, we do have. So
right before that, you also said that, you said we're the only states that have put our criteria for CCBHCs in place?
We were the first state to accomplish and implement the Certified Community Behavioral Health Clinic model through state legislation and through changes to our Medicaid state plan. From 2014, 2015, SAMHSA and CMS opened up what's called the demonstration project opportunity, essentially. And I believe 8 to 10 states were originally selected for that. No one in that point in time. And then they've opened that up a couple more times over the years. I believe it was back in 2021, there were efforts made to require and mandate KDADs to start certifying clinics through the CCBHC model, which required work from the state to open that up within our Medicaid state plan. So when I mentioned that, we were the first state to do it essentially that way. And now, not to further confuse or dilute this, but we have now recently applied for and been awarded this demonstration opportunity. And I'll speak more to that and what that means here in a couple of slides. But essentially, originally, that was the only way to do it until Kansas came along and did what we did, kind of leading the pack there. And I apologize. I don't know if we're the only one now, but I know that we were the first.
Okay, that was I just wanted to follow up on that. So on those 22 metrics, was that put in place initially, or has that changed over time, increased, or?
That was, to my knowledge, that was put in the original criteria, but there have been metrics, when I mentioned that earlier, Madam Chair, members of the committee, that have been added to that list. They updated the federal criteria in March of 2023, and I believe they may have added 1 or 2. So I think it started out with 21 that were required, and now it's either a 22 or a 23, and I can verify that.
Thank you.
Mm-hmm.
Yeah, for some reason, Senator Petty, and I wasn't here during that time when the demonstration grants were opened up, is the state of Kansas did not apply for them, and they should have. Are there further questions? All right, thank you.
Thank you. So on this slide, I just want to go over, we provided a graphic this is usually how we communicate to our stakeholders and educate them, and so we thought we would provide that here. Again, the CCBHCs are required to provide 9 core services, either directly or formally through what's called a designated collaboration organization agreement. This is a formal agreement that would require the entity that would be providing services, let's say a CCBHC can't provide certain substance use services that are required in this array here of the 9, they could enter into what's called a DCO with another entity to provide that. That DCO does require that entity to be able to meet CCBHC criteria specifically for data reporting and for services. And so that's something just to note there. But the CCBHCs are required to provide those services one way or another, and to ensure if they do work with another entity and provider that they can meet the same quality standards. So those services are crisis services, again, screening, diagnosis, and risk assessment, looking at some of those physical health care and primary care services, psychiatric rehabilitation services, the outpatient primary care and screening, outpatient primary care screening and monitoring. We have targeted case management, peer family support and counselor services, community-based mental health care for veterans, person and centered family treatment planning, and then outpatient mental health and substance use services.
Representative Carpenter.
Thank you, Madam Chair. Drew, thank you for being here. So one of the things that we were promised when we went to CCBHCs were outcome-based. When are we going to be able to start seeing metrics that measure our outcomes and the kind of job that we're doing?
Madam Chair, members of the committee, Representative Carpenter, wonderful question. My hope is that we can start to see some of that data by the next time that we meet in this committee room in October or whenever that would be in the fall. As I mentioned before, and we have mentioned previously, the Association of Community Mental Health Centers, alongside with NetSmart, have been working with providers to build a data warehouse. And we've seen this be successful in the state of Missouri. One of the reasons why we wanted to go and kind of copy that model for the state of Kansas to show the effectiveness, the outcomes, the measures. So that is one way, and I do have some slides to show what that will look like when we bring that to this committee, kind of a teaser. One of the other requirements, again, of demonstration and why we're excited to be in it as a state is that is the requirement to provide those objective measures per the model to the federal government. And so those are, again, I don't have them all in front of me. I'm happy to provide them, but those are different screening, assessment metrics. Those are things like primary care metrics. Again, they're all objective measurables that we have. And so to answer your question, I believe that this fall we'll start to be able to see what does the continuum look like, how have we gotten better since 2022 in May when we introduced the first 6 clinics. That is our hope at the state as we continue to work on the data warehouse, but also start our demonstration January 1, 2025.
Very good. Thank you for that. That's probably the biggest issue, I think, with mental health is measuring, our success. And sometimes just throwing more money at it isn't the answer.
Madam Chair, members of the committee and representative, certainly understand that. And again, that is our hope and what we are working towards. Thank you for the question.
Committee, further questions? Drew, if I recall correctly, I think in different areas and within our healthcare, targeted case management could mean different things. So is the targeted case management, how is it different in our CCBHC/CMHCs?
That's a wonderful question. I don't know. I might look over my shoulder to see if our deputy secretary might have an idea. I know that there are some differences in the TCM as it ranges for the population too, and so.
If we don't have it today, that's okay. That's something you could get to us.
Yeah, absolutely, yes.
Okay,
yes. I
that's
just
fine.
don't know that I know that I can be didactic in that response right now.
No, I remember the first time that I realized how different some of the terminology that we use, depending upon the responsibilities of the organization, that means different things.
Absolutely.
And I think there's a big difference in this one here as well.
Yeah.
And I think also if you will get the 22 criteria to staff at some point, so we can just have it included in our information, because as we proceed forward with this, we'll continue other discussions.
Absolutely, yes, Madam Chair, happy to do that. Thank you for the
All right.
question.
Continue.
And we can go to the next slide, please. So I mentioned earlier to the committee that as a state, one of the things that we set forth was to have required evidence-based practices. And so wanted to list these out and revisit these. We have assertive community treatment. This is a change, again, with the increased community-based presence being out in the community rather than in the facility. This is something that works with a select population group, a lot of the time that has crossover co-occurring substance use disorder diagnosis. They will have a treatment team, essentially a case management team that's wrapped around them. This will include, or could include, an APRN, peer services, a nurse, case manager, those types of things. And so we're excited to have assertive community treatment added to this list and as a requirement. Most, if not all, centers do have this implemented in some way, shape, or form as well. We also have supported employment on the second line there as a requirement. And really what our state preference is, and this is also on our Medicaid state plan, is to have the individualized placement and supports model. This is something that comes from IPS Works, and so we're excited to get that implemented. And for both those top two evidence-based practices, we were fortunate to have funding from the ARPA and also from COVID-19 supplemental block grant opportunities to get dollars to providers to really bring their teams up, groom their team members, and also create new positions and teams to keep these programs and evidence-based practices sustainable. So we're excited about that. We also have medication-assisted treatment and cognitive behavioral therapy. Most of the centers do already have cognitive behavioral therapy, if not all of them have them at their providers and currently going and have clinicians utilizing this. Medication-assisted treatment was something new, and so we're excited to see that added to the list and implemented within our state plan as well. Excuse me.
Representative Reese.
Thank you, Madam Chair. Drew, can you go back to the supported employment part? Using the IPS model, does that include job coaching?
Yes, it does. It includes motivational interviewing, job coaching, and one more item. I can get a list. I'm sorry. Job placement? Job placement, yes. Yeah.
And it's all required?
It's all required, yes. And at most, again, going back to the mention of the ARPA dollars and some of the additional COVID dollars that we had, that was the requirements that we had put in grants and contracts that we administered to the CCBHCs or the CMHCs to build their teams up.
Great. Thank you.
Yep.
Thank you, Madam Chair.
Committee, further questions on this slide? Representative Carpenter.
So Drew, on the supported employment, so how does the transportation piece work for this?
That's a wonderful, Madam Chair, members of the committee, Representative, I may need to ask for a clarification on the question. Do you mean transportation for the member in general or part of the model?
Well, for the folks to get to work, you know, a lot of those folks don't have the transportation available. So are the CCBHCs providing that transportation? Who's providing transportation for them to get to a job?
Madam Chair, members of the committee, Representative, thank you for the clarification. Our CCBHCs do provide some transportation. I can't confirm that they provide this specifically as a part of IPS Works, but I'm happy to get that data and bring that back to you.
Well, I think you're going to hear a lot of this more from me coming out in the next year or so. Is I think it's very important, but one of the integral pieces to this, and we learned that last year when we had our interim committees on the new waiver and all that kind of stuff, how important transportation is. And these folks are not going to be able to handle the job if they don't have reliable transportation. It's just that simple. the employer is not going to deal with them when, well, my transportation didn't show up today, or I don't have transportation. So I think that that's just such an integral part of supported employment that you're going to hear me rail a lot more on transportation in the next year.
Absolutely. Madam Chair, members of the committee, Representative, I think that's a wonderful point. And I do know that even prior to the CCBHCs, and as we've had the advent and implementation of CCBHCs, that our community and mental health centers and other providers as well do have bus passes, vouchers, those types of things for transportation. But what we can do is take that back and see what that looks like specifically to supported employment. The state is always encouraging and working and looking at our quality of reviews, how the providers are working with the individual for all determinants of health, all things such as housing, employment, anything that would affect them, not only coming to their therapy appointment, so to speak, but also how do we continue to help them thrive and be successful. But I'm happy to grab that and bring it back.
Well, one of the things, Representative, and perhaps our MCO could elaborate on this later when we hear from them, is that I know that one of our MCOs has got a program with the Johnson County CCBHC with transportation for mental health services. And I believe that KanCare, hopefully, which would be Sedgwick County CCBHC, will get theirs up and running because they've been working with Johnson County to learn more about it. Because transportation, you're right, that's a big issue. Representative Reese.
Thank you, Madam Chair, and thank you, Representative, for talking about the transportation piece. One of the things that I have been pointing out to the MCOs that even though that might be a added benefit, when I've asked about how often that transportation is provided through the MCO, that's not every day. So if a person is working, even 4 consecutive days a week, that transportation is not being provided. So I don't want us to rely on the MCOs to provide that transportation because it's not adequate. It's not where it needs to be.
Thank you for that, Representative.
Well, I think one of the things, Representative Reese, that in order to make that happen, and we all agree how important the transportation is, it's called dollars. So someone's got to be able to pay for that. And I do think that we've got some representatives that have been looking at that and how can they find a pot of money. I'm not sure that it's something that we can just, demand of our MCOs, just to do that without reimbursement on it. So further questions on this slide? Continue.
Thank you, Madam Chair, members of the committee. We can go to the next slide, please. All right, so we've kind of laid the baseline again for our certified community behavioral health clinics. I'd like to take a look at where we're going and things that we are excited about. Again, I've kind of peppered and teased some of this throughout my comments and responses to questions. And so rollout of the CCBHC data warehouse, we are making what I think to be very, very good progress. And we continue at the state to make sure that the providers and the association are aware of how important this is, and they are certainly aware of how important it is. And so again, hopefully this fall we will have some robust data to be able to point to and bring back to you all for our next Bethell meeting. We continue to develop our policies and regulations for our certified community behavioral health clinics. And so again, going back to that piece that I mentioned earlier, that we were the first state to go in to CCBHC implementation this way. We also had to look at what do we need as a state for regulatory authority, what do we need in our internal, external, and Medicaid policies as well. And so that work has continued. And essentially we are also in Kansas in the, what I would consider the infancy stages of our CCBHC comparative to other states that have done this. And those states as well have had the demonstration runway to be able to bring these other providers in. And so what we are excited about in the third bullet point here is the demonstration awarded by Sampson in May of 2024. And so this demonstration project will start January 1 of 2025. We will start working with providers July 1 to get them rebased for their cost and the cost that they believe it will take them to, again, implement anything that would be new, which shouldn't be very much because KDOTS has made sure to stay pretty close to the certification requirements, and then they would start that January 1. We are excited to have that time to go back and look at our Medicaid state plan, to look at our policies, and to look at our draft regulations to see, is there anything that we did miss? Are there things that we're noticing that are out in the field, codes, requirements, coordination, et cetera, and things that we can do? And so we're excited. That will be a 4-year period, so that will go until 2029, I believe, if I'm doing my math right. And so again, that'll start January 1, 2025. We're also excited just to expand our capacity for technical assistance with centers. And so one of the great things that we've been able to do through the graciousness of the legislature and appropriations is to have staff to actually work with our providers. And I will tell you that I get asked, and other members of my staff get asked to come and talk to states all the time, which includes Iowa, Nebraska, Oklahoma, bordering states, and they say, how amazing is it to have your own team there? We have one person doing everything related to CCBHC, and it truly is a robust response. We're able to meet with the centers. When they have a quality review, we're able to have somebody come back from the state and say, hey, here are the things that we noticed. Here's something that we've noticed in a center that's the same scale or size as you. How can we make this work, truly? It's not just this regulatory oversight to say, hey, go and figure it out. It is truly, how can we help you? So we try to maintain that customer service attitude and mindset as best we can. And of course, working with the association as well on that. Thank you. So I have, Madam Chair, members of the committee, I have mentioned the demonstration program quite a bit. This program started through the PAMA, or the Protecting Access to Medicare Act, from HR 4302, passed in Congress in 2014. Section 223, that's usually where we sit when we are looking at this. This is what established the CCBHCs, this is the original. I believe it allowed for 10 states to be added, and then there's been some amendments to that legislation as it has gone through the process. In 2022, through the Bipartisan Safer Communities Act, there was the requirement from Congress to add up to 10 states every 2 years. And for Kansas, that was huge. And how this started was there was a CCBHC planning grant award to the tune of $1 million that Kansas was awarded to work for that year period from 2023 to 2024 when we submitted our application to invest in staff, invest in more technical assistance, being on the road with the providers, anything that we needed to make sure, one, that we were continuing our program, but two, bolstering our application efforts. And so it was money and time well spent, obviously, because we did receive the award. So again, just as a reminder, that will start not July 1. We have pushed our 6 months to give the state and the providers more time to rebase, to go through the requirements, and to hopefully have a little bit of a runway to make sure everything is primed and ready to go. Again, I went over the planning grant and what the transformation is. One of the pieces of the demonstration opportunity is that instead of having simultaneous programs where we have providers that are essentially funded through our state plan amendment, or our state plan and the program there, versus our demonstration, is we are taking all of our current CCBHCs and moving them into the demonstration as soon as they meet the readiness that's required. Why that's important for me to mention today is that the main carrot and candy of the CCBHC demonstration is that we qualify for an enhanced federal medical assistance percentage match, FMAP. So right now, it's my understanding that we receive a 60-40 split between federal and state share of our Medicaid services. This will actually allow us to tap into our CHIP rate, which I believe is 72% federal match, and 28% state share. So that's a 12% savings in cost per the service and per the drawdown. For how that works in caseload, I won't go into that. That's certainly above my pay grade. But we will certainly be, and essentially that translates over to major dollars that the state of Kansas will save for 4 years while we get the CCBHC program and providers where we want them and need them to be for the behavioral health continuum. We also will receive enhanced technical assistance from entities such as our federal partners at CMS and SAMHSA, which is generally helpful. We also will receive some hand-holding and guidance from the National Council for Mental Wellbeing, some of the other major players like National Association of State Mental Health Program Directors, and so we welcome that. Outside of the state having to find funds to pay for that, we will get that for free, and so we're very excited about that. Thank you, Madam Chair. And so this is just a quick glimpse, I believe, of probably everything that I just summed up. But again, in March 2023, we were awarded the one-year, $1 million SAMHSA planning, CCBHC planning grant from SAMHSA. This is also not on here, but the criteria was updated this time from SAMHSA and CMS, and the first time that it had been updated to my knowledge. And so March 2024, we had the planning grant end. We submitted the application for a demonstration application in March 2024 as well. We did get accepted into the demonstration program, we found out in June, and that would start in July, and then January 2025 is when we will be off to the races, so to speak. Thank you, Madam Chair. I won't spend too much time on this. I do want to leave some time for questions as you all have them. But again, this is kind of a shot for shot of how I started at the beginning of the slide deck. And so we obviously want to increase access for Kansas that are in need of mental behavioral health care. That includes hopefully having the CCBHC being the bedrock and cornerstone of individuals and where they feel comfortable in their communities where they live, work, and play. We continue to want to advance the integration of physical and behavioral health care. We certainly see that as the way that the federal government is aligning and moving states, and so we want to be on board with that too. We want to continue to promote the utilization of our evidence-based practices. We have seen really good data back from that, and we have seen incredible outcomes, and so which include lower emergency room and crisis visits, and so we're excited about that, and we'll continue to promote that. We at this point in time won't change any of those evidence-based practices. Obviously, that could change at any point in time, but our goal is to continue working on those. And of course, also we want to address any behavioral health issues within the state, as we know there are many, and we want to increase the access to services and improve the outcomes for Kansas and also for the providers. All right. I mentioned these earlier, but again, just to go over them quickly, Madam Chair, members of the committee, we have an increased FMAP. Again, cost savings to the state. We're very, very excited about that. We have personalized CCBHC technical assistance from the National Council and other organizations. And then we also have support from SAMHSA and CMS and our partners there. So we're happy to take that and excited about that. Just wanted to share some of the positive outcomes that we've seen. I think that first bullet point is very important, that CCBHCs serve an estimated 3 million people, and that continues to yearly have a growth on that number. And we also have been able to see through the National Council, I believe this is from 2024, and the impact report that they did, that we have had access gains, and that's increased by an average of 33%. Next slide, please. So I'll probably hit just a couple of notes on this. We wanted to, again, talk about the savings that we are expecting to see from the CCBHC model as it is implemented and fully cooked, if you will. And so we're hoping to see a few things. We're hoping to see emergency room visits and emergency department visits go down. We're hoping to see that any state psychiatric and crisis services, if they were to go up, that they are able to be deterred from being placed into our state psychiatric hospitals or another inpatient facility. Again, so we can keep individuals where they live, work, and play. We're also hoping to really curb the involvement with our justice involved population, primarily in youth and adults. We're really hoping to see that from our CCBHCs as they get more access and gain more from the centers and clinics. One of the things, just to keep this in the Midwest quite a bit, one of the CCBHCs in Missouri had a reported 66% decrease in requests for crisis intervention and crisis stabilization services. 85% of those referred for inpatient hospitalization were diverted to community care options. That is obviously our goal with every CCBHC that we have, and however we can do that. Okay, and I believe there was a requirement, request, to see the status of where all of our CCBHCs are at. I'm happy to go over this. However, it would be helpful, or I can answer questions over this too, whatever the chair or the committee prefers.
I think we'll just take questions.
Okay.
Are there any questions on this particular chart? Senator Fagg.
Thank you, Mr. Chairman, Madam Chairman. Drew, on page 16, you said 3 million people served by the CCBHC. There's 2.9 million in Kansas. So I'm just trying to understand how many other states is this in? How many does Kansas have?
Wonderful question, Madam Chair, members of the committee, Senator, and great distinction. I should have added that's a national statistic, obviously. I could guess, but I don't think that would be helpful. Let me take that back and get that for you. And if I can just regurgitate the question, it is how many individuals are served by CCBHCs in Kansas? Is that correct currently? I might actually have that. I'll look through my notes before we conclude. I might have that. I just don't want to guess.
Representing Berquist.
Thank you, Madam Chair. Those numbers, are they incident or are they individuals? The 3 million number, is that repeated for a great number of people, or is it how many individuals by name?
Yeah, Madam Chair, members of the committee, Representative, wonderful question. I believe the terminology would be unduplicated individuals.
Thank you, Madam Chair. Thank you, sir.
Senator Petty.
Thank you. On looking at the graph up here, or the circle graph up here, those 13 fully certified, that's as of 2024. So how many of those came on in 2024?
Madam Chair, members of the committee, Senator, let me verify that. I want to say half, but again, I don't want to guess. I believe it was half. We have bridged calendar years as we've started. A lot of the time, as was laid out in the state legislation and the mandate, we would start on July 1 or May 1. And so a lot of the times, and after the legislature included increased costs for caseload and directed the state to certify as ready. Some of that has gotten just a little bit blurred through the calendar years, but I believe it's half. I'll verify that for you.
And then on the provisional and the review, could you remind me which is closer to being actually certified?
Madam Chair, members of the committee, Senator, wonderful question. The currently in review does mean that they are being reviewed for full certification. So to answer your question more pointedly, it would be the 7 currently in review.
Okay, and usually then once once they get to the review process, how long does that take?
Madam Chair, members of the committee, Senator, it can vary. We try to keep that within a month, but it can vary based upon what information we're able to get and what the bandwidth is of our quality team.
So basically, these 7, that for the most part means that they're very close to being added to that fully certified. Would it be fair, or would it be safe to say that by January of 2025, that 13 could be more like 20?
Madam Chair, members of the committee, Senator, I think that is a very fair and accurate statement. And to elaborate on that, our goal for the timeline of the demonstration would be January 1. If you're ready and you've been fully certified and you meet that readiness and review that we determine per the state and for the federal government, we would then bring you into the demonstration. And I would say, again, just to reiterate, it would be fair to say that could be closer to that 20 number for the providers. If a provider does not meet full certification and is not ready to be a CCBHC by January 1 of 2025, that doesn't mean that they are cut loose. They will have a 9-month period until September of 2025 to again request essentially a full certification review by KDADS, in which we would then deem them either ready or not ready. If at that point in time they're not ready, they would have to wait a full year until September of 2026. And the way that it helps me, it may not help you, is that's basically a portal demonstration opening. That's when it will open and close as we have that time, and that's set out per the demonstration and our requirements there.
Just a kind of a follow-up, and maybe I should have asked this earlier when you mentioned initially about the demonstration awarded by SAMHSA. And how long is that for?
It's for 4 years.
So is that 4 years starting as of January 2025? You said 29, didn't you?
Madam Chair, members of the committee, Senator, yes, that would be 4 years starting January 1 of 2025.
So does that then mean that, let's say if we're to 20, but I'll take 20 as a number, for January 2025, that those CCBHCs would then, for their services, would then be getting that a higher reimbursement level of 72% Fed, 28% state?
Madam Chair, members of the committee, Senator, wonderful question, and I should have clarified this earlier. The enhanced federal medical assistance percentage match, if I got that correctly, that does not apply to the provider, that applies to the state. That is the cost savings for the state and the investment that we pour into the Medicaid caseload process. So they wouldn't see anything different for their, again, going back in the slides, for their prospective payment system rate. Essentially, that would be a benefit tangible just to the state.
But that means that we'll see that, we'll see, at the state level, we'll see a decrease in those costs, state costs, correct? Because
Madam
we're
Chair,
getting
members
higher
of the
federal-
committee, Senator, that is correct. That is the assumption, because we will be receiving a reduced requirement for state share match versus where we're at now. Right now, I believe we're at 40% to the 60% that the federal government gives us. This would take us down to 28%, and then 72% that the federal government would match.
Thank you.
And that would be for only 4 years.
Madam Chair, that is correct.
Right, so not a long term. Representative Concanon, then Senator Fagg. Oh, did Senator Fagg?
Thank you, Madam Chairman. Mr. Commissioner, I was FQHC. How does that fit into this picture? We're seeing how this works here. Where does FQHC fit into this?
Madam Chair, members of the committee, Senator, great question. The FQHCs will continue to be able to conduct normal business. This should not affect them. And I might need, again, a clarification on the question for my help.
I'm trying to understand what the difference is. How, do they do the same kind of work? Are they different areas? I just wondered how they mesh together.
Madam Chair, members of the committee, Senator, thank you for the clarity. They do different lines of work, essentially. Somebody might be telling you different now, but no, they, as I understand it, again, KDHE may be more privy to talk about this than I. We generally speaking, do not deal with the FQHCs like we do the CCBHCs. We oversee the CCBHC program, mental behavioral health, substance use focused. FQHCs, to my understanding, and rural health clinics focus on the primary care nature of individuals. And so it helps me to think of it as different tracks, not necessarily the same. There are some overlap, as I understand it, and potentially patients, but not necessarily the same program, if you will.
So, Senator, some like you said, the FQHCs are primarily responsible for the health side of things, including dental as well. And they also take everyone, regardless of the ability to pay. And some of them, depending upon their size, will do some things on the mental health side of it, but their PPS rate is all on the healthcare side.
Thank you.
Committee, any further questions? Continue.
Madam Chair, and I do, if it's all right, I do believe have a general figure, and I'll double check this to Senator Fagg's question. Per a fact sheet that the National Council for Mental Wellbeing, and this was the question of how many Kansas are served by CCBHCs, per a fact sheet that the National Council put out, I believe this month, there are over 86,500 individuals unduplicated that are served by CCBHCs in Kansas. Thank you. We can go to the next slide, please. Okay. And Madam Chair, members of the committee, I won't spend too much time on this. This is information that's essentially in graphics that are hot off the press, but I did want to show kind of a sneak peek of what data we are hoping to get out of the CCBHC data warehouse, again, in collaboration with the Association of Community Mental Health Centers, as well as NetSmart. As you'll see, this would be a little bit more of an infographic to show things like the client count, the average client age, the age distribution, client location, and different other statuses of other client location, but also employment status, ethnicity, marital status, gender, language, and race. And so our goal is hopefully to have this information for not only each individual provider in each area of the state, but also for statewide purposes as we report out.
So Drew, is this an accurate account that's up in the left-hand corner? No.
No, Madam Chair, no.
This is just what we're going to get. That's not our data.
A wonderful question, Madam Chair. This is for informational purposes to show the graphic of what we hope to have. This will be further curated in the fall to Kansas.
So this is the data you're talking about that we'll see here later this year.
Absolutely, Madam Chair, absolutely.
All right, continue.
And I believe the next slide is just a continuation of that slide. It shows the different visits that we have over time, also comparative and comparable to the services over time, shows what top 10 CPT codes there are, and then also the services by program. And I just wanted to provide that for informational purposes. Again, Madam Chair, members of the committee, we will curate this to Kansas CCBHCs as we are able, hopefully, this fall.
Drew, trying to glance through these rather quickly, and I'll be looking forward to that data later, will we track the drugs that are used? Because we've had, some of us in health and social services budget, I know, have had a concern with the psychotropic drugs being on an increase.
Madam Chair, members of the committee, I'm happy to take that back to see if it's a metric that we could look at. I unfortunately do not know off the top of my head. I will say I don't see why not, but I can double check that.
All right, Representative Carpenter.
Thank you, Madam Chair. So, Drew, on that slide there, could you provide, we deal in acronyms up here, and these are some new ones. Is there going to be a cheat sheet
Madam Chair, members of the committee representative, absolutely, not only for you, but for me too. Absolutely, there will be a code and a key that will not be too hard.
All right, very good. Thank you.
I believe. So are there further questions for Drew? Representative Ballard.
Thank you so much. I want to clarify something. You have to turn in the results or whatever your findings to the federal government, correct?
Correct.
Okay. Now, do you have an instrument or whatever in place for that, or is it ours, or do we follow their guidelines?
Madam Chair, members of the committee, representative, that's a great question. One of the instruments will be those last couple of slides that we saw. We will combine that in the way, and NetSmart and the association are working on that for the requirements of the measures and the metrics. So we will get that and we will combine that and report on that. I believe it's annually. As far as a vehicle goes, we don't have something at the state other than requiring if an entity or provider wants to be a CCBHC, they have to give the state this data or they will not qualify to be a CCBHC. So that's essentially where the mandate comes into play, or the vehicle and the requirement, I'm sorry.
And if I might follow up on that. So they have, if you want to be a CCBHC, you have to follow the guidelines, but do you spell out all the things that they must do? And is it, do they it's mandated, right?
Madam Chair, members of the committee representative, yes, that's mandated through the criteria that we enforce at the state level and review and sign off on during that review if they're ready or essentially not ready for that and meeting the criteria.
Okay, and I hear from people that are using it that they find it to be more effective, friendly, and they can get their results. Is that how we're following this, or is there other things that the federal government wants to know that's happening?
Madam Chair, members of the committee representative, that is certainly a portion of it. There will be, again, data and quality reporting is probably the biggest change that will happen with demonstration, that the centers right now are not required to outside of an ad hoc request. So yes, but it's wonderful to hear that we have individuals that say it is effective. I'm very glad to hear that. That's certainly an expectation. Again, access to care and availability of services is something we're looking at.
So roughly, I'm not sure the numbers, but this will increase substantially from a smaller number that's required to what will be required.
That is, as far as, Madam Chair, members of the committee representative, as far as the data and the quality reporting, yes, that is correct. This will increase the requirements for what we need to see at the state and then what the Centers for Medicaid and Medicare Services and SAMHSA, our federal partner, need to see
Okay.
for us to remain in the program.
All right. Thank you very much. Thank you, Madam Chair.
Senator Petty.
And I just wanted to clarify, you said that this will be by CCBHC. It will be by each individual one. So we'll have both a state profile and then by each, hopefully 20.
Madam Chair, members of the committee, Senator, my apologies, yes. Again, we hope to be able to look at this on a macro and a micro level. And again, obviously, we hope that we are able to fully certify any and all of the current CMHCs that we have going through the process. Certainly, we have them provisionally certified, so it makes sense that they would be headed on that path.
Senator Fagg.
Thank you, Madam Chairman. Mr. Commissioner, I was wondering, there's a thing called performance-based budgeting. Do you get around that at all and fill that form out?
Madam Chair, members of the committee, Senator, I have a tangible relationship with performance-based budgeting every year for the commission, and entirely, yes.
Okay. It'd be interesting to see that, is what I'm saying. That because you set some goals and measure your goals, that kind of thing.
Senator, absolutely, yes, yes.
Okay, and I think one other request that I had for you, Drew, was there was a concern from one of our MCOs that they felt like the PPS rate was impacting their costs. Can you elaborate on that for us?
Madam Chair, members of the committee, thank you for the question. I believe we at the state feel comfortable in the budgeted amount that we have for both state share and federal funds, also known as all funds that we have put into this based upon Medicaid estimated visits, again, in that daily rate and what the costs are that we have been given in our process for costing report. So for that aspect, I will say that we feel comfortable in that. We are certainly aware of issues. We've had MCOs that have brought that to us, and we're working with our partners at KDHE to look deeper into that.
Is there perhaps any delay that kind of occurs with this transition that we're doing that may be causing it to look like it's that way, that will self-correct itself, say, next year?
Madam Chair, members of the committee, thank you for the question. That is certainly possible. I will not swear to it. Again, I'm getting a little bit over my skis and above my pay grade, but that's as I understand. That may be Deputy Secretary Brown's pay grade. I am not sure, but I do believe that there is a reason to believe that could be a potential.
Okay. I think it would be good for us to perhaps get further information on that, not necessarily today, but as we go forward through all of our hearings.
Thank you, Madam Chair. And as always, the state is happy to meet with any MCOs with these concerns.
Right. I did get information that since Kansas did their legislation, that Indiana, Nebraska, and we believe West Virginia have all done their CCBHCs by statute. And Indiana and Nebraska both refer to theirs as Kansas-like, which I'm kind of proud of, that we were actually a leader in that. And an interesting fact is that Nebraska's governor actually appeared as a conferee before their social committee to promote the bill. So I think we've come a long ways in this, and I'm always telling people, don't say Kansas can't lead, because we can. We're pretty innovative. Committee, are there any further questions for Drew? Senator Fagg.
Thank you, Madam Chairman. Commissioner, we always heard about not having enough employees and filling jobs. Is that still an issue, or is that, you might address that for a second?
Madam Chair, members of the committee, Senator, I do believe it's still an issue. Workforce shortages have not gone away, and the plethora of providers that we work with, but certainly not for CCBHCs. What I will say is that we hear a little bit more frequently that things are, the pressure has been released a little bit more. They've been able to have a little bit more financial freedom, if you will, and to start matching their rates specifically within the metro and urban areas where we heard a lot of that. They're able to start matching their other providers that they were having individuals and employees leave them for. So I don't believe that it's gone away by any means, but I do believe it's gotten a little bit easier for our certified community behavioral health clinics. And I do believe the association has done some work on that. The Association of Community Mental Health Centers has done some work on that and some surveys. So I'm happy to try and get with them and get that to this committee if helpful.
Well, Senator, I can tell you that the House Appropriations Committee did form a subcommittee, and we had a discussion on that, and that was chaired by Representative Les Mason. And unfortunately, we lost Representative Mason. But he did make a request at the end of session to have a joint committee, so we're hoping that when the LCC meets next, that they will take and honor that, because the crisis, and we are in crisis, there's no other way to explain it, in healthcare, period, for workforce, absolute crisis. And it's getting worse and worse, especially in our senior care. And in 2 years, baby boomers start turning 80. Guess what? That's when you're going to see a lot more services. We're not going to be able to take care of them. We have beds in our nursing homes right now that are offline because they cannot staff them. We have hospitals that have beds offline because they cannot staff them. So it's not a matter of if or when. And we keep hoping that some of the regulatory agencies out there that set up the criteria for someone to become, a nurse or a social worker, et cetera. And I think the BSRB has really stepped forward on that plate, and Representative Reese is very familiar with this, is to give us ideas on how they can come in, and whether it's reducing rules and regs, or it's reducing some of the criteria, or even introducing, some new entry levels so that an individual can get some type of a degree within 2 years, at least start working while they continue to keep going up the ladder. It also is and I'm kind of getting off of Drew's deal here, but it's also, unfortunately, it wasn't done in legislation. It was done by proviso and appropriations as the Behavioral Center for Excellence that will help in this work for arena. And it won't just be in the behavioral health area, but how do we get our young people to see a path forward to, getting some of these degrees. Maybe you've got a child that neither one of their parents have college education, so they never thought about it. The parents can't afford it. They're worried about going in debt by going out and getting loans. So there is things moving forward, and that's what we need to start paying attention to. But we have got to get innovative on this. And again, the regulatory agencies have got to come forward, or the legislature is just going to have to step up to the plate and say, yes, this is what we're going to do, and override them if they don't. So I'm hoping we get that joint committee. Are there any further questions for Drew? You have any more comments for us?
Madam Chair, members of the committee, not at this time. Thank you for the time.
You've done an excellent job, and I have, of course, I still get to work with you through the end of the year, but I've always enjoyed working with you, and I am very impressed. In fact, Representative Ballard just made a comment how quickly you have stepped up to the plate, because you had some big shoes to fill with Andy. So
Thank you, Madam Chair. Thank you, members of the committee.
appreciate it. All right, committee. Now, Drew, again, on another topic that will be very exciting, is opening mental health codes.
Thank you, Madam Chair, members of the committee. Drew Adkins, Commissioner for Behavioral Health. I believe we have a few slides here today, and of course, I'm always happy to oblige to any questions that you may have. Opening of the mental health and behavioral health Medicaid billing codes is something that we have been, that has predated me in this position, but that has been worked on, I know, by stakeholders and others for quite a bit of time. We have worked pretty diligently in the past 8 to 10 months to do what we needed to do, our research, our due diligence at the state to see what was required. We have always, and we just came off of that former presentation, and some of the discussion there was the need for more services. And so in response to that, and the increasing needs for mental health and substance use disorder across the state, the Behavioral Health Services Commission at KDADS is taking a step July 1 to open these traditionally codes that have been traditionally only allowable to be billed by the community mental health centers to be billed by other providers. I think it's important to note that extending the ability for additional providers to reach consumers outside of this network will help ensure increased availability of services that are timelier for individuals, family, and children in an otherwise scarce provider environment that we have currently existed, and that was noted just a few moments ago. Some of these provider types I've mentioned before, that would be our FQHCs, our substance use disorder providers, or SUD providers, child welfare providers, and others. Go to the next slide, please. So I'll go through the codes themselves, and then I'll try to list off some of the provider types just as an example. And so we have, these are specialized community-based rehabilitation services. These are provided as part of the comprehensive specialized psychiatric programs that are available to all Medicaid individuals with significant functional impairments resulting from an identifiable mental health or substance use diagnosis. The medically necessary and necessity for these rehabilitative services must be determined by an LMHP, also known as a licensed mental health practitioner or a physician. Again, eligible individuals must meet medical necessity, and this is consistent, again, with an assessment that is determined by an LMHP or physician, but also consistent with state law, regulation, and policy. And so we have on this list here, CPST is usually what it's referred to, community psychiatric support and treatment. We have psychosocial rehabilitation, peer support, and we actually expanded peer support back in March of 2023. So that has been expanded. That is one that is a little bit exempt from this list, but we included just for edification. Also, crisis stabilization, mobile crisis intervention, and supportive housing. Sorry, we can go to the next slide, please. So our supporting services are the community-based services team meeting, so CBST is how that's commonly referred to, and then also psychiatric diagnostic evaluation. Additionally, all of these providers, for these codes to be able to be billed and be eligible as the provider to bill them, licensed, non-licensed, paraprofessional staff, they must complete any required training, supervisory program specific that is required by KDADS prior to or within a designated period prior to provision of services, of any service that they would want to. So we have training that is out there right now that is required to be able to build these services. This is what is in our provider manual through KMAP, Kansas Medical Assistance Program. And so that is something that we have had readily available for providers that are interested in this, making sure that everybody understands the requirements beforehand and what is necessary, both clinical, non-clinical training, et cetera, for what will be needed to build these codes. Some of the provider qualifications, I'll kind of go over these just again for some edification. Some of these provider qualifications for the specialized rehabilitation services are required to be delivered, again, under the direction of a physician. Entities that will want to provide these services that are not a physician or are not working with a physician would need to contract with a physician then. Other non-licensed and paraprofessional staff will be under the direction of a physician or an LMHP. The provider types who are allowed to perform and provide supervision of these services must be registered KMAP providers, and this would mean that they would be able to meet the requirements to be able to bill Medicaid within KMAP. They must meet all of their respective licensing requirements per their Kansas regulatory board, such as the Kansas Behavioral, excuse me, Kansas Behavioral Sciences or the State Board of Nursing, et cetera. A list of some of these provider types could be, again, LMLP, licensed master's level psychologist, nurse practitioner, psychiatric nurse practitioner, physician assistant, licensed master's level psychologist or an LMLP, licensed clinical psychotherapist and a psychologist, licensed clinical mental health professional, LCMHP, excuse me, family practitioner, general practitioner, psychiatrist, addiction medicine, and exempt licensed physician, in addition to organizations that are currently established to submit claims and are established KMAP providers are children with severe emotional disturbances, home-based family therapy, alcohol and drug rehabilitation. The only other thing, I'm sorry, can we go back just one there? The only other thing that I'll say about the CBST and the psychiatric diagnostic evaluation, they're not technically considered the rehabilitation services. These services are additionally important to the work of the specialized community rehab services and assisting the individual to gain access to services that would support their needs and potentially prevent the need for institutional care. CBST and psychiatric diagnostic evaluation or services related to the review of need for PRTF services for children. These reviews help to ensure all available community resources have been explored and exhausted prior to admission. Thank you. to talk a little bit, excuse me, to talk a little bit about fiscal impact and CCBHCs and where that lies. We continue to believe and know that CCBHCs will be the cornerstone and bedrock of services for mental and behavioral health consumer services. But with the July 1, 2024 opening of the Specialized Community-Based Rehabilitation Services Code, it will enhance all providers in the behavioral health continuum with funding they haven't had access to before for a behavioral health population that some have been serving for quite some time. Our estimated fiscal impact at this point is budget neutral. This is due mainly to medical necessity remaining the same and because the number of eligible members will not increase. Thank you.
We are a full-service providing committee.
I love it.
This
I
is
apologize.
something that Representative Ballard and I have done many, many years, is helping our conferees when we've had you talk for a very long time, so.
Thank you, Madam Chair and Representative. I don't have any cash on me, but I will find some for a tip, certainly. Thank you so much. Appreciate
not
it.
necessary.
Thank you, thank you. All right. Thank you.
It does get very, very dry in this building when you've got to talk for quite a long time, so.
Thank you. So just to go over a little bit more of the benefits here in this slide, we do believe that this will impact a decent amount of our most vulnerable individuals with significant functional impairments resulting from their mental health or substance use diagnosis, depending upon which door they are going through and which doorstep they are darkening outside of those CCBHCs. It will increase the ability for an individual to have a person-centered approach about where they would choose to receive their services. And it will also decrease the higher levels of care needed for individuals across the state. Obviously, at the state, when we're working with our providers, we work with a litany of different providers and a variety. Our goal at the state and at KDADS, and specifically in behavioral health, is that we get services out to those that need them across the state in one way, shape, or form. And we encourage and are working really hard to have more timely access to those services. I think those are most of my slides, Madam Chair. I'm happy to stand for questions at this point in time.
All right, committee questions, Representative Carpenter.
Thank you, Madam Chair. So Drew, in this measurements, how will this come? I mean, one of the big things about CCBHCs has been the fact that we can measure these metrics. So will that go into the things that we're doing with Telenet or whatever for the CCBHCs? The usage of these codes? How will we track them?
Madam Chair, members of the committee, Representative, thank you for the question. I'll start with the first question, as I believe I understand it. The CCBHCs, they will be relegated and working specifically with their prospective payment system rate. So they will no longer be billing, for the most part, any of these codes that I just went over, because they will have access to the PPS rate. The fee-for-service world here on this other track with the providers that I just mentioned and those specialized rehabilitative services codes, those will start to be billed by other entities as they have access to them, of course, if they can meet the standards and requirements and clinical licensure requirements. And so we will still, going back to my former presentation, we will still be basing the metrics that we are collecting and the objective measurable items on the CCBHC model and criteria. That will not necessarily cross over into these codes, if that makes sense.
It does make sense, and that's one of my concerns is now we have more providers out there and we have their billing and they're doing all that, but we're still not tracking the success. We're not tracking any metrics for now another group.
Madam Chair, members of the committee, Representative, I do believe that we are working pretty diligently to see what would be possible with KMAP, also with our managed care organizations on the front end to have a little bit more insight and oversight into how these codes are built, certainly. Of course, as we look, excuse me, into the crisis codes, we want to be very diligent in that for individuals that are in crisis. Especially for providers that may not have built a crisis code before. And so there has been some preliminary work into that. We will continue to monitor that. We will certainly also work with the MCOs on the back end to audit and look at the utilization to see where are these codes being billed, are they effective? And that's always something that the state has within our authority per regulation that we can go back and look and tweak the policies and the provider manual as needed to fit the need or the lack of, therefore.
Thank you.
Excuse me.
Representative Reese.
Thank you, Madam Chair. I have two questions, and I'm trying to remember what they were. One of them is, this is opening up the Medicaid code, so therefore, in order to bill Medicaid, the person has to have Medicaid. Is
That is correct. And when, Madam Chair, members of the committee, Representative, when I mention medical necessity, that's exactly that. They would have to meet that determination, yes.
And I know that they're currently billing millions of dollars of unreimbursed services, so I know that's going to be a big help for them. The second thing was on slide 7. It states vulnerable individuals with significant functional impairments, and you say, you know, of course, they have to have a medical necessity. Who determines the medical necessity? You went through a list of mental health professionals, and are those connected in some way?
Madam Chair, members of the committee, Representative, thank you for the question. Yes, that medical necessity has to be determined by a licensed mental health professional, as that definition is, or a physician.
Okay. Thank you. Thank you, Madam Chair.
Are there further questions? Senator Petty?
Thanks, Madam Chair. This is kind of a follow-up to Representative Carpenter's question. So as these these providers reach or have the capacity and to be able to bill for these for their mental health services, won't we be seeing like two sets of data? We'll be seeing a set of data about services that are being provided by our CCBHCs, and then we'll be seeing a set of data that's being provided by other providers that have met these criteria and have the recognized staff to provide those services. So shouldn't we be, I mean, I'm just talking from the legislative perspective, shouldn't we then be able to see in two different ways that we're and I'm saying this because one's getting reimbursement at a different rate than the other, but shouldn't we then be able to see whether in fact we are having more services provided, but they're just not being provided by our CCBHCs?
Madam Chair, members of the committee, Senator, if I do understand the question correctly, I think succinctly the answer is yes. Technically, theoretically, we should be able to get data, or rather, you all should be able to get data based upon, again, going back to what we have planned for our data warehouse for our CCBHCs, but also on the other side of the fence for these providers that haven't had access to these codes before, you should be able to at least get utilization, paid claims from the managed care organizations. I certainly won't put them out there, but that's something that we've requested from the state and have been able to get. As far as the quality of the fee-for-service data, I'm not exactly sure that I can speak to that and what that would look like outside of, again, utilization. I don't know that we have really sat down and done a crosswalk on the two different systems and what that would look like, other than knowing specifically for CCBHC, as I mentioned earlier, that individuals can only get one payment rate. And so that's a way that we're going to be able to track that through the data warehouse. But it's certainly something for discussion that we can take back at the state internally.
Thank you.
Committee, further questions? I actually have a few of them for you, Drew. I know you're shocked. So these codes have been with our CMHCs forever, and that's because they were always the backstop for our mental health system in Kansas, correct?
Madam Chair, I believe you're correct.
There were also mandates, or as some of us refer to it, strings that were attached to these codes because of it, requirements that they had to meet. Will the new individuals with the ability to build these codes have those same strings and mandates attached? And how do we know that for sure?
Madam Chair, members of the committee, that's a good question. We are working internally to safeguard individuals and make sure everybody does remain safe. As again, mentioned crisis services earlier. To your question about how you would know, I don't believe that will be in state legislation or statute. It may not even be in regulation. We do a lot of that work through our Medicaid policy, and that's how we would have the most control and oversight with providers, whether that's a facility or an individual, and what we've required there. And so we are looking at that with a fine-tooth comb and how to have some level of expectation there for those new providers.
Okay, you say you're looking at this. When does this go into effect?
July 1, 2024.
So we're a few days away from that.
Yes, Madam Chair,
You're
that's
still telling
correct.
me we're looking into. That doesn't make me happy. So will they be required to take anyone and everyone with, irregardless of the ability to pay?
Madam Chair, at this point in time, I don't believe we have that in Medicaid policy. I'd have to double check that.
Well, and I think that creates a problem, because it'd be real easy as me as a provider say, I'm only going to take, if you've got Medicaid or private pay, you're the only ones I'm taking. And then the others will go. I think someone's stepping up behind you. Bring it, Andy.
Yeah, so Andy Brown, I'm the Deputy Secretary for Programs at KDADS, and I just want to be clear, like, these are Medicaid codes, right? So everybody that bills them will be billing somebody who's Medicaid eligible, right? The CMHC codes, right, as we've been defining them in the past, have been utilized by the CMHCs to help with community rehabilitation and making sure that people are staying out of our state hospitals as much as possible, right, so that the levels of institution are lower, right? That role is still going to remain with the CMHCs. We're not changing the state statutes for CMHCs, right? We're not changing the safety net. The CCBHC system and the prospective payment under the Medicaid program enhances that role for the CMHCs, right? And anybody else that becomes a CCBHC will have the same requirements as the CCBHCs do now, right? What we're doing with opening the codes is we're allowing other provider types, like our child welfare providers, our IDD providers, right, to provide services that assist with keeping people out of mental health institutions when they have co-occurring disorders, when they're part of the foster care system, or if they have a co-occurring SUD, right, and they're with the SUD provider. So these codes can be used by the FQHCs. They could potentially be used by other parts of our system, right, to provide access to care where lack of access to care has been limited, right? It is a Medicaid program, right? And therefore, the only people that will be served with those codes are people that are eligible for Medicaid. These providers, a lot of them have already been providing these sorts of services, although maybe not to the same level that's expected. When it comes to what are they required to do, right, they have all the same service definition requirements that the CMHCs had. They have all of the same training requirements that the CMHCs had. They have all the same supervision requirements that the CMHC has had and all the same medical necessity requirements that the CMHC has had. So we're not changing any of the requirements within the Medicaid program. What we are doing is expanding the number of providers that are eligible to provide those services.
Will this include schools?
Yes.
But, and if what we understood from Drew, we have the CCBHC data warehouse, but we won't have any, that same specific data coming back to us from these other entities. Is that correct?
That's correct. So we'll still have all of our MCO managed care opportunities to monitor that. We'll still provide all the same licensing and supervision through BSRB. We'll still have all the same oversight that we had for the Medicaid program, right? And there's a lot that we're doing in this next round of KanCare to increase our oversight of those managed care opportunities and the provider networks.
But we will lose the ability to track or measure the benefits of these codes, correct? With the outside providers.
So I wouldn't say we're going to lose it. Like what we have is the opportunity to capture new information about these providers and the work that they're doing with these services, right? So right now, they're doing work that's not captured because it's not being billed, right? So we don't know what the impact of those unbilled services are because we're not able to track those at all right now. By opening up these codes, one of the things that we're doing is we're allowing those providers to then bill and document the fact that they're providing these services to patients, which increases the amount of information that the state has available for data mining.
But it's not the same data, same measurements.
It's not the same as the CCBHC performance metrics, right? But it is the same as what we've been tracking for the CMHCs.
Okay, now on the schools, because we know that the Medicaid reimbursement rates to schools is different than a lot of our others. So will they receive the same rate as private providers?
So right now, the way that the codes work is that everybody will get the rate that is set in the policy will be the same for everyone that meets the provider requirements. We are in the process of getting ready to go through sort of a review of our school-based services through the Medicaid program and a potential expansion of those under the federal guidance that we're receiving. So I'm not sure what the future of that will be. But right now, the way that we have those codes set up, if you're a provider who's registered as a type 11, you'll be able to bill for those rates that are based in the policy. You can still work out a different rate structure with the MCO, but the state level policy will set the rate for the base.
Was any of this discussed with the budget committees during session? Because Drew said you guys have been looking at this for 10 months.
So it's been part of the caseload discussions. And I think we talked about it in the special committee on mental health too.
What's the fiscal note on this?
So right now, we're estimating that this fiscal note will be a zero. It'll be a flat on account of the fact that,
Oh, Andrew.
well, here's the reason why.
Andy, come on.
Right, here's the reason why, is because we're not adding any new members to the system, right? We're not adding any new Medicaid eligibles. And we're also not changing any of the requirements for the services. So if a member was eligible for these services before, they'd be eligible now.
Right.
So it should already be included in the caseload.
I'm just not sure that I'm buying that. And I think you know this as well as I do, Andy, is that we already have a problem with our schools competing for our mental health workers. And I can see this exacerbating that. And then it undermines what the work is with the MHIT program. And I just really wish that the legislature would have had a whole lot more input and that this would have been brought forth within the governor's budget, and it just wasn't. I just looked at the vice chair of social services budget, and he's not as familiar with this as he believes that he should be.
Well, we'll have more opportunities to present information about it.
Representative Ballard.
All right, I want to make a comment about it. Often when we talk about these services, and let's just say an agency says, well, we'll need X amount of dollars to do this and this and this and this, and the legislature comes back and says, can you not do those services within your own budget? And that seems to come up, and someone says, well, why do you need additional money to do it? Can't you do it within that? Okay? So at this point, Madam Chair, I'm making that comment because now you say it should be zero because we can do it within the budget. And you says, I don't know if I'm buying that. You know, in other words, here's once it comes back that maybe they can do this within the budget. And we're saying, well, I'm not sure we can, where before, anytime you wanted additional funding, not you, but agencies, we said, do this within your own means. So.
Not all the time.
Not all the time, but most of the time. Okay, so what I'm saying is, can we not just trust that if they say they can do it within the budget this time, let's see if that's a possibility.
Well, we can see the problem that we have with that, Representative Ballard, is, and I'm all about more services being available to anyone that has a need for these services. So that part I'm not opposed to. I just want to make sure that we understand the fiscal side of it. And I understand when you say, Andy, that it's zero, but I also believe that we'll see an increase in those services because individuals will have more access to it. Mm-hmm. The numbers get put into the caseloads, so then as a budget side of things, we don't necessarily see what that cost actually is.
That's true.
Because it just gets buried into the caseloads. So will you be able to show the legislature what those costs are on an ongoing basis, separate within our caseloads?
Yeah, we should be able to separate out the billing from the providers and provide a utilization report that shows what the cost of those services has been outside of the CMHC system.
Okay. Are there further questions? I just wish I could say that I will be watching you next year, but I don't get to do that, so.
You can still watch.
Oh, I can watch.
You can.
I just don't get to call you to my office. That's what it is.
Yeah.
But I
The
do
problem is
believe.
she'll probably be bugging me.
Yeah, she has all of our cell
I think
numbers.
that
right?
Representative Carpenter will stay on top of it as well, and Representative Ballard, so.
Right, thank you.
Okay. Thank you. No further questions, committee? All right, thank you very much. I appreciate what you've provided us here today, Drew and Andy, both of you. And as we will continue further, what people need to start paying attention to in the KanCare is this last session, the appropriations chair looked at me during some of our hearings that we were having. He says, well, don't you guys in KanCare look at the budgets? Well, guess what? We haven't been doing that, but it is something that I would like to go ahead and start a direction to that, so you will hear us talking more about budgetary items as we move forward. Because I think the policy, we've pretty much, not pretty much, we do have a good handle on where we go with KanCare. Now we need to make sure that we're monitoring the fiscal side of it as well. So next I have KDHE updates, and I believe that we have Secretary Stanek to appear before us. Welcome to committee, Secretary.
Welcome, babe.
Good morning, everyone. Good to see you again. I'll keep my remarks brief. Our team is here to present on a number of important issues. I would just say that our teams have been very busy, of course, this year. We've had about 13 major initiatives on our list right now. And we do have a governance council that we created this year that is trying to keep things more organized and rolling in a strategic direction, and it's going well. We also are continuing our work to integrate Medicaid, the work of KDADS, and public health, so that we are doing more with alignment of initiatives, whether it be behavioral health or just physical health, and trying to, again, align not only the priorities of the state, but also the financial that goes along with that. There's also something that Christine will touch on called the access rule, 300 or 800 pages, that needs to be complied with effective in about 3 years in different parts. It's going to be a major lift, and so we are working hard on that as well. In addition, we have continued since about almost a year now, we are working on a restructure and a reorganization of the Medicaid program and different areas and where they report, and again, to realign. And it's going very well. We're continuing that work with Boston Consulting Group, and I'm very pleased with the results of that, and we think that that is really showing in some of the output that we have. And lastly, as you know, you will be hearing about the implementation of where we're at with KanCare 3.0. Lots of work going on there, and we are in the readiness and review phase of that. So I'll stop there and see if there are any questions for me, because I know the more important people have more to report. Thank you.
Committee, are there questions of the Secretary? Not at this time.
Thank
They
you.
may pop up. Thank you, Secretary. Next, I believe we have Christine Osterlund. Welcome to committee.
Good morning, Madam Chair and members of the committee. Got several items to update you on. Madam Chair, I have a lot of variety of topics. Would you prefer that after I cover each one, maybe we pause for questions, or would you prefer we wait until the end?
I think that would be good, so we can
Yeah.
take it by sections. Now, will we be following the testimony the Secretary handed us, or will you have a separate one?
I have, you should have it in your, it's the KanCare update from the
Okay.
Bethell Oversight.
All right.
All right. So the first topic today is just kind of an update on where we are. I think at the last Bethell committee meeting, I had mentioned that we were undergoing a rate study. If you want to move forward, that is the right presentation. Should be, go to the next slide, please. So we did finish our selection process. We put out a task order. Optimus was selected to conduct the rate study. They have begun that work for us. Just some reminders of what we're trying to accomplish. For any of the Medicare codes that have a Medicare benchmark, there'll be a comparison to Medicare. They're going to compare our rates to 4 other Medicaid programs that are similar to us, with Nebraska and Iowa probably being the closest in similarity, so we'll get to see how we compare. They're going to specifically highlight, when they look at benchmarks, things that are at above 100%. We do actually have some rates that are above 100% of Medicare, and that might be something we want to look at over time to do a realignment. We'll also highlight those that are at 85%, again, because as we know, as the legislature looks at rate increases, you know, they might want to maybe do some tiered approaches if we do have rates that are very close to benchmarks. And then we're going to highlight some of our, obviously, our very low rates, which are at 20% or below of benchmarks or in comparison to other states. Again, we do have some rates that are over benchmarks, and we have some rates that are below benchmarks, so we really want to be able to highlight those for you. The rate study will also include HCBS rates. So Optimus is working with our partners over at KDADS to make sure that that study is alignment is correct, but I think that will be helpful as well. Once we get through this phase 1, as we call this, which is, of course, a bulk of our rates, we are going to be then working with Optimus on how do we look at our DRG, our cost-based reimbursement, and how do we do a comparison to other similar Medicaid states, so at least we can see how our methodologies align, and again, would maybe open it up if there's any tweaking or changing of methodologies, but that'll be a little bit further out. We're anticipating the results of this rate study will start to be available in late summer. Our goal is definitely we will have this fall, because we know this will be critical before we head into next legislative session. Any questions on the rate study?
Representative Carpenter.
This doesn't have anything to do with that, but I just want to take the opportunity to thank you for all the work you guys did on this rate study. It gives me a headache just thinking about it, quite frankly. I had no idea how complicated rate studies were when we did the increases, and I know your staff worked diligently overnight sometimes, I think, to get those numbers, but thank you for that.
Yep. Representative, you're welcome. And yes, this will hopefully make our lives easier. And then we do have a plan that we will do this rate study periodically, every 2 or 3 years. What our goal would be is that we're going to take it in chunks next time, that we'll get on a cycle of just doing rate reviews for sets of codes instead of the whole kit and caboodle, so to speak, because obviously this is a pretty big endeavor, because in outpatient codes alone for hospitals, there's over 6,000 codes. So we'll make this more manageable as we move forward. All right, moving on, next slide. Medically needy, got a couple items. This one item will be an update from what we talked about at last Bethel. We've continued to do research on the medically needy program, so we do have an additional option that would be available. Just as a refresher, the medically needy program is our program for individuals who are above the Medicaid thresholds, so do not qualify for Medicaid, but they're allowed because they have significant medical expenses to spend down their income to meet the Medicaid thresholds. A little bit of overview, really medically needy, pregnant women, children under the age of 19, and our seniors are our primary populations. You can kind of see the numbers there. Obviously, in our elder population, that's where the bulk of our membership is. Currently, next slide, please, in the medically needy program, that income level that they have to spend down to has been frozen at $475 for decades now. As you can imagine, if you're trying to spend down your income to $475, that is really not a livable amount of money. So we started about a year ago now looking at what were some options to make this program still serve as a safety net but be more livable for our members. Option one we talked about last time is we can tie that medically needy income limit instead of to the old TANF or AFDC levels. We could tie it to Social Security. Right now, that's about $1,100 a month for a family of 2. So again, significantly better than where we are today. We did a preliminary estimate that we thought for state general funds that would be about $940,000 a year to make that adjustment, and that's the option that we covered last time. Next slide. We have, in subsequent working with our partners up at CMS, we have identified there is a second option. That option is essentially you do an income disregard to totally eliminate the spend down. And so basically any child, pregnant women, or aged and disabled applicant who falls into it would have an income disregard that would essentially make them eligible for Medicaid without any spend down amount. For those populations, it works very well. Of course, because Medicaid, we just can't have it be that simple. The challenge with option 2 comes in with our long-term care populations. There are some other federal rules at play, so it would create some disparity in our populations that are under our long-term care program, which again, would be a little bit of a challenge because some of them could have the income disregard, some of them could not have a complete income disregard. So a few challenges that we'd have to work through there, but that is an option that is available, is to operate the medically needy program with no spend down amount required whatsoever. So essentially, you're really kind of increasing your Medicaid eligibility thresholds for this population.
Christine, we have a question.
Yes.
Representative Carpenter.
So backing up to the number 1 option, you're talking 900,000, but on this chart before that, we're talking, I can't add this up very quickly, but it looks like 9,000 people.
Yes.
And so to serve those, it would only be 1.8 million, all funds, 940,000
Yes. And the reason for that is because if you look at the raw numbers, it kind of seems like they don't match, is some folks that get on the medically needy program, even at that higher spend down amount, they still would not get down quite that far. You know, they might get down to $1,400 a month, which then would not qualify them for medically needy that month. So the only months they're eligible is once they hit that threshold. So that's why it looks a little bit a difference if you look at raw numbers compared to what our fiscal is, because we're looking at when someone would hit that 1,100 threshold. We do it on 6-month windows. So if I don't hit that threshold until month 4, Medicaid is only going to cover a couple of those months versus if I hit it in month 1. So that's where some of the math, and we can give you a better breakdown to kind of show you what that's all based on, but that's some of the nuances behind the scenes.
Yeah, I'd appreciate that.
Okay.
Those numbers. Thank you.
Further question? Representative Reese.
Thank you, Madam Chair. Looking at that option 1, also, the example that you just gave about, you know, if they meet that income threshold, and that you said that it's over 6 months, so if they meet it at month 4, then they only get 2 months of coverage. Does that same scenario applies to option 2?
No, well, you could keep a 6-month window, but, you know, option 2, if you're doing an income disregard to essentially make them eligible, we would go to a month-to-month program is what we would recommend, because you're disregarding their income, so you want them to be eligible immediately. We'd have to look at what the administrative cost would be. I think we could do it all systematically, so there wouldn't be an administrative cost, but we would probably change that threshold instead of being 6 months to being just an every month, because like I said, we're disregarding their income.
So to the person that is in that program, which one is the less headache? Because it's
Probably
on the side of the
option,
person with it.
yeah, probably option 2.
Yeah.
I mean, it would be obviously a lot easier for the member to understand, because it's a, you know, income disregard versus trying to explain the spend down and what qualifies. And obviously we have to track that. There's tracking that has to be done. We'd have to look at the fiscal. We haven't fully got through a fiscal analysis of what option 2, obviously fiscal would be significantly higher than option 1, but we can bring that back. We'll do that as a follow-up to the committee. We're just not quite through. This was kind of late breaking option 2, and I wanted to at least be able to put it out there for you, and we'll do a follow-up and send you what that fiscal would be so you can compare the 2 options.
And I think it's also, again, significant that for the member, because option 1, I've helped people through that, and it is crazy.
Yeah.
It is the things you have to keep up with. I don't know how anybody does it. And also, whatever information you bring back to us, can you also tell us more about how it impacts the long-term care?
Yes, yeah.
Because that's
We
significant
can, yes,
also.
we can break that down.
Thank you, Madam Chair.
Representative Carpenter.
So, and we can get this later on. I don't want to, so then they would go under an MCO, and they would be a cohort and a per member per month fee?
Yes, yes.
Okay.
And as long as they, you know, continue to meet the medically needy overall thresholds, then they would just stay eligible just like another population. What the difference is, they are not guaranteed 12 months. And so we would go to a month-to-month, you know, look. So let's say, for instance, because medically needy, when you just do basic eligibility, there's some basic criteria that they have to meet. And let's say they stopped meeting one of those, then they could go off the program sooner than someone that's in a traditional eligibility program. But to be honest, the likelihood of that happening is probably pretty small due to their significant health issues. So you're right, it's really just another eligibility cohort that would be enrolled under the MCOs.
So it would be under the Medicaid assistance report as a
Yes,
cohort?
yes.
Okay, very good. Thank you.
Committee, further questions? All right, continue.
Okay, next slide. Okay, now we get into just some of our standard updates that we do. Obviously, what we have to report is really the first quarter of the year, so not a lot of, month over month or quarter over quarter comparisons right now. I will say that the data that we are presenting this time is now really the end of the unwinding. So I know for our MCOs, as we now move forward in time and we're past the unwinding, I'll have some data around unwinding in later slides. Things should stabilize again, that fluctuation in enrollment, people going off, and then they had that 90-day window if they didn't get their renewal in timely to submit it, and then we backdated them. So a lot of these things will now start to stabilize and go back to probably what we looked like pre-PHE. So I don't know if there's any specific questions on these next set of slides. There really isn't anything I particularly had to point out. I mean, their trends, were really about the same. Some fluctuations there was one like you see some profit fluctuations. Again, that's just due to all the unwinding and, when we had big cohorts of members being enrolled or disenrolled as we went through the unwinding. But there's really not anything in here that jumps out to us as being, completely out of line with historical performance. So unless there's, any specific questions, we could jump ahead to slide 20.
Committee, any questions? All right, proceed.
Oh, they're out of order. It would be the unwinding update. Keep going. There we go. All right, with no questions, this would be the unwinding update. It has capitation payments, the HCBS waiver eligibility, and just some enrollment and disenrollment numbers as of May 31st. So starting first with the capitation payments, we had a question asked regarding what the cost was for the capitation payments for carrying members that were no longer eligible during the PHE. There's no exact way to get to a, exact number here, mainly because we did not complete renewals. So I could tell you that when a member became eligible, let's say they became eligible in May of 2020, I could tell you for certain they were eligible until May of 2021. After that, I could not tell you if they would have remained eligible, they would have, not been eligible starting in 2021 or 2022. So how we kind of did this analysis is what we looked at is we took our historical enrollment by rate cell. So for instance, you would have children in some rate cells, long-term care is in rate cells, HCBS has rate cells, so it's kind of breaking down the population. And what we did is we looked at what historical enrollment levels were. And then as the PHE went on, we looked at as that cohort increased, what was that differential between kind of our historical enrollment and the PHE enrollment, saying the best proxy is that differential. So let's say you carried 1,000 members in a cohort, and during the PHE, we saw that number increase to 1,500. Well, you would say 500 is your best proxy for the impact of the PHE and potentially carrying folks that were not eligible. And then obviously it's simple math of what was the capitation payments that you made for that differential. The other thing we looked at then too also is then what was the impact of the enhanced capitation rates. So the next slide here, what you can see, go ahead, go back one please.
I believe Representative Carpenter has a question.
So wouldn't that have been pretty easy, though? Wouldn't it have been mostly medical?
Yes.
Okay.
Yeah, and most of it was in children, and that where you saw those differentials. Children was the biggest population where we saw the enrollment differential during the PHE be significantly higher than it was prior to the PHE.
Yeah, I just think most of it would be medical and
Yes. Yeah.
kids. Okay, thank you.
So what this chart shows you, if you look at the box in the middle, is if you just took those differentials, obviously looked at the capitation payments, it came out to 713,000 or 713 million. We did a range just because obviously we don't have exact numbers, so we're anticipating somewhere between 642 million up to 784 million was what we paid out in potential capitation payments to individuals that were not eligible. Down at the bottom below that chart, what we did is a calculation of how much enhanced FMAP related to capitation payments did we bring in during that same time, and that was just slightly over $1 billion. So the enhanced FMAP, which I know is what we were all hopeful, that 6.2% did indeed cover our cost of potentially carrying ineligible members during the PHE. Any questions on a look at the capitation payments?
Committee, any questions for Christine? Representative Ballard.
Yeah, as you were saying that, I was a little surprised that it was over $1 billion. Do the departments put out information to the public or to those recipients of these, when you said because that 1 million allowed you to cover those that were not really eligible, okay? Have we put anything out to really say that? Because a lot of times we are providing services and financial backing, but people don't really realize that we're doing that. Because when you said that, I thought, I didn't know that's how we used that money. Is there anything that goes out there for the consumer out there that says, I never get anything, or boy, they just do this or that, when this is not the case?
So what I would say, is there information out on our website? There is. But did it break down like that enhanced FMAP, and is it probably consumer friendly for someone that's really a lay person in Medicaid? To that, I would probably say no. I will say it is something that we're working on within the department of how do we make the information we're presenting more digestible, if you will, and in more simplified terms, because again, if you look at our MAR report, which Representative Carpenter mentioned, you have to understand, what those terms mean, because we love acronyms. You have to have a level of understanding. So to really answer your question in simplistic terms, no, we've not done a good job at that, but that is something that we're working on, of how do we make this. You still need the technical pieces, because obviously it's some of those reports have very, very valuable data for decision makers, but we definitely need data out there. And I think you've heard a lot of stakeholders mention that as well, that is much more usable, and we are working on that. So it is coming. I would say we're probably about 3 to 6 months out. Some of the first data will actually come out in July, but it will be very basic, but we'll be building on that over time.
Is there such a thing as maybe two or three sentences to explain FMAP?
Yes, that's a good idea.
Because if I'm speaking to someone, I'll say FMAP, they'll say, what's that? And then sometimes I have to look myself, what is that?
Yep.
I can tell you what it does,
Yep.
but along those lines. But I just thought that was very pivotal for me when you said that's how part of those funds were spent. Because you received services that in actuality you hadn't quite qualified for. So now people say, well, why are they coming off? Well, because of this reason. And it's not their fault, but they were the recipient and no longer they are the recipient. So therefore they see it as, I got booted off.
Yes, correct.
Okay, thank you, Mr. Chair.
Yep, a good, excellent point.
Representative Carpenter.
So, not to kick this dead horse too much, but, so on the, you're estimating we've spent 641 million versus, or to 784 million, all funds. But what would that be in SGF? It's 60-40 split?
Yeah, it'd be about 40% of that.
Okay. And then we received $1 billion, so we made roughly 600 million.
Yes.
I mean, arguably.
Yes.
600 to 700 million off the feds
Yes.
over the public health emergency.
Yep.
All right, thank you.
So for Kansas, the 6.2% was a very adequate amount. I know some other states would probably, have, based on their experience, a different perspective. But for us, it was adequate.
Well, and to piggyback on that, that was one of the reasons why we wanted to unwind it just as fast as we could, because then we were on our dime.
Yep.
Committee, further questions at this time? Proceed.
All
please.
right. Next one is around HCBS disenrollment. I know very early on in the unwinding, we talked in this committee about the impact on some of our HCBS members. Some of that related to, the renewals and the complication of that population and filling out the renewals and getting procedurally disenrolled. And then we also talked about some of the things that we saw around stimulus payments and families keeping those in bank accounts, thinking that was a really good approach and something good to do, and it resulted in them no longer being eligible. So we've looked at, this is cumulative, so this would have been from months, correct, here, April of 2023 through the end of May, but this is a total look at by waiver. We've broken it down into two categories. We are working on breaking the other closure reason down. We have to do some little bit of changing in our system because this isn't something we've typically broken down into detail, but we will get that. But essentially, you can see in the first column there, total across all waivers, there were 782 individuals in about a 13-month window that were in HCBS waivers that no longer were eligible. And this would be income, resources, program requirements, like for instance, autism, that goes up to age 9. It has so many years or up to age 9, and so you can age out of autism, so that would be no longer meeting program requirements. And some of the other ones, there's, a lot of these waivers, obviously, there's functional assessments that are done and other reasons that someone could not be eligible. And then on the other closure reason, the bucket we're going to try to break down more. We tried to give some general reasons. Obviously, unfortunately, death is a other closure reason. Relocation to another state. We do see members. Colorado is actually a more popular state for our waiver members to go to. They have some opportunities in waivers that we don't have in Kansas. You can have voluntary withdrawal, so we will break that number down as we're able to more, but that was about 1,280 over that 13-month window. And you can see it broken down by waiver there.
Christine, on the autism, so when they age out at 9, that puts them onto the IDD waiver, correct?
Yes, if there's.
If they're still,
Lots.
well, the odds are they're probably still in need.
Yes.
Does that put them on the waiting list then, or do they automatically go into the program?
I would have to defer to KDADS. If they age out of autism and they would qualify for IDD, they would go on the waiting list, would they not? Yeah.
So they have services, and then we take services away from them? At 10
And then.
or at 9?
Now, they would, since they are children, remember, they would qualify under EPSDT. So they have, EPSDT is any medically necessary service to treat or ameliorate a condition. So there would be quite a few of their waiver services that would qualify under EPSDT. Now, we all know some of the challenges in autism is providers in the state that actually provide those services. That challenge aside, if you looked at it from purely technical standpoints, they would still be eligible under EPSDT, not probably for everything, but probably 60 or 70% of the services they were receiving.
So do we track that at all?
That is actually something we are starting to. So, and that's a really good question. I'll elaborate if you don't mind, Madam Chairman. So, last session, if you remember, and I know Representative Carpenter remembers this, but we had an ask for about $51 million related to EPSDT. And that was due to some clarifications from our federal partners on how children receive services, waiver children, and what should be covered under the traditional Medicaid, kind of that EPSDT umbrella, versus what should be covered under the waiver. And the direction really is more of those services should be provided under what is known as EPSDT under traditional Medicaid and not in the waiver. So obviously we had to make some budget adjustments there. But what we're going through right now with our MCOs is one of the items I really wanted to understand is what is the overlap in services between EPSDT and the waiver, because the requirement for a waiver is you must receive one waiver service or you're no longer eligible for the waiver. So what my fear was, if we transition to EPSDT, do we put any children at risk of no longer receiving a waiver service, which now creates a whole nother problem? Like we've moved children around of who's paying, which bucket we're paying, and we're creating another problem. So we are actually in the process for the first time really doing a much, I would say, a pretty comprehensive look at what that means when you talk about EPSDT services versus waiver services, and what falls out in which bucket, do we put any children at risk? So I don't know that historically we've had good data, but we definitely will be having some good data now to kind of really look at that and understand kind of where that falls out, if you will.
Representing Ballard.
Oh, yep, there we go. Early periodic screening, diagnostic, and treatment. Yes. Yes. Yes, it is. It's a very long one. So there's a screening, we call it the Can Be Healthy screening, so if you've heard of that, but essentially a child is required that when they enroll that they go to the doctor and they have this screening done, and that screening is to assess what any medically necessary service that child may require. And so it is going to overlap. So like, again, a physician could say, you need some personal care assistant services in your home because of your condition. And so if that physician says they need personal care services, then that should be provided under the EPSDT program and not under the waiver.
The eligibility for it, is that the... Shut up, no. Can you hear this conversation we're taking? She asked me, am I new or what? No, it may be forgetful, but but I'm looking at this. Is it 0 to 3? I mean, is it early? Is there an age screen for this?
It's while they're a child in the program. So it's either 18 or 21. 21. 21, yeah, it's up to age 21.
Starting infant or?
Yeah, starting at 0.
Yeah, there's an American Academy of Pediatrics schedule that we use, so it's like healthy.
I need you to come up,
Yes.
if you can come up to the mic, please.
Yeah, so it's 0 to 21.
Yeah. Just because we got people listening online, so just tell us who you are and then explain, please. That's fine.
Yvonne Case, Director of Operations for Medicaid. So it does go up to 21, and it works rather like the Healthy Child visits for Well Child, okay? So there's a schedule out there. I'm not sure the exact term, but it's similar to the American Academy. So 3 months, 6 months, 12 months, like that. And then every so many years as they age, up to 21.
Is there a time limit they can be on it, or what?
It's just required. So if you're up for your, again, where those screenings fall, it's your time to go in at age 5 and have your screening. And then, children really should be seeing their pediatrician I think the Academy recommends like annually, so they should be having these assessments done on that schedule. So every time they go in, they should be being assessed for any medically necessary services.
Thank you, Madam Chair. I was
And
not
where
aware.
this, and why this gets so tricky and why we're trying to be so cautious is I think a lot of you in the committee are aware, if you're eligible under a waiver, your eligibility requirements are different than traditional Medicaid. And that's why we're really trying to be very thoughtful about how we do this, because if I'm eligible because I'm a waiver child, then my eligibility was determined differently than under the traditional Medicaid umbrella. And if I don't receive a minimum of one waiver service, and I'm no longer on the waiver, I may lose Medicaid eligibility altogether. So that's why we're being so cautious in how we implement this, and again, why we're really looking at this data probably closer than we ever have, because we really want to be sure that as a result of trying to comply with what our federal partners has asked us to do, that we're not going to inadvertently and unintentionally have a child no longer eligible for the waiver because all their services are being provided under the EPSDT umbrella, and now they're no longer eligible for Medicaid at all, which now they've gone from services to nothing, and that's what we want to avoid.
Thank you. That's helpful.
Representative Carpenter.
So, yeah, I know this thing is a can of worms. So on a waiver, their parents' income would not be included.
Yeah.
So on ESPD, or is the parental
Yes.
income?
Yes.
So totally different than,
Correct.
okay.
Yes.
That's what I was curious.
And that's why this is so critical that we do this very, very carefully, because you're right. If you no longer qualify for the waiver, you have to go through the traditional Medicaid path, which is obviously a very different calculation of income and what's used and what's not used. And we know we have children on the waiver that are only on Medicaid because they have a waiver slot. And we really don't want to, impact that. And so that's why we're really looking at this analysis of, what did the EPSDT screening say? And what did the waiver assessment say? And is there items that are going to fall in both buckets, if you will, so we're ensuring they're still going to get at least one waiver service.
And just to follow up, the MCOs will provide these services.
Yes, yes.
This will be through the,
Yeah.
and so there would be another, on the Medicaid assistance report, there would be another list of cohorts under the.
It won't be a different cohort because their eligibility will stay the same. What potentially could happen, again, we're just starting to look at the data, is that you could see the cost on the KDHE side of the ledger go up for like private duty nursing, personal care assistant, some of these waiver services, and then you'd see a reduction on the KDAD side because they're being paid for. Really, to be honest, what it comes down to is a payment mechanism. Is KDHE going to pay for it under the EPSDT because that's in our budget, or is KDAD's going to pay for it because it's a waiver service and it's under, their budget? So, it's one of those items that at the end of the day, the FMAP isn't different. At the end of the day, the services aren't different, but it's a federal requirement that they're clamping down on, that you're paying out of the right bucket. And that's why we're trying to be careful, because we don't want bureaucracy and administration to really negatively impact a child where they could potentially lose their Medicaid altogether.
Very good, thank you.
Are there further questions? All right, seeing none.
Okay. All right, moving on. Next is unwinding. So if everybody remembers, it was in spring of 2023, I think it was February, we were just getting ready to start this process of unwinding. We started, as we entered into the unwinding, we had just under 540,000 members. Obviously, at KDHE, we were anticipating that our enrollment was going to go back to more historical eligibility numbers, which would mean between 100,000 and 125,000 members would be impacted during unwinding and would no longer be eligible. As we ended May, we were at 425,641 members, which is a reduction of 114,000. So we're really about at the midpoint of kind of where we thought we would be at the end of unwinding. But I am pleased to announce that we are unwound. So we did finish, and I will give a shout out if you want to go to the next slide. One more. I will give a shout out to our team. We just came back from the National Association of Medicaid Directors meeting, and there are a significant number of states who are under corrective action or audits or other activities from our federal partners due to creating backlogs during unwinding. Many of them had to extend their unwinding periods. Some are going out to 2025. In an effort to remain compliant and all of that. So we were able to finish on time. We still have a few folks still in their 90-day window, but for all intents and purposes, we are done. And I think this slide says a lot about the team and the work that they did when I was here last time, which would have been February, and we were still in the middle of unwinding. We had over 21,000 applications in-house. We are now down to 12,525. We also at that time had about 1,300 applications over 45 days. We are now down to 908. And for reference, that 908 is lower than we were in February of 2020 going into the pandemic. So our team not only managed unprecedented volumes in reviews, where some months our review volume was triple our normal levels, but they were able to keep our applications timely. We had a couple months where we had some bumps in the road, but again, I really want to do a shout out, and it's very good to sit in a meeting and everybody's talking about all of their audits and corrective action plans, and you can kind of sit there and say, well, we're done. And we're in good shape. So hats off to our team. Next slide. And then this is just a look at our call center metrics. They continue to remain very, very good. You see in November, we had one slight bump up. That's typical. That's during the open enrollment for the federal marketplace. So we always have a high influx of calls and applications. But again, our call center has continued to perform well, which is very important for our members to be able to call and get a hold of someone to get their questions answered. So that is kind of an overview of unwinding. Any questions on unwinding?
Committee, are there further questions for her on this? Representative Reese.
Thank you, Madam Chair. Secretary, going back to page 24, and as of May 31st, it was 75,532 individuals discontinued. Do you know how many of those were children?
It's about 2/3.
2/3.
Yeah. Yeah, most of the single largest group impacted by unwinding was children.
And I can't do quick math in my head, but that's a lot of kids.
Yes.
Do you know how that's been fixed? I mean, are those kids somehow back on Medicaid or CHIP eligible or something, or are they just not receiving any?
So it's going to be probably a combination. So we did have children that moved from Medicaid to CHIP, and fortunately that safety net is still there. For the children who were no longer eligible, some of the families would have gone to the marketplace in an attempt to secure coverage. We do know that probably some are uninsured. And then you'll have the 90-day window, that again, if they didn't get their renewal in timely, that they could, submit that back to us. But it is going to be a mixed bag of some on CHIP, some able to secure something through the marketplace, and some uninsured. Unfortunately, the marketplace doesn't share, since we don't have a state facilitated marketplace. We use the federal marketplace. we have a lot of requirements of data we share with them, and we don't have as much data coming back. So unfortunately, we really don't know. We really lose sight of them. And so I really can't tell you, how many of them were, successful in the parents were successful in getting coverage through the marketplace.
Representative Kankana did some math. So we're looking at around 50,000 kids.
Mm-hmm.
All right. Thank you. Thank you, Madam Chair.
Well, and Representative, I know that, individuals that contacted me through the unwinding process, I actually found an agent in my area that did the marketplace. And many of those were able to get coverage, most of them were $5, $10, $15 a month.
Yeah.
Representative Berquist.
More of a compliment on your presentation. You communicate very well using terms like unwound and kit and caboodle. I appreciate it. Thank you.
My technical terms.
Committee, are there further questions on this?
Okay.
Okay, so we're back to what, 20?
Yes, so we will now go into eligibility improvements. Should be the next.
Slide
Go
28.
forward, yeah. Move forward. One more, and one more. This, I won't go in detail into these, but during the course of the unwinding, I had at each Bethel shared some changes that we had made that were permanent changes. Had a lot of great input from stakeholders throughout the unwinding process, and there's quite a few things that we were able to put in place that will really benefit our members going forward. Just a couple that I'll highlight. The renewal form, when we started the unwinding, and traditionally on our renewal forms, the signature page was like 7 or 8, depending on how many members you had, and a lot of people forgot to sign the form. And that's the actual only thing that's required for us to accept a renewal. You don't have to fill out anything else, we just need your signature. So we were able to actually move the signature page. It is now on page 3, so it's right after the cover letter. And so it's front and center, and hopefully that will increase the amount of signatures we get. So again, we can accept that renewal and start working on it. There were some flexibilities that we were given from the federal government around resources, and this is really about attestations. It's about processing the eligibility, because I know a lot of you get feedback. We're always asking for more information from our applicants and those up for renewal. So this allows us to make some things permanent, which will streamline the eligibility process, so we're not having to ask as much information from those folks that are applying. And then probably the other item I would point out is that we are putting in a new fax solution, which will speed up getting faxes into our systems. I know over the years there's been a lot of conversation around faxes. So that solution's going in August, and that should really streamline that process, and again, really shorten that time from when they fax it to when we would see it in our system, which should really help. And next slide, please. We're also putting in a new communication tool. It allows us to do a lot more targeting of text messages for members that opt in. So really right now we can do a few blast text and things, but it's at a much larger scale. This just allows us more and more to get down to the individual level, being able to communicate with them, share important deadlines. For instance, if they missed a signature, we could let them know immediately that signature was missing. Just a lot of things that we're going to be able to do that will be just much more one-on-one communication with the member versus what we have today.
Christine?
Yes.
Question I have, how long is our application for Medicaid and CHIP? How many pages?
The application is probably 9 or 10 pages, and a renewal form can be even longer, just because, again, depends how many members are in that household, but all of them are very long.
And that's mandated by the feds?
Yes, most everything that we ask for is mandated by the feds. We are, I think for the most part, we're restricted on asking anything that's not required. So for instance, if there was something we did want to know that wasn't required by the feds, that there's very little flexibility there, but they have a lot of mandates on things that we have to ask during that process.
Okay. I just hate that, because I can tell you when Insurance Commissioner Sandy Prager was a senator, we worked really, really hard when CHIP started to make a one-page to make
Yes.
things simple. Representative Ballard.
I'm going back to CHIP. I was under the impression, and I'm beginning to wonder if I was correct. I thought anyone who really applied for S-chip, for CHIP was eligible.
I would say quite a few people that apply for CHIP are eligible just because the income thresholds are higher. So it's a lot greater likelihood that you would be eligible, but there still is a upper, income limit for CHIP enrollment.
Okay, so is it still at, was it 250%?
Do you know off the top of your head, Yvonne? She's going to look it up. I can't remember off the top of my head what the upper.
The reason why I
but-
asked it, I was following up on Representative Ruiz's question when we were talking about how many children were actually eligible. So there are guidelines of why you would be denied.
Yeah,
It's just income?
No, income, you have residency requirements, citizenship requirements. So there's a lot of the similar requirements that you have in Medicaid would apply to CHIP. The really big difference is the CHIP income threshold is obviously significantly wider than Medicaid. So yes, a lot of children, I would say the number of folks denied for CHIP is significantly less than what we see in Medicaid, because a lot of kids are eligible. Now, the nuance with CHIP becomes the premium. The rules were just changed. So before, CHIP used to be a monthly premium. And you had to pay your monthly premium to start your coverage, and you had to pay it every month to keep your coverage. The federal government issued a new rule that starting in January, this gets interesting. You do not have to pay your monthly premium now to keep your CHIP eligibility for that first year. So let's say I got eligible in January and I'm in the $20 a month premium. I don't have to pay my premium. But next January, when I'm reapplying for that child, if I haven't paid all year, I now have to pay all 12 months at one time in order for my renewal to be approved. So there's a pro and a con there, because how it used to work is if you didn't pay your premium, you would lose eligibility, and then there was I think it was 60 days was the period that you were kind of out of the program, but then you could reapply right away. And now they do give them that 12 months of continuous eligibility like we do on the Medicaid side, but I'm thinking of a low-income family. Even if it's $20 a month, if my math is right, that's around $280 that I would have to come up with when I'm up for renewal all at one time in order to keep my child on CHIP. And again, kind of going back to how do you communicate that to a family so they fully understand the situation that they're in and don't get a surprise at the end of the 12 months when we say to them, well, I need $280 or I can't continue your child's CHIP coverage. So again, a new rule, it just started in January, and we're trying to, again, that will be one that we're really focused on, of how do we get that messaging out and how do we let those families know.
So in addition to that, even though you said we can't alter too much of what the Fed's asking, can we not, as a state, say to people, if you accept this option of not paying, because if I didn't have much money and somebody says, oh, you don't have to pay it, I'm not going to say, well, I'll pay it. But then all of a sudden, they're going to be smacked with 280. Can the state say to you, if you take this option, you're going to have to pay this at the end? It's almost like the credit card now. You can pay the minimum, but when I give you that amount, and that amount to you looks as small, may take you 5 years or 10 years to pay off.
Yep.
People change their mind when they get to see it, but can we do anything to help that?
That's a good suggestion. When we send the premium notices out, we might be able to modify those letters to include more information around, what that impact would be. I think that's an excellent suggestion that we can take back.
Okay. Thank you, Mr. Chair.
Yeah.
Madam Chair.
And being I'm not on that budget, what is our federal poverty level on CHIP? I know we have a statutory, but we've also been changing that by proviso every year.
did you?
For CHIP, so it starts, with the no premium, it starts at 134%, but if you count in the premiums, it goes all the way up to 255.
Okay, so it is 255% when you're in one of our premium categories, and it was 135, did you say, for no?
134.
134 for no premium. So up to 134%, you could qualify for CHIP and not have to pay a premium. If you get into a premium category, that goes up to 255% of federal poverty level.
And that's the level we've been doing by proviso, not statutory. What is the statutory amount?
It's tied to 2006, and I think now I think it equates to like 190% of, I'll find that for.
It's two something. But
Yeah, but it's significantly less than the 255, yeah.
Okay.
And
thank
next
you.
year, it will obviously go down again.
That's why someone has to pay attention to those provisos. every year.
Exactly.
Further questions? What?
Yes.
Yeah, well, there's a reason that it's
That's
not
right.
fixed, and we've introduced legislation and it goes nowhere, so.
Yes.
All right.
All right,
further
the
questions?
last thing that I have,
Oh, wait a minute, Representative
okay.
Carpenter has a question.
Okay, so you skipped over a slide back to 28. So you've got resource compatible test comparison. So that would be Equifax on the unwinding flexibilities made permanent.
yeah, so on resources, we have asset verification system. Yes, I got it right. Asset verification. I was going to say AVS, and I thought they're not going to know what AVS is. Asset verification system is the data source that we use for resource verification.
But you're still doing that, you're just
We
not
still doing it.
requiring-
Yeah,
Okay.
how it works before is if we would get information back, you'd still have to verify it with the consumer. And so under the PHE, some of the flexibilities we received was being able to use that information, and especially if it deemed them, eligible. So if you're going to do a data match and you're paying to do a data match, you can actually use that information to determine eligibility. So it kind of takes the consumer. If we get a match back, it takes the consumer from having then to also do something.
More importantly, the pursuit of potential resources no longer a condition of eligibility.
So there used to be requirements around applying for like veterans benefits, other benefits that you had to do before you could apply for Medicaid. Those have now been removed because some of the challenges were, like, I'll use the veterans, not to pick on Veterans Administration, but it could take a significant amount of time for benefits to be approved. And so your Medicaid application could get caught up in limbo, if you will, while you were waiting for another entity. So you can pursue your Medicaid eligibility, get determined eligible when those other things happen. Let's say you get approved for veterans, and I think that's called TRICARE if my memory is right. Then that just becomes a TPL issue where TRICARE becomes the payer of, the first payer, and we become the payer of last resort. But it doesn't hold up the individual from going, months in this limbo.
But you'll still pursue those.
Yes. Yes.
And at some point in time, if they become ineligible because of that income or
Yeah.
another payer that you'll, okay.
Committee, further questions? All right.
All right, the
proceed.
last thing I have this morning, we had a late request come in. You have a document, and it's around sedation dentistry. You should have the document. Yeah. And I think he's going to pull it up here.
Okay, well, we also have the status of the transition from 1115 to 1915.
Yes, and that is completely done. That was done as of December 31st, 2023.
And so we have information on that here.
No, we covered that in February's, Bethel.
Okay, and then child care center exceptions?
Public Health is going to step up and present on that. That is not my area.
Okay.
And Derek, I think, yep, there's Derek. I see him over there. Yep. So this is my last item for this morning. I know we've got the MCO contract after lunch. So this was a request for us to look at sedation dentistry. A couple asked, one was to look at our rates, what we cover. So on page 1, you'll see that table there. Those are the procedure codes.
Christie,
Yes.
just, committee, it's in a, if you go back to your S drive, it's a separate chart. And it's under Janet's name. Go ahead.
Okay. So to show you the procedure codes there, and then we were able to do a comparison of us to Missouri, Iowa, Nebraska, Oklahoma, Washington, and Colorado. So you see where our rates stack up compared to other Medicaid states. In many instances, we are lower if you look at the rates, but there are some codes that we cover that some of our other Medicaid programs do not cover. So kind of a mixed bag there when you look at how we stack up looking at other Medicaid states. And then we did a couple looks. Then the second question was around the number of providers. So we thought it would be helpful to break it down by county. So we have both a chart that shows that we have 225 unique or unduplicated dental providers that do sedation dentistry. So there's 225 individual or practices. And if you scroll down to the bottom of that page you're on, we did include a map so you could see how many by county that we have around the states of, these are dentists either in individual or group practices that do sedation dentistry. And then on the last page, we added into it, we do have some FQHCs and Indian Health Services clinics that also do dentistry. So we did the same view for you where we have a table that breaks how many down by which counties they're in, and then there's also at the bottom the map, which is the visual. What I'm not able to tell you at this point, but it's something that we're working on and this is just for not just sedation dentistry, but just providers as a whole, is starting to get a better handle on when we look at counties where there's no Medicaid provider for that particular service. Is that because there's providers, let's say is there a pediatrician in that county? Is there a dentist in that county that does sedation dentistry and they just choose not to participate in Medicaid? Or is it due to we have an overall desert when you just look at that provider type in that community? Like for instance, we know specialists, that happens in some counties. We just don't have a specialist. So that's a layer we're trying to work on creating with our provider network information, because I think that really will help all of us look at what problem are we solving. Do we have providers in that county that could service Medicaid and there's some reason they don't, whether that be rates or administrative burden? Those are things we can really work on and fix, versus do we truly have a desert for that provider type, because that gets more into the workforce discussion, and Medicaid definitely were a part of that. But we want to be able to provide that a kind of additional layer of looking at the provider data so we can provide more information on what problem do we need to solve here. Is it a workforce issue? Is it a Medicaid kind of specific issue? Might be a combination of both in some counties, but we're trying to look at where we can find those other data sources to try to enhance our own Medicaid data so we can really look at what's happening in some of these communities.
Representative Carpenter.
Thank you, Madam Chair. So you better get brushed up on this stuff. I've asked for an interim committee to study the sedation dentistry. I continue to get tons of questions, and folks aren't able to find those services in our state. And so I appreciate all this information here, but we need to try to solve that problem.
Yes.
All
I think sedation dentistry, I think we all know private duty nursing. We have real buckets where I think we have a lot of challenges.
Thank you.
Committee, further questions? All right,
All
seeing
right.
none. Thank you,
All right,
Christine.
and I will have Derek come up to talk about the child care.
Okay. Welcome to committee, Derek.
Thank you, Madam Chair. think, 11:59. Good morning, committee.
Good morning.
I'm Derek Flerlog. I'm the Bureau Director for Family Health at KDHE. Try to be as brief as I can. I know you all are up against lunch, and I don't like to hold people back from their food. So did want to talk a little bit this morning about the number of exceptions and a little bit about exceptions in childcare. First off, I believe the question was around child care centers. I did want to clarify centers as a specific license type, so the information that I have, and we can certainly provide more information at a later time, but I looked at child care facilities as a whole. So, exceptions are really a key part of our ability to respond to specific communities' needs, deal with really specialized scenarios. So that authority to grant exception to regulations really important for us. Since 2019, we've granted a total of 783 exceptions out of 917 requests. That includes a high of 233 in the calendar year of 2023. And then through the first 5 months of 24, we've remained on pace to meet or exceed that number. And then out of those 783 exceptions granted since 2019, 605 have been for our home providers, and that's about 77% of total exceptions granted. A couple of good examples that I'll just give you briefly. Exceptions aren't black and white, so when we receive a request, we look at some of the provider history, if there's been any compliance issues, health and safety risks or things like that when determining if we grant them. We've had, most of the requests that we receive for exceptions are centered around going above the licensed capacity. So a good example would be siblings. We'll often get a request for, there's a sibling in care, there's, whether it's an additional baby that's been born to the family or an additional sibling that wants to join the provider, we'll get a request from that home provider typically to exceed their license capacity. And something that we've talked to our team about is, again, these aren't black and white requests. So if we say no to an exception request in that situation, what is the health and safety or what is the risk to the child? So, for example, if we say no to a sibling request, are the siblings going to be separated? Are they going to pull the sibling out of care to the provider that they've known? We really like to keep those sibling units together. So those are kind of some of the nuances that we'll evaluate when we get those specific requests. Another one that we've received recently, we had a provider that closed and gave less than 30 days notice to their community in a pretty populated county here in Kansas. And we worked with some of the economic groups in that community, in that county. We worked with the local health department and the local child care coalition as well to grant exceptions to providers to be able to bring those children into care. What's interesting is one of the situations we saw there is there were centers and providers that were not at their licensed capacity, and the county actually had the number of licensed slots to take in those kiddos. They just lacked the staff. So oftentimes it can be a staffing issue. And again, other exceptions that we may grant around provider requirements, qualifications, and things like that. And again, we've talked a lot with our team about having that nuanced conversation and sometimes some back and forth with that request. We have worked on making the requests a little bit quicker. So prior to me starting last year in February of 23, the forms, it's a written request for an exception. The form said, please allow for 90 days to grant this request. And we were like, that's way too long. Let's remove that. So we've removed that. And there's an expectation within our program to work through exception requests as quickly as possible. Oftentimes, families are in need or providers are in need, children are in need. So that comes to mind. With that being said, I'm happy to answer any questions you all might have.
All right. Staff, were you able to find his testimony? Okay. Apparently, we didn't receive what you were reading from.
Sure, yeah, we can follow up with that.
Yeah,
Absolutely.
that always has to happen in advance of the committee. So.
Absolutely.
Committee, are there any questions at this time? All right. Seeing none, thank you very much. Appreciate it. So staff will get those, and then we'll get those dispersed to the committee. Okay, the next item we had on our agenda was a written-only presentation by the KanCare Ombudsman. So again, you will find that on your S drive as well. And just for those that are listening out there, this testimony is also listed on the legislative page for this committee. So, I don't know. Did you have something? Andy?
This is just a correction, but when we were talking about the IDD waiver and youth that are moving from autism, there is an exception for autism to IDD waiver. So those kids do transition onto the waiver.
So they're not put on the waiting list?
Right, correct. Yeah.
Good. That is great, absolutely great news. Thank you very
Yep.
much. Appreciate that. Is lunch here, Rita? Okay. Committee, we're going to break for 40 minutes, kind of a working lunch, and it'll be provided out here, and we can thank the Community Mental Health Center Association for our lunch today, and I don't think Kyle is in the room, so, but Sue is. And we'll recess then, 12:40.
Thank you, Scott. You read my mind. I was looking for someone to flip that switch back there. We're going to go ahead and get started so that we can try to stay on schedule. We've done pretty good this morning. So the first order of business is a presentation on the Office of the Medicaid Inspector General. We have Stephen Anderson to present. Welcome to committee.
Thank you, Madam Chair, members of the committee. My name is Steve Anderson. I'm the Medicaid IG. I want to thank you all for the opportunity to appear today and discuss the OMG. Just for the record, we finalized our annual report on February the 5th, 2024. A copy of that is available at our website. That same web page also includes a link to our online contact form where members of the community and public can use to make a report of fraud, waste, and abuse and other illegal acts. We continue to see an ever-increasing number of complaints of fraud, waste, and abuse and those same illegal acts concerning Kansas Medicaid programs. In calendar year 2023, we processed 1,447 complaints with 1,377 complaints involving allegations of beneficiary eligibility fraud. There were 38 of those complaints after reviewing them did not involve Medicaid and referred to another agency, where there's one complaint that involved a state agency and 2 involving state employees. There are also 14 allegations of beneficiaries committing non-eligibility fraud that we passed along. The remaining 53 complaints involved allegations involving providers and contractors. We're currently about 40 complaints ahead of our pace from last year, so every year it gets bigger and bigger because more people are making complaints. The presentation includes a chart that breaks down how we handled the complaints for calendar year 2022 and 2023. Just want to note that, the public health emergency created had an impact on the determination for many allegations. And for example, an allegation of being over income would not have resulted in the person being removed during the PHE. We did have several no fraud jurisdiction determinations based upon our preliminary review of the matter. Those referrals were sent to the clearinghouse for additional review and may result in determinations of no fraud or possible fraud. We just want to point out, too, that our investigative staff for looking at eligibility fraud investigations did not come on until August 2023, so they've been aboard less than a year. We already have over 100 cases open, and those guys are working their tails off trying to work their way through that. And that's why last year this past year I'd asked for additional staffing and additional resources, and I will again this coming year. The IG's office also published an audit report on April the 2nd of 2024 concerning the continuing care retirement centers. The audit covered the CCRC registration certificates process from July 1st, 2020 to August 31st, 2023. And we sought to answer the following questions. We looked, are there currently issues within the legislative language that are allowing these facilities to falsely claim they're part of the CCRC? We believe there was, and the current language and the federal guidelines did not provide for a clear definition of the CCRC. We also sought, are there currently proper procedures in place to monitor compliance within the CCRC statutes? We felt like there were proper procedures in place, however, they were not always being followed. And then third, are there measures that can be taken to stop potential fraud, waste, and abuse of the federal matching funds? And we thought that there were and addressed those in the report. We also want to point out that House Bill 2784 included recommendations made by OMIG for transferring responsibility for certifying CCRCs from the Kansas Department of Insurance to KDADS. We thought that in our report, we put that the state of Kansas would save an estimated $12 million each year by properly assessing facilities as not being CCRCs and using the proper quality care assessment amount of $4,098 versus the incorrect amount of $818 per bed. We also have 2 other ongoing audits. The first one involves prior authorization processes for Kansas Medicaid recipients. And we're looking to see are there delays in the peer-to-peer review process under each managed care organization. Also, are Medicaid beneficiaries being placed in observation status when they should be classified as an inpatient? And is there consistency in how each MCO determines the level of care? The second audit that we have ongoing is an audit of Medicaid reimbursements for schools. The scope of the audit includes all Medicaid enrolled students who have had services billed on their behalf from a local education agency or a school. And we're looking at that from January 1st, 2021 through January 31st, 2023. And we're looking to see, does KDHE have an effective system for processing and tracking school-based Medicaid fee-for-service claims reimbursements? Does KDHE have adequate policies and procedures that promote effectiveness and efficiency on the school-based Medicaid programs? And then third, does KDHE and does the Kansas Department of Education have sufficient oversight processes in place to ensure individual education plans, IEPs, are complete and support medical necessity when services are billed to Medicaid? In cooperation with KDHE, the OIG developed a fraud, waste, and abuse awareness training program that's provided to KDHE as well as contract employees and the public. For calendar year 2023, we conducted 19 training sessions and provided training to 831 people. Then lastly, as an example of a recently opened eligibility investigation, we had an individual who was a Medicaid beneficiary, had been using their food assistance program, food assistance benefits exclusively in Colorado since December of 2022. A review was completed by food assistance in March of 2023, and they did not report their out-of-state residency. Multiple attempts to contact the individual at the phone numbers and other information they provided was unsuccessful. We found that the individual had a Colorado driver's license since April of 2023. The current monthly capitation for this individual is over $2,000 a month. And we're continuing to look at it. If investigation is continuing and if appropriate, we will refer it for prosecution. Thank you for your time this morning, or this afternoon, actually. And I'm so used to doing this in the mornings. And as always, we welcome any suggestions from the committee on audits, reviews, and investigative topics. Thank you. I'll stay
Thank
for
you.
questions.
One question I have on the audits, those are your audits, right?
Yes, ma'am.
Okay. Committee, are there questions for the Inspector General? Well, you did such a good job, you just baffled them all.
Well, thank you.
Thank you very much, appreciate it. All right, committee, our next presentation is in regards to KanCare Managed Care Organizations Contract and Protest Process. First up, I have Christine Osterland from KDHE. Welcome.
Good afternoon, everyone. Christine Osterland, Deputy Secretary for Agency Integration and State Medicaid Director. This afternoon, I'm going to highlight some kind of key elements and changes in the actual contract itself and kind of what we're working on towards implementation with KanCare. And then Secretary Profit is here for any questions regarding the protest at hand. So in our slide deck, right before questions, there was a slide, and that's what I am going to touch on this afternoon. So everybody find it? And then it is up on the screen. Thank you. Okay, so it is numberless. I think it's right before the question, so it should be towards the very end. Yeah, the second should be. Okay.
Yes, it's under 10. Well, the second one
All right.
Thank you very much.
No, not a problem. So just a little bit of a refresher, since obviously it's been a while since, we talked anything related to the RFP. So as we develop the RFP, starting in the spring of 2023, if I can get my years right, we engaged in some public meetings and solicited a lot of public comment from stakeholders, providers, members, et cetera, on areas of emphasis or changes that people would recommend would be made to the KanCare program. We really ended up with kind of 6 buckets, if you will, of this doesn't represent obviously all the changes in the RFP, but these are where you're going to see some key changes in the RFP compared to KanCare 2.0. One is around care coordination. I think in KanCare 2.0, kind of a newer concept, but there's a lot more requirements around what is care coordination, working to define that, making sure there's consistency among the MCOs and how they provide and plan for care coordination. And then the other big facet of this, and you'll hear this theme throughout all of these areas, and I'm not going to, get in depth into all of them, is a big part of this initiative is how are we going to monitor it? It's one thing to put a requirement in an RFP or a contract, and it's another thing to develop a strategy to monitor and ensure compliance and the goals of KanCare are being met. And so that's a big initiative that KDHE is undertaking right now of how do we monitor. Some of it will include on-site monitoring, where we'll look at actually patient files and information at the MCO. Some of it will be data reporting, but there'll be a whole concentrated effort around how do we monitor and ensure our goals for this version of KanCare are upheld and we're achieving the health outcomes that we want. So care coordination is a big area of emphasis, a lot more definition of what it is, what the requirements are. And we are in the process right now of working with the MCOs and KDADs and KDHE on what does this entire program look like. Next, under access to services and workforce, actually this morning, touched on non-medical emergency transportation. That is an area of emphasis in this RFP. We do have more requirements in the RFP around non-emergency medical transportation, around timelines and different facets of that program, trying to address some of the challenges that we know our members have faced. We have some more provisions in there around the provider directory and the accuracy of that information. So when they're trying to seek care, if a provider is listed, they're actively seeing Medicaid members, and we're trying to do a lot creatively around the direct care workforce for behavioral and LTSS. There are some new requirements for the MCOs, but there's also looking at creative things we can do because, as we know, workforce remains a challenge, and how can our MCOs partner with us to try to address some of those challenges, and how do we entice more folks to go into that workforce area, and how can we partner with community organizations, things such as going into the schools to get school-aged children interested in medical fields and providing some of these services when they graduate, and what can we do to support them. The provider experience is a big area of emphasis. We're looking a lot at trying to reduce the administrative burden for our providers. We've heard a lot about credentialing and the timelines that it takes for credentialing to occur. So we have a provision in the new RFP that we can centralize that, and that will be done by KDHE versus the MCOs. We've got some requirements in there around peer-to-peer consultation, requirements that if someone is going to look at a service being requested, that they have to be in that specialty or have experience in that area of medicine, so you ensure that if you're doing that type of review, that someone is adequately qualified to make those medical determinations. There's new requirements around maternal and infant health. As we know, as a state of Kansas, our statistics are not good. So we're not only looking at some services that Medicaid has started to cover, such as doulas, but we're asking our MCO partners to look more around value-added benefits for our maternal moms and babies. We're also going to be doing a lot more reporting. We know we have a deficit around postpartum screenings. Once a mom gets past that first 6 weeks, it's very easy to lose touch with her through the remainder of her coverage, because you remember this legislature granted the 12 months of continuous eligibility. So again, we want to be sure that they're screening that mom, especially for substance abuse, mental health disorders, and other things that go along with obviously just delivering a child, to ensure mom and baby remain safe. Social determinants of health, and I think there's been some questions around what that means. Medicaid itself does not pay for social determinants of health, but why it becomes important, and just a kind of a story here from Kansas, is there was a child presented with an ear infection. Obviously a very quick exam. You prescribe an antibiotic and you send the child on the way, and the child kept reappearing and the ear infection was not resolving itself. Well, anyway, through talking to the mother, found out that their electricity had been shut off in their home. Well, antibiotics have to be refrigerated. And if they're not refrigerated, they're not effective. And so somewhere where social determinants of health come in is how do we and the MCOs better connect with community resources, so when a provider uncovers that we've got a family here that maybe temporarily has had their electricity shut off, or I know we talked about transportation earlier, but there's other barriers that are outside of the realm of healthcare. How do they help connect them to that community resource that can help stabilize the situation that they're under or improve it? So again, it can then have a positive impact on health outcomes. So we've asked our MCOs to do a lot more with tracking and developing those partnerships and having a more robust program around that holistic view. And then the last area is around healthcare access, obviously, health disparities. Interpretation services, I know for some of you, you've heard a lot about, some of the challenges with interpretation services, so we've added some more requirements in the RFP. And then again, we're working creatively with our MCOs of how do we address some of these health disparities, how do we encourage and get members into care, and sometimes, again, those programs are going to look very different in eastern Kansas than they will in western Kansas, and how do we regionalize and get more focused into what we're doing in what area of the state so we're having the best impact for our members, and ultimately then for the fiscal accountability to the taxpayers that we're doing well with the money that is allocated and that we're using them to improve health outcomes for our members. So that's really just a high-level highlight of some of the major changes that we made in this RFP, and I'd be happy to stand for questions.
All right, thank you, Christy. I guess my first question is, if you could break out on this list, which one are actually enhancements that are in the contracts and which ones are just, we wish you'd focus on this?
So they're all mentioned in the RFP. And I can break out which ones we put like specific requirements, like for instance, non-emergency transportation, we have specific timelines of when that service has to be provided after requested, versus which ones are asking them to do or partner with the community organization. And we can break that all out for you between the very, very specific of you are going to do this and the ones that are requiring them to do relationships or programs in the community, but gives them a little bit more flexibility, if you will. And yeah, we can break that out for you.
Okay, let me rephrase it a little bit. So are any of these a requirement in the contract, new contracts?
They're all requirements. It's just some of them we defined what the requirement looked like with very little flexibility for the MCO to, I don't want to use the word improvise, that's not the right word, but to design their own program, I'll put it that way. So some of them we were very prescriptive and said, you will do this, you will do this, you will do this in this timeline. Some of them said, you will have a program, let's say, for instance, around social determinants of health. You will partner with, local communities. You will design a program. You will have so you can do these resource connections. But we gave them more flexibility to respond to us in their proposal. How would they do that? And so we didn't exactly prescribe, you have to go to this organization, you have to use, there's some networks now, like Unite Us is one of them, where they're a hub for all the community resources where you can put in a request into that hub and all the community partners can see it and can pick it up and respond to it. It's really a kind of a new electronic database, if you will. We didn't prescribe that they had to use that service, so we gave them some flexibility in how they set up that program, but they must have that program as a part of the services that they're providing. So, and I can break that out for you, which ones are which way.
Yeah, I want the shells and the maize. Okay.
Yes.
Committee, are there further questions? Representative Carpenter.
Thank you, Madam Chair. So, Christine, the first one, care coordination. So how far did you get in the weeds with requiring care coordination and the community-based care? I mean, that whole area there, how does that work?
So this one is actually one that we are developing with the MCOs. So there's a work group of KDHE, KDADS, and all three MCOs, because what they did have to, in their proposals to us, tell us how they would do care coordination. And as you can imagine, there was quite a variety of how you would do these items. We want consistency among the MCOs because care coordination is so critical, and especially like for our HCBS population, that you wouldn't want a lot of differences in those programs, or you wouldn't want gaps. And so we actually are collectively defining exactly how that program is going to look. We're letting the MCOs bring some of their expertise to the table of how they think it should look, but we did require a certain staffing level. So there were some basic requirements in the RFP around care coordination, but now we're digging in even deeper so we can have a very standardized care coordination program. So it doesn't matter what MCO you enroll in, you should get the same level of care coordination regardless.
So how would you do in that situation? I think there's a perceived conflict of interest when you're dealing with care coordination with an MCO that's providing the services. How do you get around that?
So care coordination will be, again, it's going to vary based on population. So, and the other thing we don't want to do is duplicate. And there was a lot in the RFP around not duplicating. So for instance, you heard Drew this morning talking about the CCBHCs and the care coordination they're doing within their scope of services. So what we don't want is the MCO to come in and try to do something on top of it, which is almost duplicative and really not a good use of state resources. Then there'll be populations where you don't typically maybe think of care coordination. So give you a good example is I've been hospitalized, and let's say I have comorbidities. Maybe I have diabetes, I went in for a heart issue, and now I'm released from the hospital. So where care coordination from the MCO would come in is making sure that upon discharge, not only are those appointments scheduled for their follow-up visits, but that the member goes to the appointment, and if they do not, that there's follow-up to get them into care, because of course what you're trying to avoid is a readmission or a continued escalation of the health. So there's going to be some instances where care coordination, the MCO it's being more done at the provider level or that local level, and they're just ensuring and kind of following and making sure that that's happening. And then there's some where they'll actually be doing the care coordination. So it isn't a one-size-fits-all. That's why it gets sometimes can get very complicated and very nuanced, because you don't want multiple people doing care coordination, because again, that's a conflict. But that's also why we have to lay out expectations, because, and I think where some folks get concerned is there a cost benefit to the MCOs if they don't fully engage in care coordination? And so we have to lay out exactly what we are expecting and exactly kind of what their role will be in doing that. And then the big thing is monitoring it. How do we ensure after the fact that it's happening? Because I can tell you to do something, but how am I ensuring that you are? So those are the pieces of the program that we're developing now with in partnership with the 3 MCOs.
Thank you. And Madam Chair, one final. So how would this differ from targeted case management then, especially the last one, provisions of services and person-centered service plans?
So targeted case management in the Medicaid space is a very specific term that's only allowed in certain programs within Medicaid. I know we use the term broader, but in the Medicaid world, when you talk about targeted case management, it's got a pretty narrow application.
It's just for waivers?
Yes.
Okay.
And in that, certain waivers. And so where this would come into play, and this would be true whether there's targeted case management or there's not, if I get a person-centered plan of care that says I'm supposed to get 15 hours of private duty nursing and there's a gap in providing that service, we, as KDHE and our partners at KDADS, it's on us to monitor that and make sure that those hours are being provided. And if there are workforce issues, which again, we're aware, are there creative solutions? Is telemedicine, again, private duty nursing isn't a great example where telemedicine would apply, but in some areas it would. Is there other things that we can do under, value-added benefits or in lieu of services that would maybe help shore up some of these gaps? Is there a similar service that we could provide that at least is better than nothing? And so that person-centered service plan is really more on us to make sure that they're complying. We did put some additional provisions in the RFP about complying with those plans, but it's really on us as a state to monitor it and then take the appropriate actions if they're not being complied with.
And are there appropriate responses for KDHE if they're not doing that job?
That's what that's what we are building out now is what are the expectations? How are we going to monitor it? And then what would potentially be the liquidated damages, or other financial recourses if we had to use the stick, so to speak. Always try to, develop the program so they can comply, but if they don't, yes, what is our recourse from a state to hold them accountable?
Very good. Thank you.
Committee, further questions of Christine? Senator Petty.
Christine, thanks for this contact program enhancement. I wondered, under the access to services and workforce, you have accessing durable medical equipment. I know in the past we've had brought forth about, particularly with children, the lack of consistency about paying for and reimbursement for equipment. So is that addressing that issue? Or?
Yes, that is at addressing that issue. And then it's also, again, part of it will be on us. How do we do a better job of overseeing that? Because yes, but it is around the access issue. It is around the payment for it. And some of that will come on us to come to the legislature and potentially ask for, rate increases, and that will be a part of the package. But there are additional requirements in the RFP for the MCOs to comply with. And then again, some of this will definitely fall on our side of the fence of how do we monitor it? How do we ensure it's happening? And then there are just, again, areas of the state, and a really good example is when we get into some of our very, very complex children, where there's not providers that do some of those very specialized wheelchairs or very specialized, bath chairs. Well, how do we manage that if the providers that provide those very specialized services aren't in those areas of the state? And again, primarily talking about Western Kansas here. And then how do we deal with that to make it safe for the child? Because some of them, even traveling, becomes obviously a challenge. And so there'll be some of it that, and the reason I point that out is some of these things, there are specific provisions in the RFP, but we recognize that provisions in an RFP alone are not going to solve it, because there's some of these challenges that really have to be worked on with us in partnership with our MCOs and with our own oversight to solve, because there are just challenges in some areas of the state for some of these very specialized providers. And yet, how do we do right by our members, and how do we solve that when there just isn't a provider there in that community to provide that service?
Then the other, I just want to mention, so I'm glad to see maternal and infant health, because we've repeatedly heard about, well, I think, in the past, our MCOs have continued to enhance their services, which is so important. I mean, if our families don't get started with positive health outcomes at the beginning, then it's a losing battle all the way. So I'm glad to see that area is being focused on.
Yep, agree.
Representative Carpenter.
Thank you for that segue into that. I want to tell you, Christine, thank you and your folks for helping on that durable medical equipment. I know you guys have been working hard to try to get parity between the states, Missouri especially, because we're right next door and they pay quite a bit more than we do.
Yep.
So they've been working very hard on this, and I appreciate that. So
You're
I
welcome.
just want to say thank you.
Committee, are there further questions? Christine, I have one. How much does AmeriGroup still owe providers in the state of Kansas?
That is interesting you bring that up, Madam Chairman. So I was asked that question just recently, and of course that was before my time. And my understanding is there was a settlement agreement done. So from a KDHE perspective, it was settled, and there was an amount agreed upon, and and Adam's shaking his head, so information I was provided is correct. But so now I know the providers will obviously state a number, but from a KDHE perspective, there was a settlement agreement, and that was closed.
So and if you don't have it today, that's fine, just follow up. So what was the amount owed versus the amount that was settled upon?
Okay. Let me write that down.
That's fine. Committee, are there further questions? All right, seeing none, thank
right,
you very much,
thank you.
Christine. Next, I have Adam Profit. And Adam, you could have zoomed in. I understand you're kind of under the weather, which is why I don't have Dave Long here, but Sky does a great job filling in, so.
Thank you, Madam Chair, members of the committee. I appreciate the offer. I am feeling better, but if things get a little hot in here, I might say that I'm not feeling so well.
Yeah, I'm not letting you by with that one. You know better than that. So.
I do know better than that. Thought I would try.
But if
anyway.
it does get hot, you're welcome to take your jacket off.
No, appreciate that. All right, in all seriousness, my name is Adam Profit. I am the Secretary for the Department of Administration. Appreciate the invitation to be here today. I will lead by saying I am not going to be able to provide any specifics as it relates to the current protests that are underway. That is because those protests are open and active, and I want to maintain the integrity of the process and allow my Director of Purchases to work through those individually to ensure that they receive the attention they deserve without any undue influence from me, providing input.
Sounds like a legal disclaimer. Would that be accurate?
I do have counsel over here. But I do want to talk about the protest a little bit more broadly so you understand what happens with the protest process and what it is not, and kind of what we have advised the Department of Health and Environment and KDES to move forward with. So the protest process, the procurement protest process is an administrative process that is defined by the OPC, or Office of Procurement and Contracts, their policy manual. It is not part of the Kansas Administrative Procedures Act. The process is outlined, like I said, in the policy manual. That policy manual is available on the Department of Administration website, so it's available for public consumption, and anybody can go out there and identify what's involved in the protest process and what the Director of OPC is looking for. Protests must be submitted to the Director of OPC within 30 calendar days of the bid award. I will freely admit up front there was a bit of a conflict between the dates. So the policy manual does state 30 days of bid award. That was May 7th, 2024. The RFP itself said upon regret letters being sent to the non-winning bidders, that was May 14th. We made the determination to go ahead and take the latter date to allow plenty of time for the MCOs to submit a protest should they so choose to do so. So 30 days after May 14th, all protests were due. We did receive 2 bid protests from 2 different bidders. Any protests that are received after that 30-day timeline, again, according to our policy, which is publicly available, would likely not be reviewed. Again, I am unable to comment on anything that's happening within the current protests. Those are at the discretion of the Director of OPC. They are not at the discretion of the Secretary of Administration, and that's by design to ensure, again, that the Director of OPC, who is a subject matter expert as it relates to procurement and how the process should work, is able to review each of those protests and the merits of them on their own without any influence from the Secretary of Administration. One note is that if a protest were to have been filed prior to the contract awards, then no awards would have been made. That was not the case with KanCare. No protests were received prior to the contracts being awarded and signed or regret letters being sent. So we were able to go ahead and issue the awards to the 3 selected bidders and move forward with the process. I've got on my testimony here some of the components that must be included in the protest. It must be written, and it must contain some very explicit and specific information. The long and the short is we are looking to see what it is from the bidder's perspective that they feel that was missed during the procurement process. Each protest is reviewed individually, so we received 2 protests within a relatively short time frame. The time frame will work out such that we should be able to issue final decisions at around the same time. But each protest is being reviewed individually because they are very specific in nature and individual to the MCOs that are submitting the protest. I would also note that the decision of the Director of Purchases is final. That is determined to be the final agency action. There will be no further agency action once that determination is made. From there, of course, bidders have other rights available to them should they choose to move forward with judicial review. That's completely up on, dependent on if they want to move forward with that. But the Director of OPC, their decision on this will be the final agency action as it relates to this. I would also note that we, as a Department of Administration, have advised KDHE and KDADS to continue to move forward with preparation for the new contract start date on Jan 1, 2025. This is the same process that we took last time. We feel that that is in the best interest of those that we are serving on the KanCare program to ensure continuity of operations. Just continue to move forward with the 3 bidders that were selected. As the protest process plays out, depending on what the results of that might be, we can always pivot at that point in time. But we felt it imperative, given the short time frame that we have and the amount of work to be done before Jan 1, 2025, that we advise the agencies to move forward with the current vendors. I can say this because I believe both entities are on the agenda for next, so this is already a public document. The bids that we received were, the protests were received by CareSource on June 4th, 2024. We did receive supplemental information from them on June 12th, 2024. And then from Aetna, we received a protest on June 5th, 2024. Our general goal is to provide feedback and a final decision within 30 days. That would, of course, put our final determination somewhere around the 4th of July. And once that determination is made, that information will be posted to the decision will be posted to the OPC website. But at current, we are not releasing any of the protest documents. Again, it's an ongoing protest. We want to make sure we maintain the fidelity of the process. With that, Madam Chair, I'd be happy to answer any questions that I can.
Okay, so then, are you going to go for July 5th, because that's when theirs does, or would you look at July 6th? And the reason I ask that is because we've been given dates, and then those dates pass, and it just continues and continues, and I don't want to see that happen here.
No, I understand. So again, to reiterate, each protest is being reviewed individually. One of the protests did have supplemental information provided on June 12th. So we would have our 30-day clock start with that June 12th window. So that could go as far as July 12th. Again, that's an internal agency goal. We are going to do everything we possibly can to meet that. We understand that time is of the essence here and information is needed to make sure that all parties can move forward in a good fashion. So we will do our best to hit those 30-day timelines. July 5th would be the goal. That is the day after a state holiday, and it's a Friday. So there's a possibility that could bleed early into the next week, but I don't want to hold my director to that.
Okay, so, and I'm learning about this because I've never been involved with a protest on this, is if the decision comes back and the contractors disagree with that, what other recourse do they have?
Again, from an agency perspective and procurement perspective, whatever the director of OPC says will be the final agency determination. And at that point, we consider it settled. There are other avenues that bidders could select to pursue, should they so choose. Judicial review is one of those. That's what happened last time. That's completely up to them. I'm not going to advocate one way or another.
Okay, well, I wasn't asking for you to advocate.
Sure.
I'm just we're trying to understand this because this is new to most of us.
Yes,
so.
ma'am.
How many times, Adam, have you seen a director of purchasing overturn a contract since you've been in your current position?
Yeah, it's a good question. Since I've been in my current position, I would say maybe a handful of times or less. I've been in this position, I think, 1.5 years at this point. It's not a very normal occurrence, but there have been occurrences where a director of OPC has overturned an agency decision with regards to procurement.
Can you provide us a list of those that were overturned, please?
I'd be happy to. It might take me a couple of days. I would be happy to circle back.
I didn't expect you to have it off of the cuff, so.
Sure.
Representing Carpenter?
Thank you, Madam Chair. So switching gears just a minute ago, a question was asked about how much AmeriGroup owed our state providers when they left town. So you were a medical director at that time and probably know more about that than you ever, Medicaid director, I'm sorry. And you probably know more about that than you ever wanted to, as I remember our conversations. But do you recollect the amount that would have been owed to our providers? I have a figure of $5 million roughly, arguably a figure. But what are your recollections of that?
Yeah, so I do recall the conversation. It was a topic that you brought up quite regularly, both in public and then on phone calls that you and I had, which I appreciated. I do not remember the specifics of the amount. I do recall there was a bit of conflict between the reported number. I believe there was the billed charges, and then there were the allowable charges, and there was a bit of a discrepancy between the two. So I'd hate to quote a number not knowing which one it was. I will say that the settlement that was reached to get that off the books and to make sure that providers were paid finalized after I departed as Medicaid director. So I can go back and see what that settlement was, but it might be KDHE has quicker access to the records.
And was that after we returned the bond?
I'd hate to say on public record. I'd want to go back and check the time frame, sir. I'm sorry.
Okay, I get it. It's been a while since.
Yeah.
Thank you.
Yes, sir.
So you and Christine could work on the request together that
Yes,
both
ma'am.
of us have
Be
made.
happy to
Thank
support
you.
that.
Thank you. Anyone else with a question? Senator Fagg.
Thank you, Madam Chairman, and Adam, thank you for your presentation.
Yes, sir.
How did you decide on 3? Where'd the number 3 come from?
Thank you for the question, Senator. That is an agency, a KDHE and KDAD's determination. I think they'd be better qualified to answer that. Yes, sir.
Anyone else have a question for Adam? All right, seeing none, you're released for a little bit.
Thank you, Madam Chair. I appreciate the time.
Thank you very much. We didn't put you on much of a hot seat there, so. Christine, are you able to answer Senator Fagg's question?
Yes, so the number 3 the number 3 is, it's based on enrollment levels. Because again, outside of unwinding, we run between 410,000 and 420,000 members. And so if you tried to add a 4th plan, the challenge that you're getting into is the average enrollment per plan would be about 100,000. And that from a risk and a financial perspective gets very difficult for a health plan from a profit perspective and being able to do all the administrative requirements. So it's almost like our enrollment isn't enough to support 4. The challenge with going with 2 is that if one of them has significant issues or becomes financially insolvent or something else, then you have to have choice. That's a requirement of doing managed care and Medicaid. And so we just felt like that risk wasn't worth taking. Again, you always hope you select good and qualified bidders, but in the case something unfortunate would happen, you wouldn't want to be in a situation where now you only have one MCO. So that's kind of where 3 comes from, is just looking at the numbers and financial viability.
Committee, any further questions for Christine right now? All right, seeing none, thank you very much, appreciate it. Next, I have Jane Brown, Plan President, Aetna Better Health of Kansas. Welcome to committee, Jane.
Good afternoon. Can you hear me? Good afternoon, Madam Chair and committee members. I'm going to highlight some of the basis of our protest and, of course, attempt to answer any of your questions. Although I will be upfront and say that I don't have all of the answers today based on the limited documentation that has been made available through the state's website relative to this bid award process and the grading criteria. It is our position that a procurement process should be fair, equitable, and transparent. The basis for our protest is simple. One cannot make up grading criteria after a bid has already been opened and graded. Transparency is a decision that impacts, this decision impacts over 130,000 lives and their families and billions of dollars. And it cannot be made on the basis of capricious and arbitrary, seemingly cherry-picked set of standards that are not visible or transparent to us. This RFP resulted in a tied score for 3rd place between Aetna and Healthy Blue. And the tiebreaker was suddenly and after the fact decided on the basis of network. Go ahead.
I'm going to ask you to pause for just a moment. Do we have separate testimony from you versus the protest that you sent us on what you're saying here?
I think so.
Do you see that, Arida? I just want us to be able to follow along, so.
Sure. You guys have our entire protest, so my effort is just to highlight some of the key points. If you've already read it and you want to launch specifically into questions on it, I'm happy to do that. There's a couple of call-outs that I would make if I'm able.
Okay, what we don't have is what you're presenting to us right now.
I don't have a slide.
Okay. All right.
If that's the
proceed.
question.
Yes, it is. Thank you.
Okay. So the tie was based on network, right? And network is worth 145 points. However, care coordination is worth 160 points. We don't understand why network was chosen as a key tiebreaker criteria. In terms of our performance on the care coordination sections, Aetna outscored Healthy Blue by 20 points. But still network was chosen. So this is an example of the sort of arbitrary criteria that was selected as part of the tiebreaker process after the grading had already occurred. If network is also such a vital section, then why were the millions of unpaid dollars not addressed in the Healthy Blue proposal? And there is very clear documentation to show that AmeriGroup underwent a legal name change to become the current organization, but it is at the end of the day still AmeriGroup. Settlement or no settlement, it would be very material from a perspective of network in terms of that exit and how that all operated in terms of claims payment. So this tiebreaker, it is our position, it cannot possibly be in the best interest of Kansas or of Kansans. And I just also want to talk a little bit about the duals requirements that are very clearly articulated in the SOW and RFP language. There is a clear requirement that in order to even bid on or to be evaluated on the technical questions, you must be able to operate a dual special needs plan by 1/1/25. Now, what are duals? Duals are those members who are duly eligible for both Medicaid and Medicare. That means that they are either elderly over 65 or they are eligible for Medicare on the basis of disability. So these are literally our highest needs members. And anybody that's coming in needs to have a dual special needs offering by 1/1/25 based on the language in the RFP. Aetna already has a dual special needs plan that's operating in the state of Kansas, and it is a 4-star plan. There's absolutely no evidence and no documentation posted on the state website to suggest that Healthy Blue is even able to launch a dual special needs plan on 1/1/25. Aetna serves 10,000 of those members today. Those members are not going to be able to have Aetna support on 1/1/25, nor will they have the third option of Aetna. They will be down to probably 2 dual SNP plans across the state. So these are sort of some of the things that we put in our protest along with additional information. But I will also say that ultimately this is about people. And since this decision was made, my phone has not stopped ringing off the hook by the many members, their families, by providers who are all sharing concerns about the decision. And I've submitted over 30 letters of support that have come in from all over, and we've received literally hundreds of phone calls. I wanted to read at least a couple of sentences from one of those many letters. Aetna Better Health has never once denied him the opportunity to partake in these therapy services. I am truly concerned that losing this insurance provider will severely affect my son, if not both of my children. I am concerned about the services he needs being limited and his quality of life deteriorating. Aetna has been wonderful in ensuring that Aiden has everything he needs to thrive and continue his journey to become stronger and hopefully healthier. They have been wonderful to work with and have been so kind. Aetna has been able to keep up with us and ensure we are still well taken care of. I have many, many such letters and many such pieces of feedback from our members. And I wanted to make sure that their voice and their thoughts were being represented and heard to this committee today. In terms of next steps, we have also requested through FOIA and through CORA additional information in terms of how this tiebreaker criteria came to be. We'd also like to see the individual scores by question, by bidder. None of that has been made available. Our FOIA and CORA requests have been denied and declined under various reasons. And so on Wednesday, we have filed a suit in order to compel and get that information out into the public. So we will be in front of a judge come mid-July in order to review all of the information that has not become publicly available. Again, this is about transparency, and this has not been a transparent process. I also represent hundreds of dedicated men and women who are all in Kansas, who are all doing this work every day. They are passionate about their service. This is a high-performing team, high-functioning team. I will acknowledge that in 2019, Aetna's launch into this market was not smooth, but Aetna has worked day in and day out to not only repair that, but bring innovation, bring a high standard of service, high-quality results, and continue to propel the program forward in a positive way. We want to have the chance and the opportunity to continue in that good work. And I want to also thank some of the Aetna colleagues who wanted to come out today and show their representation. It looks like a sea of purple behind me, it feels like. So to conclude, I believe in full transparency. This is why we submitted our entire protest to this committee. You're welcome to look at it. The entire public is welcome to look at it. I think we have a very good basis for our protest. We're happy to answer questions about it. I'm happy to provide you documentation showing that AmeriGroup has changed their name legally, that it is indeed the same organization. And while our past compliance issues seemingly were brought up in this tiebreaker criteria, I see nothing at all about any AmeriGroup activities leading to their ultimate exit in 2018, 2019. We will look forward to the FOIA and CORA request hearings, and once that information becomes available to us, we will happily share it with the rest of you. Questions?
Thank you, Jane. Questions for Jane? And I don't know if this will be for you, Jane, or if KDHE and something tells me we're not going to get answers from anyone, but I do have a major concern for the dual eligibles.
Right.
And I had no idea what the number was out there, but if you've got 10,000, then the number's pretty.
Yeah, it's probably about, I would have to guess, 25 to 30,000 statewide. And in terms of the SOW, I mean, it is right up there with having a license to do business in the state, that you must have a DSNP plan by 1/1/25 unless you got an exception. Now, we've requested evidence that such an exception was requested and granted, because if it wasn't, we don't understand why this ever went to a technical evaluation. The way that the RFP is worded, it says you have to meet the SOW requirements before grading. That is not the case here. And if that material is out there and an exception was granted, then I guess I would ask the next question. Why are we comfortable, limiting choice for some of our most vulnerable members?
Okay. I think what I'm going to do is just so that we're not bouncing around on questions, I'm going to have you step aside for a moment. Janet, would you please step up to the podium? Madam Secretary.
I will. I'm not sure how much I'm able to say, though.
Was an exemption provided to a provider for the dual eligibles?
Not to my knowledge.
Huh?
Not to my knowledge.
So they are going to be able to provide Medicare across the state starting January 1. Is that correct?
I'm going to have Christine step in. It's Medicaid. Hang on. And Medicare. You're getting in both,
I'm on the
right?
Medicare
Yeah,
side
go
here.
ahead.
The federal deadline for a plan that wanted to be operational with a DSNP plan on January 1st, 2025 is July 1st, 2024. A contract will be signed and sent to CMS by the 7/1/2024 or 7/1/2024 deadline for a DSNP plan.
Will all of the MCOs that you've awarded to have dual eligibility available to all of their clients?
Yes.
And how does that happen when you have one of those entities that's stopping their Advantage plans in Kansas?
So the contract requirement is any one of our MCOs, Medicaid MCOs, has to offer a DSNP plan. That is factually correct. That is a requirement. For any one of our contractors to have a DSNP plan on 7/1 or January 1st, 2025, their contract signed by our agency has to be submitted to CMS by July 1st, 2024, and that will indeed occur for all three MCOs that were selected under this RFP.
Okay, I feel like I'm getting a dance here, which I'm not happy about.
Well, there's just, because
My
this is a
understanding is that Blue Cross Kansas City will no longer have Advantage plans up there in their network.
So Advantage and DSNP are different. I'm talking specific to the requirement under our plan for
On Medicaid.
on Medicaid.
I am talking about the MCO contractor that will not have Medicare available for the dual eligible population. That is my question. I don't know how to make it any plainer. I
So-
want to know, will every one of those MCOs, January 1,
Yes.
have Medicare? Then how do you answer it when you've got one of those that will not have it in the Kansas City area? Who will step up to the plate on that? And the reason I ask
I
this,
think
I'm
we're
getting
talking-
calls
yeah.
from agents around the state wanting to know what Medicare agents, what they're going to do for their clients out there.
So there are different levels of Medicare plans, so I think that's probably where we need to start. And so we have a requirement for what is referred to as a DSNP plan in our contracts. All three of the MCOs will have a DSNP plan as required by our contract. If they have other Medicare lines of business that they do, that is outside the scope of our contract with them.
Okay, so what
so-
Medicare plans then, and I'm sorry, I didn't mean to talk over the top of you. Then, because Medicare is something that's very dear to my heart as well as Medicaid is. I think we're playing semantics with words, and I don't like that either. It's either a Medicare SUP or it's a Medicare Advantage plan. And I do know.
There's actually a third option.
What's the third option?
That's what I'm talking about, a DSNP plan. So a DSNP plan is for Medicaid and Medicare eligibles that they're serving as a part of their contract with us.
Right, I understand that.
That's what's in our contract, is the requirement to have a DSNP plan. So that's the part. And so when you get outside of our contractual provisions, we required them to have an operational DSNP plan on January 1, 2025. We did not venture into other lines of Medicare business. And what I can tell you is all three of our plans will comply with that contractual requirement.
Okay, the dual eligibles have a SUP and an Advantage plan. I understand that part of it. That's my private world. If they don't have, they can't have a dual eligible plan and not do the Medicare side. They can't do that. They're not licensed that way in Kansas. And the feds don't allow it licensed as. It's not licensed separately.
Well, they submitted a contract to us, and so I think, I don't know whether to get you a copy of the contract. I can tell you, we have a contract from Blue Cross and Blue Shield that meets the requirements of our contract for a DSNP plan that we are in the process of signing, which then will go to CMS for approval by the deadline of 7/1/2024. Now, the specifics of that and how all of this aligns, like you said, it could just be we call it one thing, you call it something else, which is probably the case. But I can tell you, internal to KDHE right now, we have the contract for Healthy Blue for their DSNP plan that they will offer as a requirement of our contract on January 1, 2025. They did not request an exception. They submitted a contract that we sign as part of our contract, and then it goes to CMS, and obviously they have their work that they have to do on them. But I can tell you, we do have a contract in-house from Healthy Blue, as well as from Sunflower and United.
Okay, well, we know that Sunflower and United have it because we've been
Yes,
operating
yeah.
under it. And now we're dealing with a new entity, so I think that this committee would like to see that contract.
Okay.
Please.
Yeah.
Representative Ballard.
Thank you, Madam Chair. Just a clarification, is Healthy Blue brand new?
I think the name is, they did, they went through the, I was going to say, I think it's Department of State here in Kansas, whatever the entity is called, but they're doing business as Healthy Blue, and it's a 3-entity group that makes up Healthy Blue.
Okay. There's so many stories swirling around.
But yes, that is their approved doing business as name.
Is Healthy Blue
associated
with the Mara Group?
Yeah, it's Blue Cross and Blue Shield of Kansas City, Blue Cross and Blue Shield, the one here in Topeka, and then Elevance, which, again, if you go back in history, Mara Group is now part of Elevance.
And how does Anthem fit in there?
Elevance is Anthem. They've gone through several name changes. So Anthem, I think, is technically the one that bought Mara Group. And so it was Anthem for a while, and now it's Elevance.
And why I'm asking this question is because that's how I'm getting it from people out there. I mean, is it this group, is it that group, or is it that group? We're familiar with the ones that we're serving, but when people ask me, is 1, 2, 3, is all this pertaining to one group? Then I can't answer that because I wasn't on the team that was selecting of what they're doing. And I think we need to clarify that part.
We can get all that, because that's all described in their response. We can get you that about all the entities and the relationships but the doing business name so you'll hear us refer to it, it's Healthy Blue.
It's Healthy Blue, okay.
Yep.
And I guess even before this even came out who it was, that we had all of this problem with it being late as legislators, and we weren't able to get the decision made, at the time we were doing it. So people were a little upset anyway about that. So then all these other things came out, and it's just very confusing. Now, I remember there was a little bit of confusion, 5 years ago, when we were doing it too, but I would hope we would have made it a lot smoother so that we would have less kind of conflict. And it seems like we're almost back where we are, but in another setting. Okay, and that makes me very nervous. Okay, thank you.
Representative Carpenter.
Thank you, Madam Chair. So is this scorecard available to the public? For picking the various MCOs?
I don't believe it'll be.
Yep.
And there's a reason?
Why can it not be public?
We have D of A legal here.
That's why we had attorneys.
Yeah, I know, I just don't want to answer wrong, but.
Yeah, so there's, on the Department of Administration website, there is a document around the scoring. And that's what's publicly available. And it is the score by category, and we can get you the link to that.
And it would be the actual score that you use to decide the MCOs?
What it would be is it would be the result of the consensus review. So how the scoring was done is, I believe it's 7 categories. It may be 6. It's 6 or 7 categories. I think it's 7. Assigned to each one of those categories was staff from KDHE and KDADS. And they went through a process. So let's say, for instance, provider is one of them. I'm assigned to provider network. I looked at all 7 proposals as an individual, and then my group got together and we scored the proposal. That's what's in that document, is the result of the consensus review process and what their score was for each MCO in those 7 categories, ranked from 1 to 5. And so that's what you'll see, because that's how we did the scoring, was through what we call a consensus review process. But I believe that document describes it in much more detail than I'm going in, but generally that's what it is they looked at him as an individual so they could come into consensus review and debate, agree, argue, whatever they wanted to do to come up with the score. And it was staff from KDHE and KDADS combined, usually 5 to 7 members per category of staff that were doing that review and scoring.
Yeah, that'd be good if you could get us that link. Thank you.
Representative Concanon.
Thank you, Madam Chair. Okay, without being able to see the scoring, is there an opportunity to debit on the scoring when there is someone that owes us money? I'm being a little facetious, but I can't, I was here when we made the last transition, and I didn't understand at that point why Mayor Group was not renewed. I had not had a lot of problem with them. Well, I'll put it this way, not more than anybody else. But it was their exit that was so poorly done. I cannot imagine why on earth they would ever be considered to be brought back in. And that right there should have eliminated them. Now, I've been kind of focused on some child welfare things and been out of the state, and I had not connected the dots until you were just speaking that that is the same company. And I'm just appalled that we're thinking about reentering, or we are reentering into a contract with the way that they behaved when they exited. And I don't really have a question. That was just a comment.
Representative Carpenter.
So, to be clear, the link is not what I'm looking for. What is I'm looking for the actual scorecard, not a link, but the actual scorecard of how you chose the MCOs.
So in that link is the actual scoring of the consensus groups. So it will say, it won't list, I don't think it lists who this, it doesn't list the staff people, but it will tell you how they scored each of the areas, and that's actual reflective of their scoring. They said, you know, for provider network, you know, United was, you know, got X score, Sunflower got X score, so it is their scorecard for the consensus review teams.
So is it an abbreviated one that I don't have to read this entire document?
I can, when we send it over, we'll tell you what page it's on. It's a nice table, so, but we'll tell you what page it's on in the document so you can go right to it.
That would be great. Thank you.
I still don't think, Representative, it's probably the details that you're looking for, but we can pursue this as well. Okay, can you provide to us a list of providers that were presented by the Blues? When they told you who their providers were?
So when they responded to the RFP, it's not they don't submit their whole provider directory. It is more of their response to the questions around the provider directory. There are some numbers in there, but it's not the directory in its entirety.
No, but I think that there was probably some within the purchasing on the enhanced stuff, wasn't there?
And I don't know, are the proposals?
Or the value-based, I always call it enhanced, but
And the
value-based.
proposals aren't public yet, that's. Until the period's over. Yeah, so the protests aren't public yet. I mean, the proposals are not public yet.
So is that why we're hearing that there's issues with CORE right now, requests?
Yeah, there's just certain parts of, and again, I'm not the expert to speak to that. We may have to defer to the Department of Administration, but while this process is going on, there's limited information that is considered public at this point. And so we can only provide what's considered to be public information.
Can you answer then why, if an MCO had the same providers, what would constitute a lower scoring for one over another?
So in the RFP, we asked a lot of questions. So in previous RFPs, and different states are going to this, in previous RFPs, there was a lot of, you're required to, you know, have so many providers in your network, or so many of this, or so many of that, and they say, yes, I will comply. Yes, I will comply. This RFP was done much more in a question format. What we were trying to get at there is demonstrate that you understand what the requirement is, and I don't get just a statement that says, yes, I will comply. And it was through that evaluation of their answers. So it was much more of an open-ended question RFP, and it was in the evaluation of those answers that then the consensus, what we call the consensus committees, came up with the scores for all 7 of the areas is based on how they responded to understand, do you understand the criteria? Are you applying it correctly? You know, do we think you understand the Medicaid population, the Medicaid business, et cetera, et cetera? And we can send you over a few of, so again, I know you don't want to go read a whole RFP, but we can send you over some samples, because the RFP is public, just some samples of kind of what we're talking about, of how we formatted the RFP, so you kind of understand what they'd be responding to for the consensus committee then to score.
Representative Carpenter.
So will there be reasoning there as to why we picked someone that we hadn't done business with that tied, that the score tied, that we had no history with? Will there be reasoning in that?
That would be. So that's the final technical document that will be produced on the scoring.
And that's not available now?
Yes, that's the one I've been talking about, but when you talk about the tie score and then the negotiations, the last technical document will be the original one that was done by the consensus committee, which is publicly available.
And that is available now?
Mm-hmm. Yes.
But that's the consensus, not the details that you're looking for.
Yeah. Thank you.
Yeah, Representative Ballard.
Thank you. Then I have to ask another clarification. In addition to looking at the RFP and everything that's there, do we then look at, say, the 3 vendors that were serving before? Do we look in terms of their performance, how well they have done with their consumers, what they have done? I mean, you would almost have to say they were outstanding here, or they did a poor job here, or they did this or the other. And then you look at the new people. And I think Representative Kincannon touched on part of what I have been receiving. The one chosen does not have a good reputation. I didn't have anything to do with it. I don't know that, except for what I hear from my consumers. And then it would come out, I think, the question that was asked: what was the settlement and how much actually was owed to the state? So now we start looking at it in terms of poor credit, or we didn't get this. The question would be, you have got to go outside of just what the RFP says in terms of the performance or the behavior of the vendors.
So my understanding, again, I'm not an expert in Kansas procurement law, is that you can't give an inherent advantage to one responder or the other. It has to be a level playing field, because then it starts to get subjective if you say, you know, well, I think this plan did a good job, therefore I'm going to bring that into the scoring. It is all based on their response to the document in front of you, and they were scored in those 7 areas based on what they put in the document, because otherwise you've essentially inherently given an advantage to 3 MCOs over, you know, so you take some of the MCOs that have never operated here, then I mean, you could say they're at a disadvantage or they're at an advantage. The way the scoring is done and the way the consensus reviewers were trained was that you have your area, you have your set of questions that you're evaluating, and you're taking what was in front of you as far as the response, the completeness of it, all those other factors, and as a group, you come up with a score for that particular area. Yeah.
I'd like to add something, if I may. I would say in the detailed questions, in addition to that document or that grid that Christine went over about what the enhancements were, a lot of the questions that were detailed out were based on the fact that what was happening today with the 3 MCOs. So let's ask those questions. If it was maybe we're not doing as good as a Medicaid plan, a lot of the way those questions were formulated was based on that very thing. So it did get everybody a level playing field without calling one particular MCO out, and let's see how they respond to how they're going to fix this or address it or enhance it in the future. So it's not exactly the answer you're looking for because of procurement law, but those questions were based on that, and then the responses were reviewed and evaluated.
Okay, now that but then I went under what procurement law it is. So you rank them and you put them on equal footing. But it would seem that at some point, there was another group that would not have been on equal footing, even though they would have responded to everybody else because of past performance. So did you totally disregard past performance?
We'd like to get back to you on that. I'm not, please.
Just give me just a minute here.
Okay, but it's me. Okay.
Sorry about that. It was just IT needs to take care of something, so go ahead.
No problem. No, I don't have any more comments, other than I understand RFPs. I understand all the legality of procurements. I mean, I know all of that. But I also know that there is and has always been a little wiggle room in terms of how we balance this, as long as we have stayed true to what we said was required in our RFP or the preferreds that were in the RFP. So, but I think this issue that I have right now, that my constituency has had, is that we have not taken in consideration past performance. Okay? Thank you, Madam Chair.
Representative Carpenter.
Thank you, Madam Chair. So, trying to understand this, we have two MCOs that tied. How did the decision then become that we picked one that wasn't even in business in our state? If we consider everything equal, just like you just said, and all that came up with this and that, how did you arrive at that then if the score is tied?
It was based on the responses. And then there was additional responses that were reviewed. And the quality of those responses and what was said and whether it met the criteria were also considered. That's about all I can tell you on that.
So after the score was, just so I'm clear here, so after we had a score of 1,000 and you were tied, then the responses that you sent out and asked for clarification is what decided you to go with another company?
Not necessarily. It was the entire picture. I don't know how else to respond to that.
Well, I'm trying to understand this too. We have responsibility to people of the state of Kansas and 450,000 Medicaid folks. And it would be nice to have some kind of a fact that I can say, oh, I can't respond to that. They tied, but I can't respond to that because nobody's told me that.
Well, I think it's timing because we're in a bid protest. That's one reason. I can tell you as the leader of the agency, I'm very confident in the process that was used. It was much more comprehensive than the past process. I'm not worried about the move forward. There's documentation. There were teams of people. Secretary Howard and I were arm in arm, equally involved in detailed reviews of many, many documents and responses back to the detailed questions, sir. So I don't know what else to tell you other than we're confident in the process that was used, no matter what's being said today.
Okay. Well, Madam Chair, I would ask, make a motion to request that the Attorney General look into what we can actually have as released to the committee or to the public. You know, I'm hearing the attorneys saying we can't talk about this. I'd like a second opinion as to what we can, in fact, have as far as information.
Is there a second? Second by Representative Berquist. Comments, discussion, committee. Senator Petty.
So my only question would be, are we talking about what can be released after the period of time that has, for Cora, that's been referred to repeatedly here in this presentation today? Are you talking about violating the legal ramifications right now that's in place?
I'm not talking about violating any legal ramifications. I would just like a second opinion as to what this committee is privy to as far as documentation.
Can you
Representative
clarify if
Berquist.
you mean now? Do you mean now versus after the bid protest period, as was discussed by Adam? I'm just trying to clarify.
I'm talking about now.
Okay,
Yes.
thank you.
Representative Berquist.
I think you made it pretty clear. That's good.
Further comment or discussion on the motion? Senator Petty.
I just think that we talk about now, we go against the guidelines that were set down for the bid protest process, and I don't feel comfortable with that.
I'm not sure why it would be any different now if it's legally public information that this committee can have now or after the protest. I don't understand why we shouldn't have that documentation.
Senator Petty.
Go ahead. Yeah, go ahead.
I think I made my statement. I think,
Senator Fagg.
Thank you, Madam Chairman. Just my 2 cents worth. It never hurts to have a second opinion.
Representative Berquist.
I think it's pretty clear that the motion is to make sure that we can get what legally we can get and what that is, not whether we can bypass legal protections under that contract. The representative simply is asking for to know a legal opinion from the Attorney General's office as to what we can legally know about this process. Thank you.
Representative Reese.
I would be more comfortable involving the Attorney General if we can have very specific things that we want him to answer versus opening up the whole thing to him. So if there's a very specific 1 or 2 questions that we want him to answer, I would like the Attorney General to stick to that.
Senator Petty.
Well, I guess I need clarification here of what I'm hearing. I'm hearing one thing to my right and I'm hearing another thing to my left. So if we're talking about what's legally available within the contract procedure, so which has been mentioned here by the presenters, the contract period, then it makes sense. But if we're talking about violating the contract period, then of open information, then that's a different issue.
Representative Ballard.
Thank you, Madam Chair. Now, I've been here quite a few years, and rarely has there been a motion that the Attorney General gets involved. The only other time I remember that occurring was around the big education decision, which was huge. If there's a protest and there's a format that you follow, and if it ends up with a trial, then I think that's when all of this comes out as to what could be. But I think involving the Attorney General at this point in it, that becomes an administrative and something else. I am not in favor of that.
Representative Carpenter, perhaps we need to clarify a little bit what you're asking is you don't feel comfortable with the answers that you're receiving today, that this cannot be presented to us or it cannot be made public. And so your opinion to the Attorney General would be to see if his office agrees with that. Is that correct?
I'm not asking to break any laws or anything else. I'm not an attorney. I don't know what we're privy to. I trust you guys, but I also trust and verify. I'd like to know what we actually have in information available to us as a KanCare Oversight Committee involving this entire process. Now, if you can tell me what that is, then we probably don't need this. But I think that we need some kind of a legal opinion, absent people that are involved in the deal, to say, okay, you can have this information, you can have that information, you can't have that because that's part of this ongoing legal deal. But I'm not asking for anything that will break any laws or anything else. I just, quite frankly, at this point in time, don't know what we are entitled to and what we aren't.
Are there any further questions or comments on the Carpenter amendment or motion? All right, seeing none, Representative, you may close.
I close.
Okay, you've all heard the motion by Representative Carpenter, seconded by Representative Berquist. All those in favor signify by saying aye. Aye. Opposed, no? No. The ayes appear to have it. Ayes do have it, motion carries. Now we're back to discussion. Senator Fagg.
Thank you, Madam Chairman. Question I have is Healthy Blue associated with the Mary Group? You do? Okay, you did. Okay, what was the answer to that one? Okay.
Elephant's Health is the parent company that has many entities under it. Healthy Blue is part of that. Amera Group is part of that. They have in the RFP, which is publicly available, their response that there was a name change done, and I don't remember what year. Jane Brown had referred to that as well. So are they one and the same? I can't totally answer that question. I don't know how they're legally structured. We just know Healthy Blue was represented as Blue Cross of Kansas and Blue Cross of Kansas City.
Committee, are there further questions or comments? Okay, we're done with you guys for right now. Jane, did you have anything else that you wanted to, for right now, that means don't go far.
I mean, the only thing I would end with is in hearing the requests from the committee in terms of the information and the scoring criteria and how the final sort of grading was done. And I do hear the reference made by the department relative to the joint scoring that is by section. That is not individual scores by question. Okay, we do not have that in the public record. We should know how we scored on each question, especially when we're in a tie, and we need to understand how we came to the conclusion that in a tie decision, an incumbent who is, at least as far as I'm aware, well regarded by constituents, by members, by providers, okay, is then at the end of that process ousted. So that's the information we'd like, and that is the core request that we are filing, and we're going to go ahead and have those conversations also in front of a judge, since we can't get any help otherwise. I appreciate your time. Do you guys have any additional questions for me?
Senator Fagg.
Thank you, Madam Chairman. Jane, I just want to make a positive comment. I got a call Sunday afternoon, visited with an individual for probably 45 minutes, that his family is a client. And he could not say enough good things about what you guys did. And so I just want to say thank you to your group for that kind of thing.
No, thank you for saying that. My phone, when I say that my phone has been off the hook since this decision came out, it really has. And I'm being asked the question of why. Why did this happen? And I do not at this time have a good answer for that. And by the time this process is over, I think we're all entitled to know why we have to have over 100,000 people go through this disruption. And by the way, on the topic of DSNP, even if you do have a SMAC agreement in with CMS by 7/1, okay, which is the deadline, does that mean they're going to have the same network? Does that mean they're going to cover in the same counties as what Aetna currently provides? We're one of the largest DSNP plans with the largest footprint. We're a 4-star plan for DSNP in the state. That is important. That is a quality carrier that is being eliminated. So I know I'm a little bit passionate about this, but this is a moment for passion, and I feel strongly that we do not deserve to lose this bid.
And Jane, I apologize, 'cause I'm trying to multitask back here with the IT issue. Did you make any reference to what you heard when we were talking about the procurement process?
Did I make any reference to what?
Did you have any comments about what you heard in the discussion that we just had with
Yes.
KDHE on the procurement
Yes,
process?
the critical point for me is while there is scoring available by group, right now there are 7 groups, network, care coordination, there's actually 36 individual questions. We would like to understand and get line of sight to how each of the 36 individual questions were scored for each bidder, because ultimately what we have is a high-level view or a summary of those final questions. We'd like to compare. If we received a poor score in one question and another competitor who had a substantively the same answer received a higher score for that same question, I would like to know why that is. I mean, we have been obviously spending quite a bit of time reading these responses, and for sure there's differences in format, but I think we brought in a lot of compelling evidence of the good work that we've done in Kansas in the past 5 years. We've also paved the way towards innovation and all of the things that we're going to do in the next 5 years. But somehow we then end up losing on the basis of network. While Healthy Blue has the highest network score, do they even have a network in Kansas today for Medicaid? Do they have a network for HCBS providers today? That would be quite shocking since they're not an existing Medicaid carrier. So unless they went out and contracted and have put this network together overnight, I would be very suspicious about how they can deliver on a network by 1/1/25. I'm just saying.
Any further questions for Jane? All right, seeing none, thank you very much, Jane. I appreciate it.
Thank you.
Okay, I've got a real quick question. I know we've got Sunflower. Do we have United in the room as well? Can you tell us what your number of dual eligibles are? If not, perhaps you can get it for us.
Audrey Masner, Chief Operating Officer with United. Our dual eligible population is roughly 11,500.
All right, thank you. Sunflower? Can you answer that question for us? There he is. He's clear back there in the corner. Yeah, quit hiding in the corner.
Good afternoon, Madam Chair. I'm told, having not done previous research for this, that our number is about 10,000.
All right, thank you.
Thank you.
All right, thank you. Next, I have Chad Moore, Market President, CareSource Kansas. Welcome to committee.
Thank you, Madam Chair. Can you hear me okay? Great. Chad Moore, Market President, CareSource of Kansas. It's a pleasure to be with you this afternoon. Thank you for the invitation. I did submit written testimony that should be before you, as well as our protest document was submitted as well, so you have both of those. How I'd like to approach today is to really just provide a framework and summary of that written testimony. I certainly won't read it verbatim. You all have it and can review it. But just want to go through some of the highlights, right? As an introduction, CareSource is a not-for-profit plan. It's been around for about 35 years. We started with a little seed grant with a social worker in Dayton, Ohio, who grew the organization to well over 8,000 employees, serving more than 19 states and a couple million Medicaid members today. We are a nationally recognized managed care organization, have been in the state of Kansas for well over 3 years, developing relationships with provider partners, community-based organizations, and getting a good perspective of what the consumer needs from its Medicaid program. As part of that work, nearly 2 years ago, we sat down with 3 well-respected Kansas-based organizations to create a health alliance, and that is how we bid this contract earlier this year. Those partners are InterHab, the Association for Community Mental Health Centers, and the Children's Alliance. And the goal there really was to understand from those organizations what are the shortcomings, what are the opportunities for our Medicaid managed program in Kansas. We developed a response together. We dug in on some of the pillars that Director Osterlin spoke about earlier, specifically around the model of care and the care coordination model, all designed to best serve the members and the providers who serve our Medicaid program today. The not-for-profit status of CareSource allows us to reinvest in our communities, in the states we serve, in a much different fashion than some other organizations. The state has asked, as part of the RFP, that any profits, 3% of profits from these plans are reinvested into the communities we serve. We had a commitment to do that of 10%. So more than 3 times we committed to invest our profit, 10% of our profits, which is more than 3 times than any of the other plans, current or those who bid for this contract. I'll touch a little bit on our protest document, and as I said, you have it. It's the non-exhibits is an easy read, about 17 pages. The exhibits go quite long. But really what I wanted to focus on, and some of the issues have been highlighted by Ms. Brown. To put it in perspective, what that means is the state's actuary says this is what it should cost in order to manage benefits for a very complicated and complex Medicaid population. What we found in what has been made available is that 2 of the plans dramatically underbid this contract, and specifically Amerigroup, or Healthy Blue, underbid it by the tune of about $60 PMPM, right? Over the course of the life of the contract, that's hundreds of millions of dollars. Representative Ballard earlier talked about, was getting at what criteria around best value looks like for a procurement process, and part of that is past performance, of course, but also cost. And I'd submit that if you were to appropriate funds to build an overpass and it came back a few $100s short of that project, I don't think any of us would feel good about driving on that overpass. There's no difference here. And so really what we hone in on the protest, or in our protest, is really this idea of underbidding the current contract. The legislature last year actually put in place a rate increase for providers that had been underpaid for some time, roughly $60 to $80 million of provider rate increases. For MCOs that have dramatically underbid this contract, I think those rate increases are frankly at risk. These are for-profit plans, right? They are tasked with delivering value to shareholders, and they will not let $100+ million go unspoken for. The other issue I'd highlight is really around process, which Ms. Brown actually talked about earlier as well. And one of the things that we were frustrated with is the lack of not only transparency in terms of documents that we have also requested, but a failure to follow process. And that's something we've challenged the state to look at and respond to. So while the Procurement Negotiating Committee asked that all of the cost proposals be released so that we could move into another phase of the process, CareSource was not asked to participate in face-to-face meetings with the state, or was there a review of its cost proposal? Again, I go back to my first point, which is a critical piece of the equation here is to look at the cost proposal, evaluate them against the other 5 bidders, and make a determination on what is the best value for the state. We've asked the department to stay the decision and evaluate our arguments. And as I said, we are still waiting for a final determination from the state before we determine what our next steps are. I'm happy to answer any questions for you today.
Very good. Committee questions? Wow. You're off the hook, I guess. Okay, perfect. Very good. Thank you, Chad, for being here.
Appreciate it.
Next, we have Secretary Howard. We're just getting warmed up, Secretary. Thank you for being here.
Thank you, Mr. Chairman, members of the committee. I'm here just to kick off the beginning of the general KDADS updates. You've already had chances to hear from some of my team members earlier today. You have the full slide deck in front of you, but we were asked to only report verbally on a few topics today. So I have a couple of pages, and then I will, after that, I will ask Drew Atkins to talk about 988, and then I will ask Commissioner Hayden to talk about the KU waitlist study and the community support waiver. We can obviously respond to questions on any of the other topics on the agenda, but as you'll see on the agenda, we were asked to hold our verbal comments to a couple of those topics. Just a couple of quick updates. We have had some new team members. I think we may have talked to you last time about the creation of a separate Aging Services Commission at the Kansas Department for Aging and Disabilities. I created that this past spring. We had the aging services blended into the Long-Term Services and Support Commission with all of the HCBS waivers and all of the work of Commissioner Hayden and her team. And I really wanted to put a little bit more focus on aging services and those pieces. So we've hired Dave Anderson to be our new Aging Services Commissioner. He is, I think, online today. And some of you may know him from his prior experience in the mental health world at High Plains Mental Health. I also wanted to introduce, if she's in, I think she's in the room. Yes, we also have a new Assistant Commissioner for Behavioral Health Services, Taylor Bremer, on this side. You might just stand for just a second, Taylor, and wave for that introduction. The third, I wanted to just take the chance to recognize one of our team members who's been a KDAD staff member for, gosh, as long as I can remember. I mean, 30-some years at KDADS and SRS, and he directs our adult services for the Behavioral Health Services Commission. And Charlie has done just amazing work in the addictions field over 30 years. I would venture to say that we kind of have the Oxford houses we have in Kansas because of the passionate commitment of Charlie
Charlie Bartlett, and he was recently nationally awarded the Lifetime Service Achievement Award by the National Treatment Network. So I just wanted to acknowledge him publicly for that work and for that acknowledgement. And you already heard earlier today all about being selected as a CCBHC demonstration state. You know, on page 3, I wanted to just mention a handful of things from the legislature. A lot of programs and activities within KDADS related to some of the legislative action. We are busy with some of the transfer of programs and activities coming into KDADS. The mental health intervention teams moving from the State Department of Education over to KDADS, and the expansion of that program also to include some private schools. You heard earlier from the Medicaid Inspector General where he referenced the transition of the registration of continuing care retirement communities from the Insurance Department to KDAD. So we're very busy making sure that we're ready to go on both of those things on July 1st. We also had some requirements placed in various provisos, for example, to track facility-initiated discharges for state-licensed only adult care homes, and also to do some reporting on healthcare supplemental staffing agencies. Obviously, the whole issue of staffing agencies has been a big issue, and so we are well on our way to getting the processes in place to make sure we fulfill that. We're also excited about some of the legislation that passed related to strengthening of outpatient treatment orders, some updates on licensing of disability service providers, and some clarifications there. On page 4, just a reminder about some of the ways in which our budget was supported during this past session, and I would thank the members of this committee and other legislators for your support, as always, in providing funding for services. But I won't go through these items on page 4, but certainly new funding in a lot of different areas, a number of increases in particular rates in HCBS, in nursing facilities, some core funding added for the first time for area agencies on aging. Obviously, the significant investment in the IDD and PD waivers in terms of the 500 slots for each and the proviso connected to that funding. And you can see some of the other investments as well. So again, we're very busy implementing that and very excited about the impact that these investments will have on our service delivery system, our partners, and most importantly, Kansans who rely on those services. The first thing that we were asked to talk about specifically on the agenda after my comments is 988. And I can stop for any questions you might have for me, Madam Chair, or I can hand it over to Drew Atkins to talk about 988.
Committee, are there questions? Well, you're just doing such a great job. Well, Representative Carpenter, ask your question.
He doesn't want to let me off the hook, do you, Representative?
And you're going to be really surprised at this. I really don't have a question. Could you ask the people to stand up, the new folks, again?
Sure. So Taylor Bremer is our new Assistant Commissioner for Behavioral Health. And then Dave Anderson was actually on WebEx, so he's out of town today, so I'm not sure. Dave, so if you say something, maybe you'll pop up on the screen. But again, he's our new Aging Services Commissioner. We'll make sure we get you introduced to him in person. So thank you.
Very good. Thank you for that.
And I'll be here should you have questions. So.
And you're letting all of them know that he likes to call people at 6 a.m. in the morning, right?
You know, I think we've sort of added that to like our new employee orientation. So.
I would take care of him in a lot of ways if he did that to me. So is that all you had, Representative?
That's all.
Okay. Very good. Thank you.
Secretary, and I was just talking to Representative Carpenter about this, and I hope that other legislators will pay attention to it, because this SUD additional money that was done by proviso I hope that it can continue at least one more year, because it's going to take that, I think, for you to actually have some good data to show why it's important and what it's done. Then if not, then you take and let it go away. But I think, I kind of looked at it as kind of what we do in, with hospitals and stuff, disproportionate share. Those that have a larger amount, then they don't have enough funds, and we want to make sure that they have the funds to continue providing the services.
Yeah, thank you, Madam Chair, for that comment. I think that's a really important aspect of that funding, because it does take some time to have the data to see what impact something is happening. And again, this really is targeted to those providers serving the most needy, as you made that allusion to disproportionate care. So we certainly would hope to see that continue in our budget as well. Thank you.
From anyone else? Nope, that's it.
All right, we're going to skip to page 20 then and go to a familiar face from this morning, Commissioner Atkins, and he's going to talk about 988.
Welcome back, Drew.
Madam Chair, members of the committee.
This afternoon and we've had lunch. So go ahead.
Very true. Thank you for having me back. We've got a few slides here to talk about 988 Suicide and Crisis Lifeline. Because we don't usually report out on this, if you have questions, I've got a cheat sheet up here. There's somebody behind me that can probably answer those. I'll kind of lay a baseline of 988, talk a little bit about where Kansas is at, talk a little bit about IDD crisis and some of the stuff that we're doing with some of the dollars we received 2 legislative sessions ago. And then again, I'm happy to answer any questions or bring something back. And feel free to interrupt me. So what is 988? This is formerly known as the National Suicide Prevention Lifeline. You may have heard of it then. But July 16th of 2022, 988 officially went live. 988 is the 3-digit dialing code connecting people to the Suicide and Crisis Lifeline, where compassionate, accessible care and support is available for anybody experiencing a crisis, a mental health-related distress, whether that's thoughts of suicide, mental health, substance use crisis, or any other kind of emotional distress. People can also dial 988 if they are worried about a loved one who may need crisis support. Again, just a little bit of the orientation. Whenever an individual calls 988, the individual will hear a message that will allow them to press 1 for veteran services, press 2 for Spanish, or otherwise their call is routed to the local Lifeline Crisis Network Crisis Center based on the caller's area code, the 3-digit code. A trained crisis counselor will answer the phone, listen to the caller, understand how their problem is affecting them, provide support, and share resources if needed. The primary goal of the Lifeline is to provide support for people in suicidal crisis and/or mental health-related distress in moments when they most need it, and in a manner which is person-centered. The vast majority of those seeking help from the Lifeline do not require any additional interventions at the moment, and currently, fewer than 2% of Lifeline calls require connection to emergency services like 911. While some safety and health issues may warrant a response from law enforcement and/or emergency medical services, i.e. EMS, mostly when a suicide attempt is in progress, the 988 coordinated response is intended to promote stabilization and care in the least restrictive manner. If we can, sorry, thank you. So focusing, that's a little bit more of the broader national landscape, focusing a little bit more in on Kansas. What does this look like in Kansas? And there is a disclaimer. We have had an additional center totaling 4 come online, and so this slide will need to be updated, but I'll kind of walk through that. So it starts out, again, at 988 Suicide and Crisis Lifeline, and then comes down to our providers that answer those calls and chats and texts. So right now we have KanCare out of Sedgwick County. We have Kansas Suicide Prevention Headquarters. We have Johnson County Mental Health. And we just had another center come online, Wyandotte Behavioral Health Network. So they would be our 4th. And then we also have Health Source Integrated Solution that serves as a statewide call backup center. KanCare does answer the calls for Sedgwick County, Johnson County Mental Health answers the calls for Johnson County. Wyandotte Behavioral Health Network answers the calls for Wyandotte in that area. And then Suicide Prevention Headquarters answers them statewide. And again, HIS, or Health Source Integrated Solutions, is the statewide backup. In fall of 2024, it is expected that geo-routing will be approved and implemented by the Federal Communications Commission. This means that this means calls will go to the call centers located closest to the tower where the call originates, rather than being geolocated at the time based upon the 3-digit number. Currently, Kansas Suicide Prevention Headquarters is the sole response for chat and text, although in state fiscal year 2025, Health Source, Johnson County, and KanCare will all receive certification to support these chat and text efforts, which is a huge deal for us at KDADS as the disperser. Excuse me. So here is a chart of our in-state answer rates, and I believe on the next slide, yes, I'll have in-state answer rates for Kansas and how that compares to the national average. But starting here first, since our inception, July 2022, up into April 2024, which was the most recent we could get data at this time, we've gone, as you'll see on the far left of the line graph, from 84%, go all the way up to 93% in-state answer rate in January of 2023. That levels off a bit from April to July to 92%, dips down to the 88% there in September 2023. Again, goes back up to 91%, and then we're back to 88%. And so for the majority of the timeline that we've answered calls, we've stayed within 2% when we have dipped below the 90%. And why that's important is that's where overall SAMHSA and our federal government partners want states to be on average. And so I'm excited about that. There are a myriad and variety of reasons that this can happen. A couple of reasons why that can change frequently is if you do onboard new centers, you have new call centers come on, you're training new staff, you have staff turnover, those types of things can attribute, but it can also be other reasons as well. So again, just mentioned this, but we do also have the average monthly answer rate versus the national average monthly answer rate. I have attended one national conference in the last month and another meeting with other states and states' behavioral health commissioners where we have been publicly thanked and applauded for our in-state answer rate in Kansas. And so I did want to share that and brag. Not only obviously on my staff that work in this realm, but also on our providers. They're working very hard to keep this up. And as you'll see, if you track that, we have stayed well above the national answer rate average. And so I'm very excited about that. We just wanted to show that chart here as part of the data. And then I've got some verbal updates. These are going to look eerily similar to our response to the Bethel's issue response log, but I thought I'd share them here, and I'm happy to share this or get this to the committee and distribute it to Madam Chair. But this is our crisis stabilization update with the roughly $2 million that we were given in a budget proviso. Again, I believe that was back in 2023 to implement crisis stabilization for the population of intellectual and developmental disability individuals and consumers. And so we started and hit the ground running. We were able to hire an IDD behavioral health crisis coordinator that works within our crisis division with our director of crisis that also oversees our 988 project coordinator and other 988 staff. So we wanted to make sure that those efforts were combined and overlapped and were leveraging each other, not working in silos. And so we've been able to give out grant awards to 6 different entities for fiscal year 24 and expect the same 6 to come back around in response to a request for applications that we put out there for this. Some of those entities, or a list of those entities, are Good Life, Johnson County Developmental Supports, Lake Mary Center, OCCK, Sedgwick County Developmental Supports, and then also Twin Valley Developmental Services. The amounts that they received varied based upon the budgets that they submitted to our application and proposal opportunity, mainly focused on training, also hiring staff such as ABA staff as well as BCBA staff for this. Coordinating with 988 efforts when calls are coming in. How are we handling individuals that are IDD? How are we making sure that they don't get dropped in the crisis continuum? I believe that's about all I have. I've got some facts and figures, but I'm happy to answer any questions that the committee may have or go back over any of that, Madam Chair.
All right, thank you. Now, on the IDD information you were referring to, we don't have that in hard copy, correct?
That's correct, Madam Chair. I'm
make
happy
sure
to
I'm not
provide
missing.
that.
Yeah.
No, you are correct.
No, just get it to staff. Committee, are there questions for Drew on this? Just a couple for me is on the March 24 and April 24 drop in lines. Could some of that also be with the issues we're having with Lawrence headquarters?
I might.
It's attributed to some of the new folks.
I might look to our Deputy Secretary, Andy Brown, to see if he has any response that he would like to provide as a...
So it's pretty recent. We really haven't had a chance to analyze it or come up with a cause for it. There are some service disruptions that happened, I think, in May and June related to headquarters, but I'm not sure that that's the cause of the dip.
Yeah, well, I mean, it's not huge, but I know that ever since it started, you guys have strived to be up in the 90s.
Yep.
And I don't know if this is for you, Andy, or if this is for Drew, but I know that the 988 Commission has been having discussions about rolling over any leftover funds. Has a decision been made on that for a request to the legislature, or?
So I believe we're going to review that in the July meeting, and I believe that there's been a discussion about having that available for the next session.
Okay.
Yep.
Thank you. Committee, are there any other questions for Drew on this? Drew, thank you very much. I just thought it was important for people to kind of get an update where we started with 988, where we're at today, and then the movement I'm real happy to see on the IDD population, because that was a tough one for, I think, everybody. So.
Absolutely, Madam Chair. Happy to come back and report out anytime.
All right,
thank you.
Thank you. Let's see, who do we have next?
Madam Chair, next we'll have Commissioner Hayden to talk about the KU wait list and the community support waiver. And I think I'll point you to page 41. Is that right?
All right.
Madam Chair, I'd like to go ahead and talk about the waiting list study first and then move to the community support waiver. And just as a reminder, the purpose of the waitlist study was twofold. Their first aim was to understand the overall makeup of the people on the IDD and PD waitlists in planning for services that will meet the needs of the people on the waiting lists, and also to create a predictive model for services needed and potential crisis exceptions, which will inform the primary data collection in AIM 2. AIM 2, we really want to understand the demographics, experiences, and needs of the 1,800 people on the IDD and PD wait lists. Using the predictive model created under AIM 1, identify people at risk for entering services to crisis exception in the next 3 to 5 years, forecast the service and support needs at the CDDO and ADRC levels. Identify important health, employment, community living, support needs, trends, and people on the waiting lists. So KU has given us a preliminary findings. The final report will be here by October 1st, but since we're really working hard on this community support waiver, they have released some of their data on the IDD waiting list. And some of those topic areas are demographics, living preferences, needed supports, frequency of support needs, caregiver demographics, and goals and concerns of caregivers. So the next slide is kind of telling us, some of the things that we're looking for here. On the waiting list, about 30% of the people on the waiting list are 18 or below. The 10% are about 18 to 20, and approximately 55% are 21 to 64, and very few are on the 65 and older. And the areas of need are home, community, learning, employment, health, and social. The blue line indicates if they need hourly support. The orange line is daily. I think it's a dark green line is weekly. Light blue is less than monthly. And then purple is monthly. And the average age of the caregiver is 47 years old. So in this study, I know that KU has been engaging with the Centers for Independent Living and the CDDOs. They have been taking existing data and the whole process has been quite the learning process as we learn what we have and what we don't have as far as data. And we've been really working on refining our procedures to have some more data on the KU wait list study. Do you have any questions about that at this point?
Representative Berquist.
Yes.
Yes, ma'am. Thank you, ma'am.
Yeah.
You mentioned 47 years old for the average age of the caregiver.
Correct.
Do you suppose, or is there a suppose that that's familial, or is that by choice the caregivers are vocationally that way? Are these family people that are 47 by average?
Yeah, it's most likely these are all family members.
Okay.
That tends to who provides the most
I should have
care.
figured that. Thank
Yeah,
you.
yeah.
Thank you, Madam Chair.
Committee, are there further questions? Senator Fagg.
Thank you, Madam Chairman.
I almost promoted you, just so
Did
you
you?
know.
Okay, well, thank you. That'd be an honor. KUCDD, what was the cost of that study? How much money do we have put into this deal so far?
I don't have the numbers, but I can get that for you.
Okay, thank you.
So KUCDD does plan to meet with our contractor and KDADS, a contractor for the Community Support Waiver, which is Public Consulting Group, to share their findings so that we can help formulate the Community Support Waiver to best serve Kansans with IDD. So some of the preliminary findings that we have found, or the key takeaways, are that with the survey results we've found so far is there's strong preference for people to live with families, a spouse, a partner, or alone. Few respondents indicated they wanted to go live in a group home. So, that gives us some information about what services need to look like moving forward. We need to use person-centered planning to determine the preferred living situation of the person on the wait list. More supports for community living, such as personal care services, and fewer group homes may be needed. Family, friends, and technology were the types of supports most respondents identified as needing. When developing the community supports waiver, it will be important to include procedures that allow family members to be paid as caregivers. And that did pass with CMS. We are allowed to pay family members as caregivers, so that's already has been approved by CMS. In open-ended questions about needed supports, caregivers frequently noted transportation was a critical support, particularly for community living, going to school, employment, and being social. In each area of life, about half of the respondents indicated the person on the waiting list needed support every day. Between 20 to 30% of the respondents also indicated that the person on the waiting list needed supports hourly. So one of the things that we are considering for the community support waiver is something called budget authority. And budget authority is a cost-effective way to give people choice and control over the supports they need in their lives. The community support waiver needs to build in flexibility for individuals to identify goods and services that can be paid through budget authority, such as support staff training and wages, transportation, technologies, family caregivers, community engagement, licensed and qualified professionals, gym memberships. It can be a number of different things. This is complicated, and the states, we do plan to be consulting with national experts on the budget authority. There was concern about sufficient funding. While budget authority is cost effective, the system needs to ensure that adequate funds are available to meet people's needs. The data shows that the services people need might be more expensive than originally thought. Also, services are becoming more expensive. So we need to be sure that funding is adequate for this waiver. Care plans and in KU's analysis on preferred living situations show differences in preferred living situations between caregivers and persons on the waiting list, with more people on the waiting list preferring to live alone or with a spouse or partner, along with many that prefer to live at home with their families. And to ensure that the person is being supported as they want to live, care plans and goal planning needs to be guided by the person in a person-centered manner. Also, there is concern about access to qualified professionals. There has been showed a need of emotional, behavioral, and health-related services, and we need to be working with our partners to create a robust network of licensed qualified professionals, such as occupational therapists, physical therapists, speech therapists, emotional and behavioral therapists. So as I indicated, KUCDD has, they will have their final report in October. The data collection will be complete by July 31st, and then they will conduct analysis. Additional analysis and recommendations from the survey will be included. Findings from KUCDD's analysis of existing administrative data, findings from KUCDD's analysis of national data collection of practices used in other states to manage waiting lists, and they will have their completed survey results from the PD and the IDD waiver. So we can move to the community support waiver update.
Michelle, can I pause you right there a minute?
You bet.
So the report will be done in October.
By October 1st, yes.
So what do you think would be available to us in November?
You should have a final report with
Okay.
recommendations.
But not necessarily the analysis?
The analysis will be completed then too.
Oh, okay, all right.
Yeah.
So staff, we'd want to make sure that we have them present that in.
Yeah, okay, making sure.
Okay.
I got that right.
Well, I don't want to ask you to present something that you don't have ready, but I think, this has been a long time coming, so we're
Yeah,
kind of
you
anxious
bet.
to see
I
it.
understand, yes.
Okay, and I think Representative Carpenter had a question as well.
I
Oh,
was
I'm
just gonna
sorry,
say,
Madam
I
Secretary.
just wanted to make sure the committee knows that you have the full interim report as a separate document from our testimony. So you have a 22-page interim report that was provided
Oh,
to the
okay.
committee. So just so you know that.
All right, thank you. Representative Carpenter.
Thank you. Michelle, thank you for being here.
You bet.
Sometimes Michelle's on speed dial with me, but, so.
Michelle, do you get those 6 a.m. calls?
No, he has not called me at 6
No, I
a.m.
don't. But I do call her late.
He does do that.
So has anything changed as far as the number of respondents? I know when the KU folks were in my office, I thought it was a very low response rate to the surveys. Has that picked up any?
I believe it has. Does anyone have the answer on that? I don't have, yeah. Evan, if you'd like to. I'm going to ask Dr. Dean to address that to make sure I give you correct information.
Sure. Hi. So I'll say the number of responses has picked up. I think it's in the report there, so I've got it up here. Are the numbers that we have right now, because remember we created the two different surveys, one for the people on the waiting list and one for caregivers. So we've had about, so now I'm getting lost in the document. There. So about 1,400 across both surveys. And so just the numbers I have here are just for people with intellectual and developmental disability on that waiver. We've had about 764 for the waiting list survey and about 692 for the caregiver survey. So the actual response rate is still pretty similar to what we talked about before, a little over 20% of the people.
I just think I'm amazed that it's that low, given the need for services out there. I was shocked when I met with you guys earlier this year, and it hasn't changed any.
Yeah, and I'll say that's with pretty close partnerships with the CDDOs and the Centers for Independent Living, reaching out to people, letting them know the survey's coming. We're talking with people on the phone that want to complete the survey that way. We're sending it out in paper. Like, we're doing a lot just to get the response rate that we are. But and it's actually, like, if you look at national surveys, a 20% response rate for people with disabilities is actually pretty good. But I know we were hoping for more.
Okay, very good. Thank you for that.
Committee, further questions? Are you done?
I was just going to go over the community support waiver update
Okay,
real quick,
yes,
and
yes.
then we can be done. So we have brought on a contractor to help us develop the community support waiver. It's a public consulting group. We have hired some staff internally to help us manage the community support waiver. The new waiver will help to address the extensive waiting list for the current comprehensive IDD waiver with over 8,800 Kansans served and 5,000 waiting. The community support waiver will offer less costly services with a proposed $20,000 annual cap per person, and keep in mind, on the comprehensive waiver, it's about $53,000 a year for a person to be there. Services may include transportation, employment support, personal care, respite, and various therapies. Due to network adequacy, a phased rollout is planned, starting with 500 participants funded 60% by the feds and 40% by the state. Year one, 500 participants with a $20,000 cost cap equates to approximately $10 million, all funds, $4 million SGF. And year two is 1,000 additional participants with a $20,000 cost cap equates to an additional approximately $20 million, all funds, and $8 million SGF. When fully implemented, it could be as high as 140 million all funds, 49 million all funds, including 40 million SGF. But we'll get a better feel for that as we finish up the waitlist study. So just to give you kind of what we've been working on the community support waiver, there's a number of areas that we have to address in our application to CMS. The first bucket is waiver development. That's goals, populations, age served, services offered, provider enrollment process, quality improvement process. We also are working on a rate study to determine the rates for the services. We'll also have to determine the FMS arrangement. We are working on the stakeholder engagement. We're launching a website regarding the community support waiver with PCG's help. We're going to be initiating an advisory group in July with stakeholders across the spectrum to participate in that, and we will be holding regular meetings with them. We will be serving stakeholders, having monthly meetings with CMS and KDHE to keep updated on where we are. The next step will be public comment and CMS review. And we're going to also have to make IT systems changes, already starting all those processes because they take a very long time to do. But we'll have to develop procedure codes, prior authorization, eligibility rules, the whole 9 yards. But I'm very excited about this. We've been working hard to get things rolling in the right direction and serving people as soon as possible. Do you have any questions?
Representative Carpenter.
Michelle, thanks again. So it was early April that the waiver development folks were hired,
About there, yes.
and they're going to be done with their development of the waiver next week?
No, no.
Oh, I thought I misunderstood.
No, it's just, that's just a bucket of work that we're doing. It's not the timeline. It's just, these are things we're all working on, kind of all at the same time.
I
It's
know,
just different
but I
buckets.
wanted it done next week.
I know. I would really like that too, but we'll do the best we can.
So seriously, when can we look for the application to be completed so that we can apply to CMS for this waiver?
I will have to get back to you on that, but we really plan to start serving people in FY '26. We are nailing down exactly when that would be so that we can provide the legislature with cost estimates there.
But isn't it reasonable that we would be able to at least apply to CMS by the end of this year?
I think that, I will have to look at that, but yeah, somewhere in there. But when we get the timeline ready, I'll give that to you.
Very good. And thank you guys for all the work you're doing on this. I know it's a lot, but
Yeah, it's worth it.
it's going to be worth it.
Yep.
Thank you.
Thank you.
No. You're going to miss me, Will.
Madam Chair, those were all the formal comments that KDAD's had that you'd asked for verbal responses to. I obviously have my team members here if there's other topics as well you want
Right,
us to
I
address.
just wanted to, I was trying to find the testimony, Madam Secretary, just to take a look to see if we had any questions on the regional state hospitals, if you could tell us what page and which update
That's at
to
the
look
very
at.
beginning of the testimony.
Of the
and,
first batch or the second batch?
It's on the batch you were looking at this just now, the KDAD's updates that we were just looking at. If you go back to starting on page 5 and 6, and I have Deputy Secretary Bruner here, he can give an update on that. So.
If you've got just a brief one, Scott, to kind of give us, I know we didn't ask for that, but just,
Sure, glad to do that. Scott Bruner, Deputy Secretary for Hospitals and Facilities. Just a quick update from the end of the legislative session. You all appropriated an additional $26.5 million to the project. The importance of that is it lets us build the full 104-bed design that we've been working on for the hospital in Sedgwick County. That's an important step. We've been working on a design that is flexible, that we could expand from 52 up to 104. With the additional appropriation, I feel confident that we can build that full design, and we can stop designing two things and just concentrate on finishing the design for the one building. We've received the 100% design documents from the architect. We're in the process of reviewing that with our internal team, the team at Sedgwick County, and then a consulting architect that's working with us to make sure we're dotting all the I's and crossing all the T's. We expect that to be wrapped up. I asked for another week, but that's this week. Once we approve those design documents, the architects will start converting them into construction documents that can be part of the bid package that'll go out to general contractors. We're expecting that conversion drafting process takes about 4 months. So that would put us into the fall when the county would issue an RFP seeking a construction contractor. And then once we get that awarded, we'll be off to the races to break ground and start construction, hopefully early next year. On That's the design part. The other significant thing that's happened since the last time that you all met, on the site that that the county selected, that we worked with the county to choose in South Wichita, there were some zoning changes that needed to happen to that property. The property sits in the city of Wichita, so the city planning commission, we had to go through that process to get that change made. That made it through the city council early in June. There were a couple of public protests which triggered a slightly longer review process, but we've completed all of that. The zoning's been done, and the county's working with the property owner to complete the sale process. The property was, the county issued an RFP sorry to go through the whole story, or I don't think it'll make sense at the end. We did an RFP process to look for properties, looked at a number of different ones. The one that we ultimately selected was gifted to the county, but we're still having to go through a formal purchase agreement to actually transfer the title, and that's in the process as well. The county's in the third or fourth version of the purchase agreement, but expect to have that in front of the county commission mid-July. So once that's done, the property is finalized. We're well into the design process, and we'll be, again, waiting. The next kind of major milestone is the RFP for the construction that'll happen in the fall. We are planning one more town hall meeting, well, probably some others, but we're planning a town hall meeting sometime in August, early August, in the community close to the site. We've been talking about the site. We've been talking about that with folks in South Wichita. We want to have another meeting to kind of go through that now that the zoning is complete, the design's more complete. We can show people what the building will potentially look like so they can get a sense of what impact that's going to have on their community. So that'll kind of be the other thing that may happen before you all meet again. But I'm happy to report about that when you come back together. I think those are the major updates on the project. Really good progress, feel good about the timeline, and it's, as it sounds like, it takes a lot of people to make this happen, and we've had a lot of levels of review, but feel good about the cooperation and collaboration to get to this point.
Okay, and we're at 145 beds?
104.
104. Why keep trying to get more?
Because everybody does, and I'm only building 104, so.
I was just off 40. It was no big deal. Do you think that when we get this opened up that we'll actually have some beds for voluntary care? I know what the immediate need is, and that's down at our jails.
Mm-hmm.
And I don't think people understand that that testing can take months or years on some of those individuals from the jail.
Just as a reminder, what we're building is 104 beds. 52 beds will be forensic beds for people that are criminal defendants that need their competency to stand trial evaluated or restored, and 52 of them will be for patients that are in mental health crisis, screened by mental health centers, and found at a maximum. They'll need involuntary commitment for treatment. The care and treatment statute allows a process to involuntarily commit somebody by a court, also allows people to voluntarily admit themselves to a state hospital. We don't have a whole lot of voluntary admissions because we don't have the space. Right. So once we add those additional 52 beds with everything we've got at Larned, everything that we've got at Osawatomie, and then our state institutional alternative partners as well, it's not impossible. I'd be really hesitant to predict that even give you a number. I wouldn't even speculate. But the processes that we're going to create for admissions at this hospital and continue at the others would allow for voluntary admissions, and as we have space available, we certainly accept that. Our current rule or guidelines that we follow is if we were at 85% of our budgeted capacity, we don't voluntarily admit. But that could change over time as more beds come online. Right. And that's the vision for the future as well.
Okay, thank you. Committee, are there any other questions for Scott? Appreciate you stepping up there.
You're welcome.
Let me put you on the spot.
My pleasure.
Committee, now the next thing on our agenda is written-only updates from our MCOs, but they are in the room if you have questions for them. But before I do that, is there anything that the MCOs would like to say to us before we take questions? All right, I like that. Representative Concanon.
Thank you, Madam Chair. I have a question for Aetna. For Jane. Oh, yeah, Jane's back in the room. Hi. So assuming things move forward the way they are now, could you talk just a little bit about your commitment to a transition plan?
Absolutely. We've already sat down and had a very elaborate internal discussion about what a smooth transition could look like. You have my commitment that we will ensure that this is a transition that looks nothing like the transition of 2018, 2019. We will ensure that we have boots on the ground, that we will continue to staff all of our departments. We're putting retention bonuses out there to ensure that our case managers and care coordinators continue to be active in the field so that our most vulnerable members get all of the support that they need all the way up until our very last day as a MCO doing active business in Kansas. And then going into next year, we'll have an operational team whose job it will be to ensure that claims run out, all appeals, all grievances, sort of all of those hanging things get resolved in a timely manner, and that nothing is left hanging or is left outstanding, so that when this committee thinks about us in 2019, you're going to miss me when I'm gone.
All right, committee, are there any further questions for the MCOs? All right, seeing none, thank you, Jane. All right, committee, the fun part of our process here, the spreadsheet. So I believe first up, we'll have Christine.
Hello again.
Yo, you're back.
That's right, I'm back again. Okay. So from a Medicaid perspective, we only have 2 questions that I'll provide answers to. I know we have someone from Public Health on their way over, so to answer theirs our first item was item number 3 on the KDHE spreadsheet. It was around the core set. Data that is now required. We did provide the PDFs for the 2024 core sets for both adult and children and quality back in February at the last meeting. I don't really have any additional updates right now. We are actually in the process of uploading our 2023 core sets, so we'll have more information on our data shortly, but we're just kind of in an awkward timing place around the core sets.
All right, committee, as we go through this, we'll make the decision to keep or not Representative Carpenter.
I think we ought to keep this on here at least for a period of time.
Okay.
Yep. And then the last one that was Medicaid.
I'm sorry, Christine, just a minute. Committee, if someone's asked for it to stay, just let me know if you object, and then we'll have to go into a vote. Otherwise, we're not voting. Go ahead.
All right. And then the other Medicaid item was number 6, and this was on the Transmed audit. So just kind of a recap of where we'd been, that one of the major contributors to some of the errors in Transmed was a system issue that had been identified, but then when the public health emergency came, we couldn't implement the change because we couldn't take anybody off the rolls. But as soon as the PHE ended last March, where we were able to start the renewal process, that system change did go in. Other things that we've been doing around the things that would have been contributable to staff errors is that we did create a computer-based training program that as of early 2024, over 400 of our eligibility staff have completed. And now new hires do that, obviously, as they come in. We've uploaded some documents to a SharePoint site that our eligibility workers use in an effort to kind of make the information easier accessible, so hopefully they don't have to go look through pages and pages. And then we've done an audit where we had our quality staff go in and look at over 500 cases and review those just to make sure the processing was accurate. Small amount of errors, but in the realm that you would consider these are humans processing these cases and not, due to what we saw in the audit. So again, I think things are progressing in the right direction. We will have our quality staff keep an eye in this area just to make sure we don't take any steps backwards.
Okay, unless there's objection, I think that we can remove this, and if it ever needs to be brought back, it can. Everyone agree?
Yep.
All right, go on.
All right, and that is the end of mine.
Okay, looks like next I have Andy Brown. And then when your other person shows up, because we're early.
Andy Brown, I'm the Deputy Secretary for Programs at KDADS. And I'm going to start with number 1, which is our Sedgwick County State Hospital update. You just heard from Scott on this topic. But in just a brief, again, we're looking at $26.5 million in order to build the 104 beds all at once, instead of using a phased approach.
Okay, just a minute here.
Yep.
Why am I, huh? Page 5.
Yeah, page 5, number 1.
There it is.
Yep.
Oh, okay. I hadn't figured out where the page numbers were at yet, so
Yeah.
that's on me.
That's okay.
And number 1, okay, thank you.
Yeah. Construction's on track to begin February 2025 with the new hospital scheduled to accept patients in 2027. And then,
I think we could remove it unless someone objects. Okay, move on.
all right. So for number 2, this is a need to develop models for intensive community support for the IDD population to avoid incarceration. As an update on that, all of our fiscal year 24 projects are making progress to identify IDD crisis stabilization efforts. There are 6 projects in total that include training components for community providers, including law enforcement, targeted case managers, and direct service providers or family members. Our 2024 grant period began on December 1st, and it'll conclude at the end of the state fiscal year. Work is being done for the start of fiscal year 25 with the current providers, adding more if the responses are received by the agency that determines an interest from additional providers. And Drew talked a little bit about that in his update as well.
Right. Representative Carpenter.
Madam Chair,
Representative Carpenter.
I would make a motion, we keep that, at least for the near future.
Yes, number 2. Okay, proceed.
All right, so for number 3, we've got Kansas should adopt language for assistive services that is similar to the Technology First States language. So this is around sort of smart home technology projects. Our proposal was approved by CMS, so KDADS is working to hire a contractor in order to oversee the distribution of RFAs to providers and individuals in order to purchase smart home technology devices.
Okay, we're going to keep that one. Is that it?
No, I got more. So,
Wrong way, that's why.
yeah. I wish it was that short.
Nothing wrong with me here.
But, so for number 4, this is around the KMIS system, or the Kansas Assessment Management Information System. For our update, KDAD's budgets include the 1 million SGF to analyze the KMIS system. Our agency is posting an RFP to procure a third-party vendor, and we're hoping to have that analysis completed this summer. The project will include a system analysis and recommendations for system upgrades and alternatives. And then we're also going to work with the AAAs on the data reporting opportunities within the current system.
We're going to keep that one.
All right, moving on to number 5. This is for the applied behavioral analysis, or ABA therapy. This is just an update. We do have policies that have been approved, and we are waiting on publication on the KMAP website, but we're continuing to work on that.
Okay, we're going to keep that one on there, and then once it shows up, we'll probably take it off, but for right now, we'll keep it.
Sounds good. For number 6, there's a need for access to respite care. This is, I believe, for the youth. We were looking for a TA manager or a program manager. So we're now hiring that TA program manager as the legislation was approved for funding for the position. So next steps on that is we're still working on getting that position up and running. So we'll continue to provide updates.
We'll keep it.
For number 7, this was about what services are reimbursable by Medicaid or private insurance for a patient that's been screened and waiting for a state hospital admission. Last time we recommended convening a work group. We had a meeting. KDHE clarified that for the Medicaid member, coverage of inpatient hospital days are determined by medical necessity, and so there's no differential in the criteria or the payment if a member is waiting for transfer to state hospital versus if they were inpatient for another medical necessity reason. The ER visits would be covered by the overall Medicaid policy, and so there's no differentiators due to need to transfer a state hospital. So the discussion with that was closed.
Okay, we're going to keep it.
Okay. All right, and then on number 9, this is around the statutory or policy changes that are needed to reduce wait times in order to address competency evaluation or treatment. So our update there is that the Governor's Advisory Panel for the South Central Regional Psychiatric Hospital is planning to study competency statutes and processes as part of the program design for the new hospital, as well as how it will fit with the existing programs and law enforcement needs. So additionally, the Judicial Council will be studying this issue of competency in the near future as well.
We're going to keep it.
Number 10, this is around the root cause of antipsychotic drug use. We provided information about this in our agency update on the PowerPoint. So we continue to just refer back to that for now, but we understand the need to track the item.
Okay, we're keeping it.
And then I jumped to number 12. And this is around what KDADS is doing to lower the number of Kansans on the BI waiver who do not receive therapy services to under 100. Currently, we have 58 individuals that are showing not having therapy services. 39 of those are new to the waiver within the last 5 months and are starting therapy soon. We also have a BI program manager that's following up on others that are in that group. And we've started a process to close out 2 cases where the individual is not wanting to receive those services any longer.
Okay, I think we're going to keep it. I guess my question is, all right, so you've had individuals that they've chosen not to proceed with therapy, correct? 2 of them. And then you've got 39 new individuals. How long do we normally wait, or do you have an idea before we're able to get them therapy?
I'm not sure. I can circle back.
Yeah, I think it'd be good for us to have that information because we want to make sure that we're dealing with that timely. And I don't recall off the top of my head, you know, is there a window to get this started so that we can proceed to get positive results? Representative Carpenter.
Thank you, Madam Chair. So then there's 58 showing not having therapy services. So what kind of services would they be having under the brain injury if not therapy?
They might be getting some kind of care coordination service or, Michelle, you got other thoughts on that? Yeah.
Yeah, there are a number of services on the BI waiver, like personal care attendant, home-delivered meals, overnight supports. So there's other services they can be getting.
Okay, so they're just not getting any they're just not getting therapy,
Correct,
but they're getting other services?
correct.
Okay, very good, thank you.
So it might be helpful as we report further, because we're going to go ahead and keep this on there, so if we can kind of get a breakdown of that.
Okay.
You know, again, it's, you know, one of the things we're trying to get processed through this is so that we have a record so that legislators can learn these instead of it just being a handful of us up here doing it. So, yeah, thank you.
Okay, so then moving on to 13. This is around the waiting list for the PD waiver. Again, it's about the causes for the increase of the wait list and what the population is being impacted. So our update for this quarter is that we're beginning to send out our offer letters for the 500 additional slots that were provided by the governor and the legislature through the budget process. These offer letters are going out in batches every 2 weeks over 90 days. So we're hoping that by the end of the first quarter, we'll have extended all of those offer letters and have those folks available to enroll in the waiver.
We'll just keep it on there to monitor it.
Okay, and then number 14 is basically the same question with the IDD waiting list. And again, we're sending out those offer letters through that system. We're working with a contractor, public consulting group, or PCG, to work through the process of developing the community support waiver, which we think will also assist in getting services to folks that are on that waiting list.
All right, we're going to keep it, and Representative Carpenter has a comment or question.
So I received correspondence, and I've forgotten their name, so that there's significant, it was one of their children or whatever had received a letter, and they'd been on the wait list for 10 years. And they were so excited that they finally received services after 10 years on that wait list. So that's what we do sometimes.
Yeah, thank you for your help in that.
15?
Yep, so for 15, this is about the workforce that's needed to accommodate the additional folks coming through. We're currently working on announcing our awardee for that direct support waiver career ladder study. The Federal Administration for the Community Living did provide Kansas with a peer learning collaborative grant, which will allow us to get technical assistance along with several other states that'll help us build a career ladder. So we're currently working towards that goal of establishing a career ladder.
We'll keep it.
So for 16, this is asking what is the benefit to the individual to have case management services on the waivers and the cost to add it. And their update for this quarter is that we're currently working with the MCOs. I think our first meeting is July 2nd. We'll be trying to develop a community service coordination program with all 3 of the MCOs. And our goal is to sort of level set what the expectation for the MCOs is at that meeting so that they can begin meeting with stakeholders and working to push that out.
Okay.
And then number 17 is to invest in the future home recruitment and retention by increasing funding on behavioral health needs to support SED youth. And then it's like it gets into specifics about workforce, et cetera. So currently in our agency update slide deck, we do provide information about the number of beds and whether those are staffed or unstaffed due to workforce issues. In addition to that, we're in the process of evaluating proposals for our 2025 Children's Crisis Respite Centers. And we're looking at sending $2.1 million out to providers for that purpose. We currently have 5 proposals from different providers that are wanting to expand or create new services, up from 3 last year, which is encouraging for us. We want those providers to be able to deploy those services because they're pretty badly needed around the state. We also are currently working with Ember Hope to continue their pilot of aftercare to follow up with their PRTF and in the community with budget proviso funding from 2025. So we're looking forward to expanding that pilot to additional PRTFs around the state. There are 3 sites that have been selected for fiscal year 25, the KVC, Canberra, and Kansas City, TLC, and the Florence Criterion.
Keep it, and I believe Representative Carpenter's got a question.
So Andy, on the sheet, I think it was on there, it was on the waivers, HCBS, there was 2,300 folks on the SED waiver, and there was no wait list. So how does that, does it have a wait list? Does it calculate just like we would with the PD and the ID? So there's nobody on the wait list for SED?
Yeah, that's correct. We don't have any.
Really? Are you kidding me?
No, we don't have a wait list for the SED waiver.
Well, but how many people do we have waiting for services? I guess that's a different, okay.
Yeah.
Somatics.
Yeah.
You know what I'm getting at?
Okay, so you're wanting to know how many people are like waiting to get into a PRTF.
Right, that's a wait
Yep.
list.
So we do have a wait list for the PRTF admissions. And again, that's something that we track and report on that agency update slide deck. So those numbers are in your slide deck under the Behavioral Health Commission, and and they're here now. So
friend.
yeah, it's on page 19 under PRTFs. So the current MCO wait list for as of June 13th was 146 kids.
Okay.
Yep.
I mean, to me, that's a wait list, but
Yep.
you can call it whatever you want to.
Yeah.
Yeah, and I should have asked
So-
Drew this, so I apologize for
It's
asking
okay.
you, Drew, and I apologize for circumventing the process and not asking you to.
Yep.
So,
Which number did you just say?
It's page 19 of the update slide deck. Yeah. Yeah.
all right, so,
All right,
So-
but so yeah, just as a point of clarity on that, right? So this is a wait list to get for SED youth to get into a residential treatment program. It's not a wait list for them to get community-based services from the CCBHCs.
okay, very good.
Yep.
Thank you.
I'm talking about.
Madam Chair, members of the committee, Representative Carpenter, Commissioner Drew Adkins, Behavioral Health Services. Important distinction that Andy just made about the SED services versus the PRTF and the residential the temporary residential placement. We also do in the past month have a new PRTF in Fort Scott. If you're familiar with the area, they had the old Mercy Hospital there. They have started accepting kiddos there, so we do hope that as we get them online, I believe that their census will be, and their capacity will be somewhere around 50 beds. We do hope that wait list does come down. And so we haven't had a new PRTF in Kansas for quite some time, and so we're excited about that.
Very good, thank you.
All right, who's up next? What else you got? Are you done?
I think I'm done. I think that was my last
We're
one.
done with you?
Yep.
Oh, wait a minute, I think someone's got a question. Oh, yeah, I'll leave it to another one leaving. Go ahead, Representative Concanon.
Well, this is while we're on this topic. It's not exactly this, on the PRTFs. Seems like once upon a time, we talked about the number of kids that were placed out of state at PRTFs to help. I just was at a national meeting, and we were discussing some of this. I'm interested at some point, I know you're not going to have this now, but how many foster kids are placed out of state, not Missouri? Because I understand that sometimes we're just crossing the state line, but are we sending kids to other states? And I'm just curious about that at some time when you have a chance.
Yeah, we can certainly look at that and bring back some numbers, but I would expect that it's going to be a pretty low number.
So do you want that as a spreadsheet item? Okay. All right, because Rita and staff are really good about getting stuff back to us. So now we're done with you?
I think so.
So you and Drew are over for the day? All
so,
right.
yeah.
Till we meet again for the next meeting. All right, who's up now? Just tell us what page and what number we're looking at. We can get there.
Working off of a digital copy here, so excuse me. I'm Derek Flerlug. I'm the director for the Bureau of Family Health at KDHE. In my digital copy, I'm looking at item number 5, I believe. These are related to childcare.
All right.
Yep, page 1. So in relation to how do we have more childcare facilities available, or how do we increase the number of facilities or openings, and what reasons are preventing Kansans from having more childcare facilities or openings currently? So I did want to bring up, we are currently and have been doing an exit survey of those providers that submit for closure to KDHE. And the exit surveys themselves are not required, but we kindly ask if they would complete And the feedback that they can give us varies. It includes everything from, did you close due to reasons for regulatory burden, financial burden, personal choice, other, and so on and so forth. And so out of the 42 submitted surveys that we've received since August of 23, we had 7 providers that indicated that the challenges were related to rules and regulations, and that breaks down to about 17%, pretty limited sample size there. And then of those 7 providers, 3 of them indicated issues directly with our surveying staff. So when we receive info like that, we always follow up and circle back, either meet with that surveying staff, licensing specialists, or what we call them now. If it's KDHE staff, we'll meet with them. If it's local health department contracted staff, we'll set up a meeting with them. And we can do everything from conversation with them to actually looking into the survey itself to see how it was conducted, and could include also investigating with the provider as well to make sure that their concerns are addressed. The other 4 indicated issues with some of the federal requirements like fingerprinting or with some parental relationships, or actually we hear I shouldn't say quite a bit, but we do hear a little bit about competition with some larger organizational providers that have kind of spread their arms into some of our more rural communities. The remaining 35 providers, about 83%, indicated issues with financial and staffing sustainability, a lack of benefits, retirement, took other jobs, or personal issues that were unrelated to really anything childcare. From our licensing perspective, I know the last time I was here, I talked a little bit about our regulatory review. I'm happy to present a report to you all this afternoon that we've completed that regulatory overhaul, and we're just awaiting to be published in the Kansas Register by the Secretary of State's office. So we've gone through all the fun hoops and hurdles on that process, and gotten really good feedback from our providers and made really good partnerships as well. It does include the consolidation of 2 separate home license types down to 1, so increases that provider flexibility. We do increase our max capacity up to 12 kids, which is based on state fire code. And then we've changed some of the age groupings to reflect 0 to 12 months, 12 months to 5, and then children 5 through 10. And that lowers that age of the middle group to allow for graduation of children into older age groups sooner, which by default adds additional slots for our youngest infants. We've also tried to streamline staff qualifications, and we've made a concerted effort to account for experience in early childhood settings, even when they don't directly tie into childcare specifically. So again, trying to respect the workforce and lower barriers for entry into the field. The barriers for a provider in Kansas, we believe are pretty well established. Child Care Aware has their 2023 Kansas Supply Demand Report, and they cite staffing shortages, low wages, lack of benefits, which includes health insurance, retirement, paid time off, et cetera. It's also supported by what we hear from our providers out in the field as well. We have engaged with our local coalitions and organizations and providers to assist on some of these challenges. We've worked to create strong partnerships at that local levels, and we've had some really good open conversations with communities all across the state, whether it's Greeley County, way out in western, or Sedgwick, Johnson, Shawnee, everywhere in between, really. I think I've mentioned before, the concern with some of the pandemic relief funding coming to an end. That did provide some sustainability funds to providers directly, and we do hear occasionally that with those funds unavailable, some of the closures are related to that. They're just not getting the sustainability funds to keep them open. So we are a little bit concerned about seeing an increase in struggles or closures related to that. Luckily, we did receive $1.3 million via Children's Initiative funds for state fiscal year, this next state fiscal year, to administer health and safety grants. So these are funds that we're actually able to grant out to providers who are having issues with regulatory compliance to assist them into coming into compliance. This could look like assisting for purchasing of a new fence, playground materials, plumbing, et cetera. We've also have active small center pilots that are being evaluated for a possible new licensure type. So it's a mixed age group in sort of a center setting, which you don't typically see. Typically, centers are defined by different age groups in classrooms or kind of their own units, and this is that mixed age group setting. we've gotten really good feedback on that, and we currently have, I believe, 3 underway right now. Our first one was out of Ashland, Kansas, and that provider was actually her idea, so we were really happy to work with her to make that a possibility. We're also working to promote non-traditional styles of care, intergenerational in our long-term care facilities. That's a partnership with KDADS. And then after-hour care for those that work beyond the normal 9 to 5 and other non-traditional styles of care. And then I think really engaging in that systems level thinking. So we're trying to transform the way childcare is offered and supported in Kansas. And then, always looking for additional legislative investment too. So we appreciate opportunities like this to continue to talk about the importance of childcare. I think that's all I have on that item. If there are questions?
Unless someone thinks we should keep it, I think we can mark it off our list. Oh, Representative Reese, I'm sorry.
Thank you, Madam Chair. I had a constituent who was trying to open up a child care center in my district, and they received a letter, and I could probably find it and show it to you afterwards. But it was a form letter, and it just said that they would, something about not being able to license them, something like that. But no explanation as to why, what were the reasons. And it wasn't until they really got into it, and they had me look into it, and before I could look into it, they did receive a notice. But it's an interesting letter that is sent to prospective providers that gives no explanation at all as to why they were being declined.
Yeah, I'd be interested in seeing that, Representative. Okay. I believe in your district we have an agreement with the local health department where that letter may have been from them, but that's still an opportunity for us to improve customer service. Because those sorts of notices without explanation, not just why, but also how do we get you to become one? What's the solution?
Yeah,
like it's
exactly.
Not really acceptable to me to communicate with
Okay.
with
I'll
them.
see if I
like
can
that.
dig it up.
Yeah, yeah, absolutely.
Thank you, Madam Chair.
All right, are you still okay with this taking that off? Yes. All right. What else do you have?
I have another one here, additional info on home providers, though it doesn't have a number next to it. You all see that there? It looks like provide details on why home providers are closing and how many and what type of exceptions are made to daycare providers.
Well, it doesn't have a number, honey. Go to page.
For me, it's right below, but that could just be my agency copy.
Page 2.
Second page, right above number 6, is what I'm told.
This one right here, Barbie. Huh? Oh, it's part of 5.
Okay. And I was going to say, I think some of my feedback might at least tie into that.
Okay, it's gone.
That's all I needed to hear.
Unless you want to keep talking to us.
I mean, I don't like the sound of my own voice that much, so thank you, Madam Chair.
Well, we appreciate you being here and running back early for us, so thank you very much. All right, who's up next, ladies? That's it?
Right, from the other providers, the written on page.
Right.
On page 12, and your top.
Page 12? Oh, from the judicial?
Oh, yeah, she sent out a letter here.
Yes.
They have a letter for item 12, and then DCF answered question 2 first. And this will be on page 3.
I would say on page 12, item 1, that we continue monitoring that and see how it progresses. And, I appreciate the judicial folks, providing us a written update on it. Agreed?
Yep. Yeah, we'll keep that.
And then, okay, it's DCF. Well, it's number 2. It's a written only, huh? Okay. Did we keep it? On the KDAD's one? KDAD side? So do we need it in both places?
You should keep it on KDAD's.
Oh, okay, because it's DCF. So maybe we can make a note, because we kept it on the KDAD's one. Let's just make a note that it's KDAD/DCF, because that's a little bit, then we don't have it on here twice, and then you can just remove this one. Is that good? That one's gone. What else we got?
Did you remove it?
Huh? You just removed it, because you're going to put DCF on the previous one. You're not laughing at me, are you, Drew? Yeah, you are. No, you're laughing with me. I know Scott is.
And then you have number 3 on page 3.
Page 13, item number 3, it's a DCF. Yes. Yeah, it's smaller font. Yeah. Hey, this is still a whole lot better than what we've had to deal with in the past, so I am very happy with it. Representing KanCare.
Thank you, Madam Chair. What were you wanting to do with this, number 3? Keep it? Okay.
Unless you don't think we need it.
We're discussing this at Child Welfare Oversight
Okay,
as well.
let's keep it.
So,
We're talking about social security, therapeutic care, and foster homes, too.
okay.
Yeah, so we'll keep it. Is that it? So, by my sheet, except for Representing Carpenter.
Yes, Madam Chair, I would like to add an item to our list. Probably not very many of us are familiar with it. There was a deal called Unite Us that got a $7.7 million Sparks contract to implement a closed-loop referral system, and that would be where you would apply for Medicaid, and you would also be put in contact with food stamps and any other services that you need. So this has been going on for a year or so. We haven't heard a single thing about that. So I would ask that DCF and KDADS provide us with regular updates regarding the implementation of the closed-loop referral system by a third-party vendor and its requirements to be left on a spreadsheet until statewide implementation.
Okay, would you be okay with sending that to staff, and then they can add that to our spreadsheet?
I would.
Committee's okay with that? So
Thank you.
make sure that Will does. If he doesn't, you call me. I'll call his wife.
That's cold, that's cold.
Yeah, I'm pretty cold. Representing Berquist.
Whenever the stated business is done, I just have 1 minute. I need to say something to you guys.
Representing Berquist, speak.
All right. I've been on Health and Human Services for all 7 sessions that I've been here. And I've been in this committee, and I've never been around so many passionate people that are passionate within their own right for the responsibility of the people's money and about people's lives, individuals and 3 million people all at the same time. That's a pretty big responsibility, but you guys, the people on this committee, including Senator Petty that took out of here a little early, and another numbers of dozens that I've worked with, this committee either brings people that have that passion or creates them. I don't know what it does, but it's amazing. This committee on Health and Human Services, it brings out the purpose and focus of passion, not just emotion. And I just want to thank you for the privilege of being a part of this committee and a part of this cause. Thank you.
Well, and those are very kind comments, especially since Representative Ballard's been on social services budget since 1997.
Well, wait a minute, she's almost been that long.
When she was in kindergarten.
Okay, so we got things wrapped up early. I like seeing those kind of things.
May I make just one comment myself?
Representative Ballard.
I appreciate this sheet because in 1996, Brenda Lamware.
No, 97.
97.
97.
Thank you. Say, acronyms, let us know what they are.
We asked for a dictionary.
And a dictionary. And, you know, when I look at these each time, I think, oh, because you know what you're talking about, but sometimes you don't know what that acronym really stands for. So whoever made it on this sheet, thank you so much.
And the one you and I were looking for.
I'll tell you.
Representative Carpenter now.
I'll tell you a funny story on that first year of chairing social services budget, seeing all those acronyms, I said, we will not be using acronyms anymore. Boy, was I wrong.
Well, and the thing is they just continue to grow because you get new ones, and then if you haven't dealt with one for a while, you go, what's that?
What's that one?
I don't know.
I
So then we have to ask staff and everything, so.
Now, I have to say,
I don't know.
the P4P was new to, that's a new one. I hadn't been noticing that one.
Representative Reese.
Thank you, Madam Chair. I just wanted to thank legislative staff for putting this together. I know this has got to be the biggest pain to do, but you can't imagine. I mean, this is so invaluable to us to be able to have it in print like this. I just wanted to thank you for putting it together, and I would wish that other committees would be able to do it too. Thank you, Madam Chair.
Well, I think it's really made it nice. It streamlines our process. It allows us not to forget things that need to be followed up on and addressed. And I think it's provided the agencies valuable information as well, so.
Do we have another meeting?
We do not have another meeting scheduled as yet. When LCC met, they authorized this meeting. So in the month of July when they meet, which I think is second week in July, then they'll authorize the other days, and we've asked for 6 days.
Okay.
Now, do we use all 6 days? It doesn't mean that we do. It just depends what comes before us. Okay?
All right.
Anything else? Staff. Oh, yes. We would like to approve, okay, approval of the last minutes by Representative Carpenter, seconded by
I'll do it.
Representative Ballard. All those in discussion, comments, none? All those in favor signify by saying aye.
Aye.
Opposed, no. The ayes appear to have it. Motion carries. Guess what? We're adjourned.